structures. Can we go for the next session in the meantime till the volunteer is ready?
If
Okay. Okay.
Hello. Yeah. Good morning, everyone. So the topic given to me is knee. Structures here are quite superficial, so we'll be using a linear probe. Positioning is very, very important. So we have just given a bolster or a pillow. You can give it and hold it at an angle of about 30 degrees.
Can you please adjust the camera on the volunteer,
Yeah.
on the knee?
Camera adjustment there.
Yeah, thanks.
So we have given about 30 degrees of flexion, and we are actually going to divide the knee into anterior, medial, lateral and posterior. Anteriorly, we will start with the first landmark which you are actually going to palpate is your patella. Patella is very important. Many of the times what happens is, so to the left is actually cephalad. So just palpate for your patella, and you can place the probe half on the patella, half outside. So you can actually see this is the patella should be seen. Most of the times if we are actually placing it here, we don't know at what plane we are. So it's always better to place your probe half on the patella, half outside. So once that is done, you can build the structures around. You can see that. So this is the patella, this is the quadriceps tendon, this is suprapatellar fat pad. You see with thin people and with normal individuals, the recess is very thin. So interventional wise, it becomes a little challenging for us. This is a long axis view which we are actually seeing of the quadriceps and the recess as well. And down what you see, there is another hypoechoic area. This is your femur. So whenever you are doing any scanning, it's always very important for us to appreciate the proper white hyperechoic lines, the cortical surface. Mostly the bone will, you will have your shadowing, you're not going to see anything other than the cortical surface. So here we are able to appreciate only a thin recess. So in that case, giving a knee joint injection in this case, for me it's okay, because if I get this, I go for my fluoroscopy. But once you don't have it, it's always better to do a dynamic maneuver where you're placing the probe and holding it. बहुत slowly घुटना मोड़ो. So you can see that. हाँ. So what I do, थोड़ा नीचे रखो, नीचे छोड़ो, ढीला छोड़ो. हाँ. So you can see that the recess is moving. Sometimes it will be even difficult to appreciate the recess in itself. In this case, you can, at that place where you are able to appreciate more, you can ask your assistant to hold back the knee. And you can take it in short axis as well. So this is the short axis view of your quadriceps tendon. That full is the quadriceps tendon. Slight small recess which you can appreciate right below that. With a little bit of pressure, you can open that space up also. Depth. So the needling in this case is going to be from lateral to medial. So, and one more thing is, here he's a thin individual, so we are getting it at about 1 to 1.2 centimeters. So for your linear probe, it's always better to have your needle parallel to your linear probe. You will be able to visualize the needle beautifully. So once the primary thing is ergonomics, I would want my machine to be right in front of me, and the needling becomes much easier in that case. So the needle, I believe, so you can see that. So it has to be parallel, so about 1 centimeter away. So we don't go very close and at an angle. Here you are not going to see the needle properly. So we'll go a little deep. If it is, most of the times it will be at 2 or 3 centimeters. So in that case, you go 2 centimeters away from your probe, and you're going to enter the needle. So once you enter, you're going to come parallelly in this direction, and that's actually the space. So quadriceps tendon is 4 muscles form the tendon. It's a 3-layered one. So your patella basically is a sesamoid bone. So when we are going to appreciate here, the superficial most layer is little blackish it looks, that's the rectus. Second layer is formed by 2 muscles, and third layer is by a single muscle again. So you can actually, this is the suprapatellar area which I'm actually showing you. As I translate my probe above, you can see that black line, and this is also the area prepatellar, where you are also going to, if I have not seen, for many years I have not seen any prepatellar bursa as such. So, but if you are going to find a prepatellar bursa, this is going to be the area. In that case, the pressure which you are going to apply is very important. You need a lot of jelly, and the pressure should be as minimal. See, I'm just holding it there. So, and again, you just follow the rectus femoris, it becomes a part of your patellar tendon. If you can see there, the black color top superficial layer, it becomes, and this is the patella, and as I go below, that's your tibial tuberosity. So this is your patellar tendon, this full tendon. So the pathologies which you are going to appreciate here, proximally, you are going to see your jumper's knee. If there is any patellar, tendon tear, you're going to appreciate it somewhere here. And patellar tendon is not a thin structure. See, when I'm doing a long axis view, I'm only seeing at one cut section. So if I take a short axis, you are actually going to see that the patellar tendon is quite a large structure. So you need to assess it and translate your probe both medial and lateral, and also in short and long axis. So here again, patellar tendon you can appreciate, and as I go below, that's the attachment. 2 very important things which are to be appreciated at this level. One is deep bursa, this is the infrapatellar area, and superficial bursa. Superficial bursa. And also there is something called as Osgood-Schatter's disease. Young individuals coming to you, abnormal, this cortical surface will be abnormal. This is more of a conservative, it's nothing to do with our interventions as such. So one more thing which even yesterday I had a patient, young individual had a trauma, and this Hoffa's fat pad doesn't look like how it is. If you can see here, this is the Hoffa's fat pad, and the Hoffa's fat pad, it looks more blackish and collection of fluid, it looks ugly. So you have to suspect for Hoffa's fat pad impingement or disease. Certain things you can take it with before your interventions, but it's very important to judge and take a call that you have to send it for MRI. Modality based, you need to diagnose and then you go ahead, because the Hoffa's fat pad didn't look, there is 2 things. One, you appreciate between normal and abnormal. If you feel something is abnormal, you need to know that much. And your modalities like MRI is actually going to support you. So next, coming down to the medial side, I'm just going to take external rotation of the hip, and my target will be here. So the probe position which is there, you're not going to keep it tilt. So this is a common mistake most of them do. Your probe position is going to be in this way. So you can appreciate the bone well and the muscle on the top. So vastus. As I'm coming down, you see a small dot there actually. That's your genicular. That's your genicular. And I'm just going to translate the probe more down. Now I come to the condyle. So this is the femoral condyle, and as I come down, slowly the joint space is opening up. So what we appreciate, one is a femoral condyle, then you see the tibia, and you also see a meniscus in the middle. So this triangular structure, again not a very diagnostic, because most of the part of the meniscus is not appreciated with ultrasound, and I'm just translating my probe slightly more posterior, and I see another fibrillar structure opening up. This is your MCL. So MCL is basically made up of, it's made up of two layers. One is a deep layer, one is a superficial layer. Deeper layer is very, very, very closely associated with your meniscus. That's the reason why we call it as meniscofemoral and meniscotibial. This is the deeper layer. Superficial layer, it jumps up. You can see this is the superficial most layer that jumps and goes below, and I'm going to demonstrate that. It's going to go more inferiorly. So that is your, so one more thing what I do usually is, so you can do a dynamic maneuver also. See, I'm doing a dynamic maneuver for the assessment. So loose chodo, theek hai. So I'm just tracking the superficial layer of the MCL, and there, and you can also see a vessel there. So that's your genicular area. There. I'm just going to come down, and that's your MCL coming and attaching. Your MCL is attaching there. So another important structure to be appreciated above the MCL is basically your pes anserine. So there are three muscles which actually come and attach here, your sartorius, gracilis and semitendinosus. And they are not oriented straight. So they are not oriented this way. So what you see above there, you can see two, right above your MCL. Those dots are basically your pes. So it's like a goose feet. So you just can note that my probe position is slightly more tilted. See that? And this is also what I've seen. People say it's very rare. Agreed. The bursa cannot be appreciated so well. But post our procedures, these are the common areas. See, I've just rotated and I'm going more posteriorly. So sartorius is one area which comes a little front and it attaches. So this basically is your pes. Usually, once you have given an intra-articular injection, most of the times people do have pain here, pes. So this has to be treated. I don't give any steroid, but I do a prolotherapy, about 5% dextrose. That's the maximum prolotherapy I actually use, and it has worked for me. So coming to your geniculars, this is your genicular artery. It's a thin individual. We can appreciate a little. This is a short axis of the artery. I'm just going to rotate and see if I can actually open it up. Yeah. You can see a small thin pulsation. That's your genicular vessel. Nerves cannot be appreciated. Genicular arteries can be. And once you have located, this will be the position from anterior to posterior or your radiofrequency. Don't go very, anterior. We want to be somewhere here, posterior. This is about the medial aspect. Another structure sometimes cannot be appreciated so well is your infrapatellar branch. You can locate it if you are not able to even, I believe so, that is the one. Is a very thin individual. Usually it will be, when there is more subcutaneous fat, you will be able to appreciate it at this level. So that can be a cause if the patient has any burning sensation in this area. So infrapatellar branch of saphenous nerve. So going to the lateral side, thoda udhar ghum jawa. So what I do in lateral side is, you first palpate for your IT band. You palpate for your IT band, place your probe. So what we are actually seeing is my marker is there, that's the IT band. And you can just track that slowly. Below is your femoral condyle. This is your femoral condyle. That's your vastus lateralis. So I'm just going to come down, keep tracking the IT. I'm just going to come. It jumps. It doesn't attach to your femoral condyle. It jumps. And this is also an area where there can be friction. So it jumps. You can see that. I always tell this is like a snake hood. It comes and it attaches to the Curtis tubercle there. So the structures which you're actually going to appreciate here are your lateral meniscus, your femoral condyle, your IT band. If there is any friction, you can actually appreciate. If I go little more posterior, I can see the popliteus tendon there in the groove. And this is like a snake. Can you appreciate the IT band coming and attaching? It's like a snake hood. So that's about your lateral side. And another important thing is palpate, surface anatomy. So this is IT band, whereas LCL is more towards your fibular head. So first palpate for your fibular head and place your probe there, and that's LCL when in this position is not taut. So here you can actually appreciate this is the LCL. There can be a little bit, maybe on the top you see that is also a biceps femoris, which is because they are very, very closely attaching to each other, and that's your LCL. LCL is not taut in this area, so it comes and it attaches to the femur. So your probe position is important. Again, the lateral meniscus you can appreciate here. You can also appreciate here you can have a cyst. Sometimes this is actually a tibiofemoral joint, proximal one. I think lateral side we are done. Posterior side is left, so thoda ulta let jaye. On posterior side, the most important structures is to appreciate the femoral condyles. Always go with the bones. Once you have so that's the lateral condyle. This is the medial one. Here you can actually appreciate two muscles, gastrocnemius heads, lateral and medial, and you can see the nerve there. So and the artery. So the nerve probably we are seeing, I believe so, that the tibial nerve. We can actually take it more proximal. Yeah. So here you can see the split. Here you can see we were seeing a common nerve. This is tibial, that is common peroneal. You can track the common peroneal nerve. I'm just tracking it there. So that is going to go there, and you can appreciate it. And that is going to go there. And it is very, very closely associated with your fibular head. So it's right posterior. So whenever I'm doing any interventions for my LCL, there are two things. One is assisted, one is guided. So most of the times when I'm actually doing prolotherapy, many a times these are superficial structures. You can't just put a needle with guidance. Assistance, you should know that my nerve is here. So I put my finger there and I go more anterior. So these are the things which you can appreciate on the posterior side. Yeah, important thing is medially, this is that's your semimembranosus, that's your gastrocnemius, and this is also the area for your Baker cyst. So as you go up, the thing which you can see is semimembranosus, semitendinosus. So just a small hint that once you are going to go more proximal, semitendinosus is going to become the muscle and enlarge. You can appreciate it. See this? It's growing here. And semimembranosus is going to become small and going attached together in your as a hamstring attachment. So this is called a cake and a cherry appearance. Cake and a cherry appearance. So as you come down, you see the semimembranosus is becoming smaller, and that's the area where you're going to appreciate your semimembranosus, medial gastrocnemius bursa. Yeah, thank you.
Now we can take the questions from the audience. Later. Then. Who's the next? Huh?
Questions we can take in the tea time or lunch time. We can go ahead with the next speaker.
Thank you, Dr. Ahmad sir, for fantastic session on knee USG. Our next demonstration by Dr. Harshita Surangi. Ma'am, she'll take us through the scanning of the elbow and wrist. She is known for her expertise knowledge on musculoskeletal imaging.
You can see, if I can just reduce the pressure, you can see the artery and the nerve. The artery is the median, the brachial artery and the median nerve just medial to it. And further on its top, this area, this tendon which you can see is nothing but the biceps tendon, which is the most superficial tendon. At times it becomes very difficult to see it also, but any hypoechogenicity which is seen above the brachialis is the biceps tendon, and you can just do a little anisotropy. I need to remove this. So any anisotropy, which is any hypoechogenicity seen just above it, is the biceps tendon. And you can just do rocking of the probe, and you can see it becoming echogenic and hypoechoic, right? That's the biceps tendon. A lot has been described about the biceps tendon pathologies, but I am yet to see a distal biceps tendon bursitis or biceptoradial bursitis. But a lot has been talked about, so we need to speak about it also. So this biceps tendon, it has an angulation. It dips down, that is why it is very difficult to visualize it. So what we do is, if you just see, keep seeing this biceps tendon here. See it going down, down. See it dipping further down, down, right? And if I just tilt the distal end of the probe and here. Can you see this biceps tendon in the long axis? See the position of the probe. What you need to do is, I'll just repeat it again. Just remove it again. So here you see the biceps tendon. This is the biceps tendon. First see it in the horizontal view. Then you just move your probe a little more medially and keep tilting it or pushing the medial end of the probe into the skin. And as you push it further down, you are still pushing it further down, and you tilt it here. And here you see the biceps tendon. Can you see this biceps tendon going like this and getting attached? So if at all there is a biceptoradial bursa, if at all there is a bursitis, it will be fluid around this area. This is only for diagnostic purpose. But if you have to do an intervention, then this is the position, the cobra head position, right? In this cobra head, so this is the position. Can you see this position on the screen? The hand is in the form of the cobra head. And can you just focus the screen? And the bone which you see here, this prominent bone close to the skin is the ulna, and there is this deeper placed bone. There. That's the ulna, that's the radius. And if at this place I see the biceps tendon, this is the biceps tendon. Okay? Hold on. There's the biceps. This one. There's the biceps tendon, which can, if you have to do the dry needling, or have to put injection, or you have to put in steroid there, you need to see it from this side and do the needful. Okay. Then coming over to more common pathologies which we encounter on day-to-day lives. The common extensor tendinosis. That's one of the most commonly encountered pathology for which the patients come to us. So, okay. So coming back here, you see, that's a bony landmark again. And for this, after seeing this, everything, okay, the other structures which you can see here is, I want the depth to be reduced. Superficial, no. Yes. So here, what you all can see is this is the brachialis muscle, as I told you. On the lateral side is the brachioradialis. Between the brachioradialis and the brachialis, you can see some hypoechogenicities here, right? This is nothing but the radial nerve. The radial nerve dividing into the superficial and the deep branch. So, see, if I go up, see, this is the radial nerve right here. And if I keep tracing it down, delete. See it dividing into two branches. This is how we trace the divides into two branches, the superficial and the deep branch. See the deep branch going, dipping here, here, and what you see deep here is the supinator muscle. The superficial head of the supinator muscle, and that's the fibrous leading edge of the supinator. So it dips under the supinator, superficial head of supinator. which is the entry point of the tunnel, radial tunnel. The deep branch of the supinator can get entrapped at the entry, in the tunnel, and at the exit. So here what you can see is see this nerve traveling in the, it goes like this. And that's the end of the tunnel, and you can see it exiting. I'm going up and down. Now, for the common extensor tendon, I keep the hand of the patient on his abdomen, and then maybe some jelly on the lateral side. So, for this, the common extensor tendon is formed by the muscle, the common extensor group of muscles, which does not comprise the extensor carpi radialis longus tendon. The extensor carpi radialis tendon arises from the lower end of the humerus. So, the most common pathology which occurs in common extensor tendinosis is the tendon of extensor carpi radialis brevis. When I started my MSK interventions journey, it was patient had typical complaints of common extensor tendinosis, but on ultrasound I was not able to visualize the pathology. And radiologically it was not visible, but the patient had complaints. So, after a lot of struggle and understanding, I came to the conclusion that we are actually not examining, I was not examining the common extensor tendon, not the common extensor tendon, the extensor carpi radialis brevis tendon. So, how do we do it? So, we start from the most anterior end, and when I see this long muscle right here, this is the muscle of extensor carpi radialis longus. And then when I start moving posteriorly, if you see the probe, it was here anterior, initially most anterior, and then I move it posteriorly. And when I start moving it posteriorly, I reduce the depth. Or yes. So now here you can see there's the muscle of extensor carpi radialis longus. There's the muscle of extensor carpi radialis longus. There's the supinator here, and as I move further, I see the first muscle arising. This muscle is the extensor carpi radialis brevis. And at this level you can see this is the extensor carpi radialis brevis. And when I move my probe further posteriorly, see my probe, it started from here, I'm just rotating it. And as I rotate it, now this tendon with over which the pointer is there, there's the tendon of extensor digitorium. And if I move my probe further posteriorly, this is the tendon of extensor carpi ulnaris, this small little tendon, right? This tendon. This is the extensor carpi ulnaris tendon. And now tracing the ligaments. The ligament, the lateral ulnar collateral ligament lies under the extensor carpi ulnaris tendon. Okay. So here you can see my probe position is towards the little finger, and at the when I probe and at this place when I'm seeing the extensor carpi ulnaris, this thin little tendon. Underneath is the posterior band of the radial collateral ligament or the ulnar collateral ligament, lateral ulnar collateral ligament. To see the anterior band, you need to be in the center of the tendon, and the lower 1/3 of the tendon, this area, this tendon, this part of the tendon, this part of the ligament, this is the anterior band. So that's the anterior band. When I come posteriorly, then that's the posterior band. So these two ligaments are very important because many a times we see the ligament is torn or there is a ligament sprain, which we often mistake with the lateral epicondylitis. Many a times when we do an intervention, we put in PRP or we put in mostly the PRP. Steroid is not to be put in the tendon at any time. We see that there is a tear involving the anterior band of radial collateral ligament, which is the cause of pain rather than the cause being the common extensor tendinosis.
Dr. Harshita, actually time is over, but we have to complete rest also.
Okay. So the other way to how to do the intervention after diagnosing the pathology, you just place your probe over the upper third of the humerus, and what you see this one, this muscle, which has got a scorpion tail appearance. This scorpion tail appearance. This is tendon of extensor digitorum, and when I go up, I'm moving my probe up. This muscle bulk is the tendon of muscle of extensor carpi radialis brevis, which is a pathological tendon most of the times. I'm just moving up, 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 and see this is the scorpion tail appearance, and I'm still moving up. This is the tendon of extensor carpi radialis brevis, which has appeared, the white thing, and I'm moving up, up, and here. This is the tendon of extensor carpi radialis brevis. So if at all you are looking for a pathology which you are not able to see, always look it in the short axis. And even the intervention, if you want to do the intervention, this is much easier way of doing the intervention rather than in the long axis, because the tendon is spread over a anteroposterior dimension. Many a times you would not be, the hand doesn't become stable and you will not be able to visualize it well. So it's always a good idea to keep the probe in the short axis over the tendon and visualize the entire tendon. Okay, there. This one. So I'll move on to the wrist because of the lack of the time. How much? You need a bottle. Yeah, I've got a bottle here. How much time am I left with? 5 minutes? 3 minutes, okay. So quickly I'll, again the bony acoustic landmarks. So if we have to see the bony acoustic landmarks, we know that on the lateral side it is the first bone, entry of the carpal tunnel. The trapezium? Yes, scaphoid. The scaphoid articulates with the radius, right? Trapezium is the proximal bone. Oh, sorry, it's the scaphoid. The scaphoid is the proximal bone and the trapezium is the distal bone. Okay, so here you can see the trapezium. Oh, sorry, the scaphoid, and on the medial side, here, you can see the pisiform. Now, how to identify whether we are on the pisiform or the hook of hamate? At the level of the pisiform, what you will see this Guyon's canal right here, with the ulnar artery and the nerve, right? And there will be a lot of anisotropy, right? You just need to do a rocking movement of the probe and your anisotropy will be gone. Now, after identifying this, you see this hypoechoic line which is traveling like this and bifurcating. Just a minute, let me delete it. This line going like this and getting attached, and there is a bifurcation, and this is your Guyon's canal. The Guyon's canal, and this is your carpal tunnel area. This one is the carpal, and this superficial hypoechoic structure is the median nerve. Now, how to do the interventions in the carpal tunnel area? See, there is the first and the most important thing is always do it from the medial side. Why from the medial side? Because on the lateral side we have got branches of the median nerve coming out. It could be the recurrent branch, it could be superficial branch which can get injured. So it is always a good idea to do it from the medial side. Now, the commonest question which is going to come is, on the medial side you have got the ulnar artery and the nerve. Why can't they get injured? So what you do is, what my technique is, once I come over to this plane of the carpal tunnel, and the second thing, the nerve get entraps at the distal end mostly. not the superficial part, superficial end of the carpal tunnel. Why at the distal end? Because it gets narrowed. So the idea is to deposit the drug at the distal end of the tunnel. But again, because of the thickness of the muscles here, you are not able to do that. So what I do is, what my technique is, okay, I come over to the distal end where I see the hook of the hamate. See, how do I differentiate whether it's the hook of the hamate? The ulnar artery goes superficial. The ulnar artery climbs over or goes superficial and lies almost in the superficial plane, not in the Guyon's canal. That is the place where it is the hook of the hamate. That's the ulnar artery, that's the hook of hamate. And now at the hook of hamate, I tilt my probe obliquely. Okay. Now after tilting my probe obliquely, I move little medial and then I enter from the medial side. So what is the benefit of doing it? The benefit is, once I've tilted my probe, I'm going deep. My ulnar nerve, the target, the ulnar nerve is already at the distal end and my needle is going so there. This is my area for the needle. Coming from the medial into the distal part of the canal to do the hydrodissection and to deposit steroid. My experience of giving a steroid is much better than doing a putting 5% dextrose or even putting ozone and dextrose, because steroid definitely helps in subsiding the inflammation much faster and the patient gets relieved.
Dr. Harshita, sorry to interrupt you.
Yes, I am almost done. So about the distal intersection syndrome, maybe we can discuss it a little later. If there is any particular question, I would be happy to answer at the end of this.
Thank you, Dr. Harshita. And there is a small announcement. This is going to be the last lecture of this session. And after this, there is going to be tea break for 10 minutes and we'll return for next session. And I would like to especially appreciate Dr. Anand and Dr. Madan for managing the stage and holding the camera. That's really helpful.
Thank you, Dr. Arshita Surange, ma'am, for taking us through the scanning of the elbow and wrist. Since we are running late, I like to request all the faculties and delegates to make time for themselves and have their tea in between the sessions. Let's move to our next session. Please welcome Dr. Rajendra Sahu, sir, who will demonstrate scanning of the ankle and foot. Dr. Rajendra Sahu, sir, has a special interest in peripheral joint ultrasound.
Okay, so good morning. Exhaustive session. So I'm going to cover the foot and ankle here. Anterior, medial, lateral, posterior and plantar in a stepwise manner. Lots of muscles, tendons, joints. If you guys will be interested to see the
Hello, hello.
Hello, yeah. So I can show you the Baxter nerve if I get to see here. Bit of ligaments, ATFL, deltoid, all those. So let's start with the anterior knee scanning. Okay, so step 1, you can see here, knee flexed, foot is bit of dorsiflexed. Always scan in the long and short axis, both. Okay. Okay. So what you are seeing here, I am scanning in a transverse plane over the ankle.
My orientation marker is towards the left, which is lateral, right is the medial. Okay. So, you can see here 3 tendons, tibialis anterior. Okay, let me go further medial. Okay, so tibialis anterior, extensor hallucis longus and extensor digitorum. So, tibialis anterior will be the medial most. This one you see in the long axis, that is the tibialis anterior, this one. Okay. So, this is the tibia, this is the talus, the hyaline cartilage, and this is the tibiotalar joint. Okay. So, you see that in a lot of inflammatory arthritis, spondyloarthritis, rheumatoid arthritis, a lot of joint effusion there. If you want to do an intervention, people say they do long axis, I go out of plane, easy, quick and do out of plane, and this is your fat pad. You just stop it there, you can aspirate fluid, you can do the injection. So, so this is the tibialis anterior, and if you change to 90 degrees, so that small tendon is your tibialis anterior there. Again, you do that. Tibialis anterior, this one, this is your extensor hallucis, tendon on the top, muscle is a little down, and this is your extensor digitorum, digitorum group over here. And in short axis again you can see the long hyaline cartilage, this is the talus, you can see the joint over there, and without putting a lot of pressure you can see the pulsatile artery there, you can see the artery, and here just lateral to should be your, take it out, your posterior tibial nerve. As I scan up, let me, so this is the nerve over there usually to the lateral side of the artery. So, this is the step 1, you see the tendons as you go up, you can see this is your tibialis anterior, this is your extensor hallucis. इसको थोड़ा ऊपर करो, ये उंगली को ऊपर नीचे, ये उंगली को. So, you can see the EHL. Okay. So, this is the tibialis anterior, just to show you that, and if you go further lateral you can see the extensor digitorum. So, this is the front of the ankle, just to show you the tibiotalar joint again, which is one of the injection site for a lot of inflammatory arthritis here, tibia, talus, this is the talar dome, neck, and as I go distal you can see this is the talonavicular joint. Okay. So, this this tendon will go all the way insert at the cuneiform there here. So, that is the insertion of your which one your I am going tibialis anterior. Okay. So, this anterior part is all gone. Let me move to the medial side. Okay. The medial side, that is medial malleolus, we have 3 tendons, the tibialis posterior, flexor digitorum longus. Can you see here? There are 2 things, 1 and 2, they look similar in appearance. Okay. So, this is your flexor retinaculum on the top, take it out, all those. Okay. So, here, isko thoda upar niche karo. Okay. So, with this movement, you see that is the tendon of FHL and this is the muscle of FHL, flexor hallucis longus, take it out. And this is your tibial nerve. Take it out. So, both of them look similar. If you have to do a posterior tibial nerve block for your plantar fascia PRP and you just end up giving here, the block is not going to be effective. Make sure that you are not giving around the tendon. Okay. So, that is the posterior tibial nerve there. Okay. Take it out. So, now I will slowly go down just to show you the Baxter nerve. This big nerve, keep an eye over here. This big nerve will divide into 2 branches. Actually, a small branch usually maybe little proximal takes off from here will be a medial calcaneal nerve that innervates the calcaneus there. Okay. Just keep an eye over here, take it out. Okay. Slowly I will go down, 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 down. Now, it has divided into 2 branches. Okay. So, medial and lateral plantar, take it up, 2 branches. So, now look at the lateral branch, little more gel. So, the Baxter nerve is the first branch of the lateral plantar nerve. Okay. So, that takes a 90-degree course, travels between the abductor hallucis and the abductor hallucis and the quadratus plantae. So, now that this is a single almost 2 branches, medial and lateral. our focus should be on this lateral. Take it off. Now slowly going down, down. Now I am here. This is the lateral plantar. Take it off. So keep an eye over there, lateral plantar. The first branch. Now you can see this is the medial and this is the lateral plantar. Two branches. Okay, can you make out that? Now that this is from the lateral plantar, keep looking at this place, not at the, this is the medial plantar, take it off. So now from here, lateral plantar, the first branch slowly going down, that is just first branch coming out, take it off. So that first branch takes a 90-degree course again, so this is the branch, small branch there. So that small branch, again you can see it here, small branch, take it off. That goes 90-degree, and at this point you are going to miss it because that takes a 90-degree course. And then as I slowly go, I can see little bit over here, this one. And slowly as I go anterior, now I reach a place, these are the two muscles I was talking about. Look at my pro position. So this is your abductor hallucis, this is the quadratus plantae. Okay. So for you who wants to do a Baxter nerve intervention, like in heel pain with or without plantar fasciitis, around 10 to 20% of the heel pain is from the Baxter neuropathy. So even if you are not able to identify the Baxter nerve, you just need to identify these two muscles and there is a facial plane, correct. So in that facial plane, the nerve is usually around over here, put that. So I'll try to slowly show you that. So the nerve is usually over here. So what I need to do is that your needle should come from posterior to anterior. That is actually the nerve. Stop it here in this plane, inject around 2 ml, 1.5 ml to local or 10, 20, 30, 40 of steroid there. So that is the Baxter nerve hydrodisc. Okay, stop it, take it out. So mostly that is the nerve. I'll slowly go up, 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 up. Now see, that is enough. Take it up. So that is the nerve. Slowly going up. Did you see that nerve structure there? This area, take it off, take it off. Going there, slowly, slowly. That branch, that is the joining that lateral plantar nerve. Okay. So that was about the Baxter nerve. I have published that paper in Anesthesia Analgesia Practice. You can see that. So now in the medial part, one ligament. Let me show you. Now that once you see all those tendons there, tibialis posterior, flexor digitorum longus, okay, slowly coming down, 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 yes. Just once the tendons are off, this is your part of that deeper part of the deltoid ligament. Take it off. Have a look at that hyperechoic tendon as I do a bit of plantar extensor. So this is the deeper part of tibio-talar joint there, okay, tibio-talar part of that component, okay. So that is one component. You look just beneath that tendon there of the tibialis posterior. If you scan little, so here another band, anterior band of the tibio-talar. This is the subtalar joint, talus calcaneus. Okay, so this is another anterior band of your joint. Take it out. Can you see that ligament very nicely going this part? Okay, anterior tibio-talar ligament there. So these form the complex of that deltoid ligament. Okay, and this is your subtalar joint, talus calcaneus. So you go there for a subtalar joint injection. Okay. So the medial part is all gone. Let me go to the lateral part. Okay. In the lateral part, again, changing these positions are very important. I'm going to show you in the lateral part. Some people might not be. Let me start with superficial peroneal nerve. Okay. I'm scanning at the distal. Thoda depth बढ़ाओ. Depth. Thoda gain कम करो. Increase the depth. Yes. Okay. So here. Okay, look at what I am doing. So my orientation marker is posterior. This is posterior, left is posterior, right is anterior. Yeah. So what you see, pointer le lo na, pen, scribble le lo. So now you see you have to identify two bones. Number one is your fibula, inverted V said fibula. As I go anterior, you can see the tibia there. The muscle over here is extensor digitorum longus. The muscle over the tibia is your peroneus brevis. Longus is bit of tendinous over there. Take it off. Okay. Now you can see a intermuscular septum that divides the anterior to the lateral compartment. Can you see that? And there is a fascia over here. That is a crural fascia. Identify this stepwise. Fibula, tibia. Then look at these two muscles, EDL, and then this is the intermuscular septum, crural fascia. Clear? Take it off. Now, just below that crural fascia, look here. So that is your superficial peroneal nerve. Okay, take it off. As I go down, keep looking there. So that, give me that. So that one will slowly pierce that. Now you can see that is the nerve there. Slowly pierce that crural fascia, and will come superficial. Now here, close to the fibula, will become superficial and divide into two branches. Where are they? Okay, so that was about the superficial peroneal nerve. Now let me go down to the close to the ankle over here. You can see the tendons, that is the lateral malleolus. You can see the tendons. There is a tendon on the top, that is the peroneus longus. There is another just next to the bone, that is brevis, B for bone. ठीक है, जो bone के बगल में है, that is the peroneus brevis, and you see a bit of muscle, that is the peroneus brevis का muscle है. The top is your peroneus longus. Take it off. Okay, so you can see for those tenosynovitis, all those things. Here another small nerve that I want to show you is your sural nerve. Okay, so this is anterior, this is posterior. Look for that subsaphenous vein. Don't put a lot of pressure. You can see the subsaphenous vein over there. Okay, the sural nerve, this one is your sural nerve, is usually posterior or deeper to that nerve. As you slowly go up, that is a nerve there. That is a nerve. Did you see that? Take it off. निकालो उसको. ये है sural nerve. Okay, so that is in the vicinity of your. This is important. Sometimes you may see all those neuropathies from trauma, injury, post-surgical, fibular surgeries, all those things. You know, lateral side of those foot neuropathy. Now coming down, I'll go to the tibio ATFL. Okay, so this is interesting. So here is your lateral malleolus. What I do, I start scanning a little proximal actually. Okay, maybe around 5-7 centimeter proximal to the lateral malleolus. So what you see, this is your fibula, this is your tibia. Slowly start coming down till both are of same height, almost same height. Did you see that? This is lateral, this is anterior, posterior, anterior. So they are almost at the same height. Okay, same height. Now as I approach the lower part, now the tibia, this bone is gone. I don't see anymore. Something pops up now. You see a bone there? And there is a hyaline cartilage, that is the talus. Okay, so this is fibula, this is the talus. Okay, from here, what I do, look at my probe. Probe is a bit of transverse. I change that outer end or the medial end of the probe towards the big toe, Okay, here I go. So that is your ATFL. Okay, take it out, reduce the depth. Did you see that very nice ATFL there? So this is the tibia, this is your talus. You can see the hyaline cartilage. This is around, this is whole of ATFL. Yes, clear? So let me do a bit of, usko dhila chote babu. So if you do a bit of, you can see that very nice ATFL there. As you do plantar flexion, dorsiflexion, you can see that getting taut there. Can you see that ATFL? I want to hear a yes. Yes. This is that ATFL. Okay, so just to repeat that, you may struggle. So I start little proximal, come down, both are of equal height. Keep the distal end of the probe lateral over lateral malleolus. You see that talus there, hyaline cartilage. Once you see that, fix the lateral end of the probe over your fibula, over the lateral malleolus. The medial end of the probe tilt towards the big toe. Now you see that. Okay, so that is your ATFL. Done? Okay, so now the next, okay, coming here maybe like coraco, calcaneofibular, if you want to see, probably we can show you. So now you see here, again just to tell you that this is B for bone, peroneus brevis. This is peroneus longus. As I slowly come down here, down, see tilting the probe this way. Freeze ho gaya. Calcaneofibular is not that important.
We'll have to rush up.
How much time?
3 minutes more.
Okay, हो जाएगा उसके अंदर. Okay, so okay, now I see this is my lateral malleolus. Those are the tendons. Just below that, there is a small ligament going here from, starting from, fibula to the calcaneus. Take it out. That is your calcaneofibular ligament. Okay, here you go. This ligament. Okay, so comes from that is a calcaneofibular ligament in the long axis. Okay. Now this part is gone. My anterior, medial, lateral. Let me थोड़ा ऐसा हो जाओ. posteriorly. Yes, so now I will show you the plantar part. So you saw Baxter, you saw those ligaments. एक मिनट ये lateral में कर देता हूँ, then we'll just do the prone. Okay, two things. ऐसा रखो. Yeah. So now I'm going to the plantar fascia. Okay, scanning over the plantar fascia, you can see the calcaneus there. Okay, the very nice fibrillar from here to here is the plantar fascia. Okay, as I scan distal, you can see those. You can see this lateral band of that fascia going there. Can you see that nicely? So here, this is a very nice fibrillar fascia here in patient. Take it out. In patient who have chronic plantar fasciosis, you can see this becoming thicker. Okay, generalized or can be focal thickening over here. We measure it from here to here. Okay, at the calcaneal attachment should be more than 4.5 millimeter or so. Okay, and hypoechoic thick plantar fascia, color Doppler, all those changes. The intervention. So this is a long axis scanning. I turn short axis like this 90 degrees. So you see this is the calcaneus. This is your plantar fascia. I go in plane from here to here on the top from medial to lateral. The surface top of the fascia for a steroid injection, go into the fascia for a PRP injection. I do it under posterior tibial nerve block. Final part, the Achilles tendon. Look how. Okay, so getting inserted here, you can say a bit of anisotropy as it gets inserted there. You can Achilles tendon, normal thickness in patient who have Achilles tendinosis, they can observe insertional calcification also. You can, this tendon will be very thick there, hypoechoic, that homogeneity will be lost there also. This is your retrocalcaneal bursa. Sometimes you can see retrocalcaneal bursitis. We see patients seen from the orthopedic, other people, bland, common diagnosis, RCB, retrocalcaneal bursitis, just looking at the symptoms. So, and as I scan in short axis, you can see this calcaneus, this nice fibrillar tendon there. As you slowly go up, you can see that it's there. Okay, so in patient who have tendinosis, this will be thick, like this much of thick, hypoechoic, that homogeneity will be lost. Okay, thank you. I hope you got some take-home message.
Thank you, Dr. Sahu.
Done?
Thank you, Dr. Sahu, for your beautiful presentation. Now we will move for the tea break, and we will be back again after the tea break.
Excuse me, ma'am. Actually, there's no tea break. Faculties and delegates have to make their time by themselves to have the tea in between the sessions.
No, the session will be more interesting than the tea break. So get your tea here inside. Please rush in with your tea. I think this is an important topic, posterior pelvis examination, and includes the hip also. We'll wait for you maybe for a couple of minutes. Have your tea. Please come inside the hall.
We'll wait. Really?
I like to welcome Dr. Anand Murugeshan sir to present on hip and posterior pelvis.
Are we waiting for 2 minutes? Hip. Oh, then hip alone? Oh.
Oh, seriously?
Session ended.
Anand, 2 minutes. Posterior pelvis is there. It's there.
Hello. We'll start. Hello? Hello? There was some miscommunication, so sorry for the trouble. We are starting with hip and posterior pelvis scanning by Dr. Anand.
Yeah, I'm
Attention please. I request all the poster presenters to gather in Hall Nova 1 for their poster presentation. It will start sharp at 11 a.m. I repeat, all the poster presenters gather in Hall Nova 1 for poster presentation at 11 a.m. sharp. Thank you.
Now I like to welcome Dr. Anand Murugeshan sir to present on hip and posterior pelvis musculoskeletal ultrasound technique.
We can start, yeah. Delegates will be coming inside. I think we can start.
Yeah. Okay, so we are going to do a hip and posterior pelvis. So my humble request for the chairpersons to be little more considerative. So like we will start with hip. Hip is little superficial structure, so I am going to use a linear high frequency probe. And again, like there is no hard and fast rule, it depends upon the body torso. If the patient is on the higher BMI side, we may have to go for the low frequency. So never keep a fixed idea like for this structure you need this particular probe. So he's a thin built guy, so I am going to use a linear probe which is a high frequency probe. So what are all the area of interest in hip? So we need to see how we are going to inject, how are you going to give an intra-articular hip injection. So that is one. And how are we going to target the articular branches of the hip for hip denervation. Then how are we going to scan and reach the hip bursas. So these three are the very commonest painful conditions of the hip. If you know these three structures in the hip, that is more suffice. So now to start with, how to scan the hip articular branches. So in scanning, as I previously mentioned, like start from the familiar structure and then we can familiar sono anatomy and then you can reach the target. We call it as the sono tracking. So this is a anterior superior iliac spine which you cannot miss. The superficial and the hyperechoic structure is the anterior superior iliac spine.
We need to
and
adjust
then
the camera.
You can see the iliacus muscle here which is attaches medial to the iliac bone, iliac crust. So as you come down,
on the probe position. Yeah, thanks.
I just want you to focus here. As I'm coming down, are you focusing this? Yeah. So I want you to have a look at my probe, how I'm moving. So we have once you locate the anterior superior iliac spine, you have to slowly move the probe inferiorly and medially, and then get the anterior inferior iliac spine. This is your anterior inferior iliac spine, which is the next hyperechoic structure, and just before it disappears and forms the joint. So this is the anterior inferior hyperechoic structure called anterior inferior iliac spine. This is a very important landmark because you see that my scan is in the transverse scanning position. So now once I get the anterior inferior iliac spine, I am turning the probe to 45 degree. Can you just show me the probe? Yeah. So now it has turned 45 degree. It has shown 45 degree in the clockwise direction. Now what you see are the most three important structures which I would all of you to appreciate this.
Camera is frozen.
This is your anterior inferior iliac spine, and you see a nice pubic notch here, and this is your pubic iliopubic eminence IPE. These are all the very important landmarks for your articular branches. So if you see above, you can see the femoral neurovascular complex of the femoral bundle, the femoral vein, the femoral artery, and the femoral nerve. So now this particular muscle, this is a iliacus muscle, this is a psoas muscle, and this is your iliopsoas tendon. So this is the landmark, very important. I am freezing it. So now the targets for your articular branches of the femoral nerve will be exactly at 2-3 sites just distal to the iliopsoas tendon. Or in other words, you can take this measurement, the femoral nerve is here, just a line perpendicularly down from the femoral nerve on the pubic notch. You have to go laterally and then make 2-3 lesions at 1 centimeter apart between your iliopsoas tendon and your pubic notch. The articular branches of the femoral nerve are very richly placed here before it goes and supplies the anterior superior labrum and the anterior superior hip joint, which is the anterior hip joint is predominantly supplied by the superior capsule, and the superior anterior joint is supplied by the femoral nerve, where we target the articular branches exactly distal to the psoas tendon, and this is your pubic notch, and this is your iliopubic eminence, IPE. So, this is where your accessory obturator now comes here. So, that now the target, the trajectory will be like from the lateral to medial and then come and then reach the iliopubic eminence for lesioning of the accessory obturator nerve. So, the caution to be careful here for this particular accessory obturator is the femoral nerve is sometimes will be in this particular patient it is not coming in the trajectory, but sometimes this femoral nerve may be coming in the trajectory. So, we have to be very careful in avoiding the femoral nerve, or else sometimes you will go through and through the femoral nerve to reach the iliopubic eminence. So, this is for the accelerator obturator now. So, having finished the femoral and the accessory obturator now, so I am again going back to the transverse scanning and your anterior inferior iliac spine. As I come down, you can see a rounded contour structure. Can you see? This rounded contour structure is the head of the femur. So, once I get the head of the femur in the view, now I am making the same 45 degree as the anti-clockwise. Previously for your articular branch of femoral nerve, we made it clockwise. Now, I am making anti-clockwise, keeping the rounded contour in the picture, and then you see a nice cobra sign. This is your head and neck of the femur. So, what is so important here is like the capsule is extra articular here. The capsule is extra articular. Sorry. You can see the capsule here. The capsule is coming out of outside the joint, and then it is attaching at the neck of the femur. So, our needle trajectory is from infrolateral to the supromedial, and then reach the junction between the neck of the femur and the head of the femur, and the drug will be tracked into the joint here. And you can see a labrum, nice labrum here. Try making not to reach this labrum here. We should avoid reaching that labrum ding. So, now, and this is your acidabulum. So, now what is more important here is, once you get this structure, you can you show me the probe? So, now I am moving that probe inferiorly and medially. You see now, this is your joint, this is your acidabulum, this is your femur, this is your labrum. I am moving the probe inferiorly and medially, and then you know the head of the femur goes off, and then you get one inverted V-shaped. That is your infromedial acetabulum. Otherwise, we call that as insinura acidapuli, where your accessory obturator nerve comes there, where you can do a lesion there. So, that is about the articular branches and the intra-articular hip. Can you just lateral? So, now for coming to the bursas, so we get the rounded contour. You can see the vastus lateralis muscle, and this is your short axis view of your shaft of the hip. As I come inferior to the superior, you get a tower like sign, that is your facets of the greater trochanter. See, now this is rounded contour here. As I come up, you can see the facets of the greater trochanter. So, this is your anterior facet, this is your lateral or the posto-superior facet. This is actually, for him, the anatomy is so good. This is your gluteus minimus muscle, this is your gluteus medius muscle tendon. I mean, this is a gluteus medius tendon, this is your gluteus minimus tendon attachment to the greater tubercle, greater trochanter, and this is your gluteus maximus. The gluteus maximus is above the superficial to the gluteus medius, and it continues as the ITB, iliotibial tract. So, if you track this iliotibial tract, the gluteus maximus tendon gets merged with the iliotibial tract, and then it goes superior and inferior and attaches to the girdles tubercle, as Dr. Vikar Ahmed explained. So, where the bursas to be injected? So, we have three bursas here. The one is between the gluteus minimus and the anterior facet. Another one is between the gluteus medius and the lateral facet. And this is the very important bursa called GTB bursa, greater trochanteric bursa, where you just inject between your beneath the greater, gluteus maximus tendon, and the drug will spread to all the three bursas. So, this is gluteus minimus, medius, and this is your maximus, which continues as the iliotibial tract. So, now lateral femoral cutaneous nerve is another important landmark. Again, start with anterior superior iliac spine. So you can see the anterior depth decrease. Increase the depth, please. Increase the depth. So this is anterior superior iliac spine, and as I said, this is the iliacus muscle. Now I am scrolling down. As I scroll it's a transverse scanning. As I scroll my ultrasound down, you can see another small muscle coming up. That is your sartorius muscle. Can you see now? That's the sartorius muscle. That again starts from the anterior superior iliac spine, and the lateral most is your tensor fascia lata. This is your tensor fascia lata, and this is your sartorius. Both arises from the anterior superior iliac spine. And can you see one sleeve here? That is the sleeve, facial sleeve formed by the iliacus fascia, where your lateral femoral cutaneous nerve starts. Can you decrease the depth? So I am now scrolling down. You can see that decrease the depth. Yeah, thank you. So now you can see the nerve nicely visible here. Can you see the nerve? That's your lateral femoral cutaneous nerve, which is a very, very superficial nerve, which is hypoechoic nerve in the fascia iliacus facial sleeve between the sartorius and the tensor fascia lata. As I come down, you can see that nerve going slightly deeper, and then it enters into the sartorius muscle and gets divided into anterior and the posterior division. So when you are giving a lateral femoral nerve cryo ablation, you can do one ablation here and one at the bifurcation of the division of the lateral femoral cutaneous nerve, like an anterior and the posterior division. So that's about the lateral femoral cutaneous nerve. Then little bit on the posterior pelvis, which is again very important structure. I am going to use the curvilinear probe. Why it is so important in posterior pelvis? We need to. It's one of the very underdiagnosed chronic pain conditions, especially the piriformis syndrome and the pudendal neuralgia, where you will come across a lot in your clinical practice. So which is little bit complex in the scanning because the structure is very deep. So I am using a curvilinear probe. So start scanning again from the posterior superior iliac spine. So this is your posterior superior iliac spine, and the structure you are seeing is your gluteus medius. This is your gluteus medius muscle, and this is your iliac crest. So I would like to have complete, it's called nice tracking. See, now the iliac crest is intact like a nice waterfall. You can see it's a waterfall sign. And I want you to show the probe here, somebody. All of you can see the probe. Because this is very important one, like how to get into the piriformis and the pudendal nerve is very important. So I am starting from the posterior superior iliac spine, and this is your gluteus medius, I said. Very good, thank you. So as I come down, you can see there will be a break in the iliac crest. Can you see the break? So where the greater sciatic notch starts. This is a very important landmark here, because once the greater sciatic notch comes, the gluteus medius becomes smaller, and one more muscle pops off, that is your piriformis muscle. You can see the nice piriformis muscle here. How do we know it is a piriformis muscle? You can actually, the piriformis muscle is an external rotator of the hip. So once you keep here and then you do a external rotation, you can see the muscle sliding from the greater sciatic notch to the peripheral. So that is your piriformis muscle. So how to inject the piriformis muscle? We have to be extremely very careful, because there is if you can have a look at it now, this is a place where, can you see some hyperechoic structure here? That is your lumbosacral plexus. So the lumbosacral plexus starts here at the greater sciatic notch, deeper, and as I go down, the deeper lumbosacral plexus becomes a sciatic nerve, and it forms a sciatic nerve superficial to the ischial spine. So this is your sciatic nerve becomes superficial to the ischial spine distally. I am going little proximal. The linear ischial spine has become a greater sciatic notch here, where you see the piriformis muscle. See, this patient has got a very thick, this person has got a very thick piriformis belly, but sometimes you may have very, very thin piriformis. So the trajectory will be from lateral to medial, and here make sure you are not in the sciatic nerve, because in 20% of the individuals, the sciatic nerve can be superficial to the piriformis muscle. See, now usually in 80% of the individual, it will be superficial, but it is deep to the piriformis muscle, but
it can be superficial to the piriformis muscle in 20%. So, as you are injecting into the piriformis muscle, make sure you are not on the sciatic nerve. So, now as I come down, again I am on the linear, the curved greater sciatic notch has become the linear ischial spine. So, now here what I am doing, I am just going slightly medial. As I go slightly medial, I am going to focus on the some pulsation. Yeah. So, now can you freeze it? See, now this is a very important picture. I would like to show, this is a pulsation, this is your pudendal artery pulsation. The sciatic nerve is lateral to the pudendal artery, and this small hyperechoic structure is your pudendal nerve. This pudendal nerve is exactly in the tunnel formed by the sacrospinous ligament and the sacrotuberous ligament. So, the entrapment happens here. The commonest entrapment of the pudendal nerve happens here, especially in prolonged, the job involving the prolonged sitting. So, you get the entrapment of the pudendal nerve. Patient can have either a perianal pain or the genital pain. So, this is your pudendal nerve medial to the pudendal artery, and the sciatic nerve is lateral to the pudendal artery. So, where is the trajectory? The trajectory is from medial to lateral, so that you can avoid the sciatic nerve. So, last 1 minute. So, now you can see better now the pulsation. Can you see the pulsation? That is the pudendal artery. That is the pudendal artery. This is a sciatic nerve, and medial to the pudendal nerve is your pudendal artery is your pudendal nerve. So, now I am going little bit distally. The linear ischial spine now becomes curved. Can you see it is curved? So, now we are at the ischial tuberosity level. Once we are at the ischial tuberosity level, again you are going to look for the pudendal artery pulsation. So, you can see a nice pudendal artery pulsation here. You can see the pudendal artery pulsation here. So, now this is another level where the nerve can get entrapped. See, now the nerve is just medial to the pudendal artery. This is a pudendal artery, and you can see a hyperechoic structure, that is your pudendal nerve. Again you can come from medial to lateral, and then you can hydrodissect here. This is a place where the pudendal nerve can again get entrapped. So, what is the difference between the entrapment at Alcock's canal and the ischial spine? The rectal nerve gets paired here. The rectal nerve, before it reaches the Alcock's canal, it gets paired after it crosses the ischial spine. So, this procedure may not be ideal for perianal pain, but for the genital pain it is really helpful. So, you can see the nice pulsation here, that is a pudendal nerve, artery and pudendal nerve. This muscle is an obturator internus muscle. So, once again I am going back. So, this is your ischial spine I told, ischial tuberosity I said. So, now this is your piriformis muscle. So, now what I am doing, I am just going, can you, is it focused? Yeah. So, from here I am going slightly lateral and superior, cranial and lateral. So, now I want you to have a look here, three structures. One is, this is your gluteus minimus, this is your gluteus medius, and small, as you go lateral, the gluteus maximus becomes small, and gluteus medius and gluteus minimus becomes prominent. So, between this plane, between the gluteus medius and gluteus minimus, this is a pulsation. You can see a pulsation here. If you can focus here, you can see a pulsation here. Can you see a pulsation here? That is your superior gluteal artery. That is your superior gluteal artery, and right next to the superior gluteal artery is your superior gluteal nerve. So, you come here and then you can do a pulse radio frequency or even a conventional radio frequency for the superior gluteal nerve. That actually denervates the posterior superior hip joint or the posterior superior capsule. So, that is one of the denervation. I think with that I think we have covered the most.
Yeah, we have been generous not to
Thank
disturb
you so much.
you.
You have been so generous. Thank you so much.
So, thanks a lot.
Thanks for your patient listen.
And I would like to invite all the speakers of first session.
Yeah, you're fine, over.
No one is here. Other speakers? Yeah. Dr. Anand, Dr. Vikar.
I'd like to request the day one poster presentation participants to assemble in Nova 1, where the presentation starts at 11:30 a.m. There's a special announcement, 40th ISSP Con Hyderabad. We are excited to welcome you to the 40th ISSP Con at Hyderabad. As a special offer of all delegates and faculties, we are providing a discounted registration fee for the ICRA Pain conference. Kindly register at the earliest to avail this opportunity. Thank you. Now I'd like to call Dr. Suzanne to take over the next session.
Good morning, everyone. We now move on to an exciting session on radiofrequency ablation in pain and more. Radiofrequency ablation has emerged as a cornerstone in interventional pain practice, offering long-lasting relief for chronic pain conditions. This session highlights its principles, techniques, and applications. I would request the chairpersons to take their positions on the stage. Our chairpersons for this session are Dr. Varsha Kurade ma'am, Dr. Amna Goswami ma'am, and Dr. Surbhi Kalita ma'am. Dr. Varsha Kurade ma'am has prestigious FIPM, FIAPM qualifications and is director and program head FIAPM, and she has represented ISSP India at international level and is an IAPM examiner and has authored book chapters in FIAPM manual. Dr. Amna Goswami ma'am is a consultant neuroanesthesiologist at Park Neuroscience Center, Kolkata, and has numerous publications in national journals. Dr. Surbhi Kalita ma'am has a PDCC and FIPM qualification and is founder of Narayana Pain Clinic. Welcome ma'am on stage. Our first talk is by Dr. Shrish P. Amitya sir on cooled RFA of the sacroiliac joint. Sir has FIPM, FIPP, and CIPS qualifications to his name. He is director at Nepal Pain Care and Research Center and is an esteemed faculty at Daradia Pain Clinic. I welcome sir on stage to deliver his talk.
Where's the mic? Is this one? No.
Okay, the cordless?
Yeah.
Okay, sir, I'll get it.
Good morning, all the chairpersons, respected delegates, international and national, my dear friends, teachers, colleagues, and I'll be presenting today sacroiliac joint radiofrequency ablation. There is no conflict of interest or a financial interest to my presentation. So as we all know, sacroiliac joint dysfunction is quite common in day-to-day clinical practice, and it is in fact the third most common. Okay, it is third most common cause of low back pain. Various studies that I've quoted in the PowerPoint also are in common consciousness that the percentage of or the prevalence of SI joint dysfunction is about 25% in general population. If you see the prevalence, some studies ranges from 10 to 30%, but the other one, the one which was done by our sir, Dr. Sudhir Diwan from USA, in his study, it was found out that prevalence rate was almost as high as 62%. But both of these studies basically concluded that average prevalence of SI joint dysfunction in general population is about 25%. There are various risk factors associated with this SI joint dysfunction. In this disease also, like any other degenerative disease, increases with the increasing age. But having said that, SI joint dysfunction is not uncommon in young population, especially those young people having spondyloarthropathies commonly have SI joint dysfunction. And female gender being the hormonal change that they grew through pregnancy, childbirth, or during postpartum period, where there is too much manipulation of SI joint. These are also risk factors. And since SI joint is the main weight-bearing joint, and it also provides stability, any abnormality in the weight or the balance can also produce the sacroiliac joint dysfunction such as obesity, trauma, if there is any leg discrepancy, abnormal gait, scoliosis, or if there is previous lumbar fusion surgeries, these also contribute to the SI joint dysfunction. Similarly, infection, especially in this part of world, tubercular infection of SI joint is quite common, and inflammatory arthropathies are also one of the common risk factors. So sacroiliac joint is a unique joint, and it basically basically connects the trunk with the lower limbs. So it helps in transmission of weight from upper part of the body to the leg, and it resides in the lower part of the lumbar spine at the level of pelvis. And if you see the anatomy, it is located in the lower part of the pelvis between the sacrum and iliac, and it forms the diarthrodial synovial joint. And as you can see in the picture, it is a pinna sepate joint where the sacral surface is basically covered with hyaline cartilage, but the iliac surface is covered with the fibrocartilage. And as you can see in the picture also, these are irregular joint. So this irregular surface of the sacral and iliac part forms the interlocking joint. So since it is a diarthrodial joint, it provides very little motion because there is an interlocking of the iliac part and the sacral part, and it only allows the slight 4-degree rotation, and the stability is by the various ligaments and muscles which is surrounding the SI joint. According to the International Association of Study of Pain, for the diagnosis of SI joint dysfunction, following criteria has to be met, such as there should be pain localized in the region of the SI joint, and there should be pain localized in the SI joint. These pains should be reproducible by any stress or other provocative test, which we commonly do in clinic. And finally, this pain should be relieved with injection of local anesthetic in the joint. So these are the main diagnostic criteria. There are various intra-articular and extra-articular causes of SI joint, such as infection, arthritis, SPA, enthesopathy, fractures around the SI joint, and the ligament and the muscle which supports the SI joint. If there's any dysfunction in those structures, also produce SI joint dysfunction. So if you think the clinical features basically regards as patient complains of pain which is dull, aching, and sharp stabbing in nature. Most of the patient complains of pain over the gluteal region, but there can be referred pain especially to the lower lumbar area, upper lumbar area. In fact, the referral pain can be to the groin or upper abdomen, and occasionally to the posterior aspect of the thigh, not beyond the knee. But rarely it can also mimic radicular pain like lumbar radicular pain, especially when it involves the piriformis. If you see the origin of piriformis, some part of piriformis also originates from the SI joint. So if there is any SI joint dysfunction, it may irritate the piriformis, which can lead to irritation of the sciatic nerve, and patient can complain of radicular pain down to the leg, even down to the leg. In these conditions, you might get confused whether it's a radicular pain or the SI joint dysfunction. Okay, so there are various aggravating and relieving factors such as activities such as sitting to standing, sitting for prolonged time, running, climbing stairs, or change of posture can lead to increase in pain. Similarly, this pain is relieved with rest and non-steroidal anti-inflammatory drug. So there are various lots of clinical tests for provocative clinical tests for to test the SI joint dysfunction. But whenever there is lots of tests, you always have to remember that none of these tests are diagnostic. So according to the International Association of Study of Pain also, there should be at least 3 out of 7 tests should be positive for us to diagnose as a SI joint dysfunction Okay. Can be various investigations which are commonly done in SI joint dysfunction, such as blood test, X-ray of LS spine, CT scan, and MRI. Regarding blood test, we choose depending upon the clinical condition of the patient, such as if the young patient comes with SI joint dysfunction, then we usually go to the rheumatological profile. And X-ray are commonly done to see the degree of degeneration of the SI joint. CT scan and MRI are also commonly done. Out of CT and MRI is always gold standard. But simply injecting the SI joint with local anesthesia and getting relief of pain can be a good investigation or diagnostic tool that you may do in your clinic. So these are few X-ray which shows the left one shows the unilateral sacroiliac joint sacroiliitis. In the middle picture, you can see bilateral sacroiliac joint has been involved. And the last one, not only the sacroiliac joint, but if you see the spine, there is bambooing of the spine also. So these are it can be degenerative changes or it can be inflammatory changes like shown in the right-sided picture where the involvement, bambooing of the spine is also there. So these are few MRI changes that you might appreciate in the SI joint dysfunction, where you can see changes in the joint as well as the iliac part of the pelvic bone and the sacral bone. Nowadays in Western countries, bone scintigraphies are also done to confirm the SI joint involvement. Okay. There are various differential diagnoses with pain in the buttock pain, such as like low back pain or buttock pain, such as spondyloarthropathies, radicular pain, facetogenic pain, hip pain, and the various muscles and ligament which surrounds the SI joint might be the pain generators. So regarding treatment option, whenever patient comes with SI joint dysfunction, we always go with conservative management. And this conservative management is usually multimodal. We basically go to pharmacotherapy depending upon the root cause of the disease. For example, if it's a degenerative cause, then we mainly rely on NSAID and SNRIs like duloxetine for a long-term pain management. And the physiotherapy and rehabilitation, which is also an integral part of the pain management, also plays an important role during the initial phase of management. But if the conservative management is not giving good result or if it fails, then we switch to the intervention management. And intervention management also, there are various intra-articular injections that can be given, the most popular one being PRP, platelet-rich plasma injection in the SI joint. Especially this is given in case of degenerative SI joint issues. But if it's an inflammatory cause of SI joint, then steroid injection can be also be given. But if the intra-articular injection is not giving good result, then nowadays radiofrequency ablation has also been done since ages. Previously in late 90s, conventional radiotherapy has started and it was giving good result at that time. But nowadays cooled radiofrequency is also there, and this cooled radiofrequency usually started at late 2020s or early 2010. And since then there has been lots of review article regarding cooled RFA and success of cooled RFA in treatment of SI joint dysfunction. And recently cryoablation has also been used for the treatment of SI joint pain. And I'm proud to say that our Dr. Gautam Das sir has published the first paper of cryotherapy of SI joint. So you can go to the cryoablation where sir has written a beautiful article regarding the cryoablation of SI joint. But my focus today is cooled RFA. So there are lots of, as you can see in the slide, there are lots of papers of cooled RFA in clinical researches in cooled RFA. Some are as a case reports and some are multi-center randomized comparative trials. And there are other articles, there are lots of hundreds of articles in the net who basically regarding cooled RFA with SI joint. So it started in early 2010, and at that time they regarded this radiofrequency as a new radiofrequency ablation procedure. And the latest article that I could find was in 2023, where cooled RFA ablation, like retrospective studies of cooled RFA was done. And in the right side of the slide, you can also see multi-center comparative effectiveness crossover studies has been done. So these are just a tip of an iceberg, but if you go browse the net, like hundreds of articles available of cooled RFA in SI joint. So, and most of the article basically says that it has a very good and excellent pain reduction with cooled RFA. For example, you can see the pre-operative numerical pain rating score was seen, and post-operative NRS score was taken. And here also the patient had initially had moderate to severe pain pre-operatively, but after cooled RFA, 1.5 months after the cooled RFA, pain score decreased to just bearable pain, that is 1.5. And that those patient was also followed up for 2 years. And you can see nicely in the slide also, at the end of 2 years also, the pain, though there was slightly increase in pain from the baseline, but at all time it stayed below 2.5, or basically this means there was a bearable pain up to 2 years. So you can clearly see with this slide also, it provides long-term pain relief in those patients who are suffering from SI joint dysfunction. There is another slide which shows that the comparison between bipolar radiofrequency ablation and cooled RFA, and it clearly shows that there is marked reduction of pain if you compare the bipolar RFA with cooled RFA. In cooled RFA, you can see that most of the patients had more than 50% of pain relief up to 1 year following cooled radiofrequency ablation. And one interesting article that I found, which we tend to skip, is that if you use cooled RFA, the operating time has been half, and the exposure, radiation exposure, as well as that was also 80% reduced. So it is safe for us as well as patient by going for cooled RFA, because we are using less lesions. And this is the summary of the evidence of intervention pain management for SI joint injection, where they have the cooled radiofrequency ablation had 2B plus evidence, which is quite good. It is second to intra-articular steroid injection. Okay, so cooled RFA is basically a safe, minimally invasive percutaneous technique, where we basically go when there is positive diagnostic block, and here our main target is dorsal ramus of L5 and lateral ramus of S1 to S3. So in the radiofrequency, the main principle is that the normal household electric current is about 50 Hertz. It is converted to about 300,000 to 400,000 hertz current. And so there is a massive vibration of the electrode between each other, which produces heat, and that heat produces the lesion. But the beauty of cooled RFA is that here the probe is designed in such a way that there is a running water channel within the probe, which maintains the temperature of the probe at all time. And by this, the advantage is that we can get a bigger lesion. You can see the water, this is the picture of the peristaltic pump of cooled RFA. We put the normal saline there, and there are 2 connectors. So water will flow through the channel, and the temperature is regulated below like at around 60 degree at all time. Okay, so the main advantage of this cooled RFA and this water channeling is that we can put the power in a higher setting. There is no sharing of the structure, so that the larger size lesion can be achieved, and the size of lesion predicted is 6 to 10 millimeter. And another advantage is that there is a distal projection of the lesion also. So here in the picture you can see the comparison between the lesion by the conventional RFA and cooled RFA. You can clearly see the size of the lesion has increased, and there is distal projection of the lesion also. So the accuracy rate will improve massively. And another advantage is the procedure is angle independent, so we can go for the tunnel vision in these cooled RFA technique, which may not be possible with conventional RFA. Okay. So cooled RFA not only for SI joint, it is indicated for lot of genicular nerve like knee, hip, articular branches of the shoulder, as well as in cervical and the lumbar region. So whenever you are doing for cooled RFA, you do it in a sterile operation theater environment. All the emergency drugs, sedative and other drugs should be ready with you. So for the procedure itself, you require a fluoroscope, RF generator machine with cooled unit. And you usually go with minor surgical set, lidocaine, steroid, IV cannulation, and antibiotics. We are basically targeting these dorsal nerve, especially the dorsal rami of S1 and the lateral branches of the dorsal rami of S1 to S3. Okay, so here, as you can see in the picture, we basically go for like a carpet bombing. We ablate the entire lateral branches of the S1 to S3 as well as L5 medial branch. And you can see in the lower part of the this one there is a entry point where we basically target 1, 3, and 5 o'clock position in the left side and 9, 11, and 7 o'clock position of the right side. Okay. And after the informed written consent, it is done under basic American Society of Anesthesiologists monitoring. The procedure is done in prone position in the local anesthesia, and if required, minimal sedation, and always fluoroscopy guided. Here basically there are two main steps. So in the first one, patient is laid a prone position and AP view is taken, and we basically identify the superior articular process and sacral ala. And at the junction between the superior articular process and sacral ala is the location of the medial branch of L5, and the cool LFA needle is directed at that area. And after a lateral view, where we can see the probe is resting between the ala and SAP, and it is also done to avoid accidental entry of the needle into the foramen. After confirmation of the position, we go for the sensory stimulation and go for radiofrequency ablation with 60 degrees Celsius for about 150 seconds. So after ablating the medial branch of L5, then we move to the lateral branches of S1 to S5. So in the third one, you can see AP view of the sacrum with the small dorsal foramen. So in the SI joint, the small foramens are the dorsal foramens and the larger one are the ventral foramen. Here our target is the articular branches coming out from the dorsal branches. Just 1 minute, I'm sorry for that. And after identifying the dorsal foraminas, we basically target the 3 o'clock position in the right side and 9 o'clock position in the left-sided foramen. And after confirming in the lateral view where the needle is resting on the posterior part of the sacrum, we go for the sensory stimulation and go for the radiofrequency ablation. After the initial lesion at 3 o'clock in the right side and 9 o'clock in the left side, we basically redirect the needle. So after putting at the 3 o'clock position, we redirect the needle to 1 and 5 o'clock position. So if I'm targeting the right side, initially at 3 o'clock position, one lesioning is done, then it is redirected to 1 and 5 o'clock position. So the strip lesion along the lateral side of foramen is created at the level of S1, 2, and S3. So, and basically this is it. There are
Dr.
very
Shirish, Dr. Shirish, we have exceeded the time limit. If you
this
can,
is the last
little
slide.
bit,
Yeah. So there are a few complications like pain, bleeding, infection, which is common in all intervention. There can be thermal injury sometimes. Drug allergy is there also. Since we are doing heat ablation, deafferentiation pain is always there. And normal post-procedural care, like a few days of analgesic, cold compression is done. And follow-up, depending upon your institutional practice, is done. About 1 week, 1 month, 3 months, and 12 months is done.
You could wind up with your
Thank you very much.
results.
Thank you very much. So this
Thank
take
you,
home message.
Dr. Sirish. Nice presentation.
Thank you, ma'am.
So, what do you think that the technical pearl we should take from your lecture is? Do you think is it just cooled versus conventional for SI joint, or do you believe the comprehensive coverage, that is dorsal ramus of L5 and lateral branches of S1 to 3 with overlapping lesions, that is more important, or do you think the debate is between conventional versus cooled?
Thank you for the question, ma'am. Previously, the cooled RFA is not available in all the centers, and it is also not many companies are making cooled RFA. Mainly the success rate depend upon, like you said, ablating the lateral branch of S1 to S3, whether it's bipolar or cool. But lots of literature has said that cool is, if present, cool will be better, as the size of lesion is big. There is more chances of getting all the nerve, the articular branches of the lateral side. If you have both, then cooled is definitely the best. But if you don't have that option, as Surabhi ma'am has said, mainly is we have to target the nerve, the lateral branches of S1 to S3 and the medial branch of L5. If you can target that, and if the needling is done near to the nerve, that is good enough. Thank you, ma'am.
So, as per the literature says, cooled also has advantage of improving the functionality of the joint rather than only conventional. So I think that's where the cost effectiveness comes between cooled and conventional.
So there is one study, which US-based study, which shows that those people who are undergoing cooled RFA, the cost was $1,000 less to that of the conventional RFA. And not only that, I've shown in the slide also, for us also cooled RFA is better because we are getting less radiation exposure. The operation duration has been reduced to almost 50% time. So that is also, I think that also accounts for the advantage of cooled RFA.
So what is the number of cases you had up to date?
Up to date, ma'am, I'm beginner, ma'am. I have done only 10 cases of SI joint in last 5 years. I live in Nepal, ma'am.
Pleased with your results?
Yes, sir, ma'am. I'm pleased with my result. I'm pleased with cooled RFA in SI joint, but in knee, I don't have that much of result. I'm very frustrated with the cooled RFA in the knee. But in SI, I'm really happy with the results, ma'am. But because of the economical constraint, many people are not doing cooled RFA. That is the only barrier that I'm having in doing this procedure, ma'am.
So we just conclude by saying that because it definitely shows superior outcomes than medical management,
yes,
I think cooled RFA SI joint can become an integral part of SI joint pain rather than just an optional step with patients with positive blocks.
Definitely, ma'am.
Okay, thank you.
Thank you, ma'am. Thank you.
Thank you, sir. We highly appreciate the time and effort you invested in preparing such an engaging and informative session, sir. Up next, we have Dr. Rohit Lahori, sir. Sir will be presenting on Gisserian ganglion radiofrequency ablation. Sir is director at the Pain Clinic, Jammu, and has various awards and publications to his name in the field of pain medicine. I request sir to take the stage.
Thank you, ma'am. So good morning, everyone. I'm really thankful to organizing team of ICRA who have invited me to here, be a part of a big gathering. So the topic is very close to my heart, the trigeminal neuralgia. So if we go back to the history of the trigeminal neuralgia, you can see that the Aratus was the first in the 2nd century who gave the description of trigeminal neuralgia. He gave the first account of trigeminal neuralgia, which was a bit accurate to the present classification of trigeminal neuralgia. And in then 1756, you had the French surgeon Nicolas, who named it as the tic douloureux. 1773, the Fothergills described the typical features of trigeminal neuralgia, and it is still named as Fothergill's disease also. In 1820, the Charles Bell attributed the disease to the 5th nerve. So this is a small history before we move on to the trigeminal neuralgia. So if we see the epidemiology of the trigeminal neuralgia, the prevalence of the disease varies between 0.03% to 0.3% of the population. And if we see the annual incidence of the disease, we have around 12 cases per lakh population globally. The female predominance is definitely higher. The male to female predominance is 1 to 2, and the mean age is 50 years. And one very classical thing is that this disease is seen more prevalent on the right side as compared to the left side. So we talk about the clinical manifestations. So remember the mnemonics called Socrates. The whole definition lies into the Socrates itself. S-O-C-R-A-T-E-S, Socrates. Socrates defines the S as the site of the pain, O as the onset of the pain, then C as the characteristics of the pain, R is the radiation of the pain, A is the associated symptoms of the pain, T is the time and the temporal relation of the pain, then E is exacerbating and relieving factors, and S is the severity of the pain. So if you see this Socrates word, it defines the whole definition in itself, that how the pain should be there, what are the classical features of the pain that we are going to do in the next slides. So what are the clinical features? The clinical features are, whenever you have to diagnose a patient of trigeminal neuralgia, there are very limited investigations present. So you usually come across the history that tells you that the patient might be having a classical trigeminal neuralgia, idiopathic trigeminal neuralgia, primary idiopathic trigeminal neuralgia, or atypical trigeminal neuralgia. So hallmark is always the proximal and lancetating pain that is usually along the division of the fifth nerve. The pain is usually virtual unilateral, but it can be present on both the sides, and this is very commonly in V2 division. So there are a number of triggered activities that can trigger this phenomena, like chewing, speaking, brushing the teeth, swallowing, touch, face. These or even the flash of small breeze also can accelerate this disease. So if we go back again, so pain is usually very typical to severe and is more pain always in the morning and the daytime, but the night times the sleeps are very comfortable. So pain relief is, you always get a very good pain relief with the anticonvulsant like carbamazepine or oxymazepine, and they are hallmark in diagnosing of the pain also. Because if patient comes to you, you give some anticonvulsant like carbamazepine, the patient is totally relieved, so it itself goes in the favor of trigeminal neuralgia. So patient pain is usually, they have weeks of free intervals also, where you don't find the pain also. So recurrences are common at the site of initial complaints. And if we go for the neurological examination, very limited neurological examination will relieve something like, except some sensory loss on the aspect of the affected area. So burning, aching pain, and they are the features of atypical trigeminal neuralgia. And sometimes these patients, what they will complain you is, they will feel as if there are some tick sensations on the side of the affected area. So if we talk about the distribution of the trigeminal neuralgia affecting, so V1 division is usually around 4%, V2 is around 35%, V3 is around 30%, V1 and V2 combined is around 10%, and V2 and V3 combined is around 20%. We go again to pathophysiology. Very less you can find, but the important thing is, when we talk about the nerve injury, then the central and peripheral demyelination happens, and ectopic action potentials, and that is usually in the sensory nerve roots. So अगर आप इसमें देखेंगे इस स्लाइड में, तो आपको पता चलेगा कि प्रोग्रेशन जो होती है ट्राइजेमिनल न्यूरैल्जिया में, वो कैसे होती है स्टार्ट फ्रॉम इनिशियल टू एंड पे कैसे चली जाती है, इसमें कैसे रहते हैं पीरियड्स ऑफ एक्सरबेशन कैसे रहती है और पीरियड्स ऑफ रिमिशन. तो आप देखेंगे पीरियड्स ऑफ एक्सरबेशन जो है वो बहुत कम होती है इनिशियली, और वही बाद में जाके लेटर कोर्स ऑफ द डिजीज में बहुत ज़्यादा हो जाती है. अगर हम इटियोलॉजी की बात करें, तो इटियोलॉजी में बहुत चीज़ें आपको देखने को मिलेंगी. इसमें इडियोपैथिक हो सकता है, जो वेस्कुलर लूप हो कोई भी, चाहे वो आर्टेरियल लूप हो या चाहे वो वेनस लूप हो, अगर वो टच कर रहा है नर्व को, सो दैट कुड बी इडियोपैथिक. ट्यूमर्स होते हैं पॉन्स में, एंगल ऑफ द पॉन्स में ट्यूमर्स हो सकते हैं, दैट कैन कॉज दिस. देन एवीएम एन्यूरिज्म्स कैन कॉज दिस. इन्फ्लेमेटरी डिजीज लाइक मल्टीपल स्क्लेरोसिस, सार्कोइडोसिस और लाइम्स डिजीज, दे कैन कॉज दिस ट्राइजेमिनल न्यूरैल्जिया. और डिफरेंशियल डायग्नोसिस में भी हमारे पास बहुत सारी चीज़ें हैं. This is not only that any pain on a particular side of the face can be trigeminal neuralgia. We have glossopharyngeal neuralgia, we have the postoperatic neuralgia, we have the geniculate neuralgia, we have temporomandibular joint pains. Many of the times my dear dental surgeons, they refer the patient to me, sir ये temporomandibular pain को हम treat कर रहे थे, तो हमारे पास अभी हमको नहीं समझ आ रहा है. और आपके पास बहुत क्लासिकली कभी कभी ऐसा पेशेंट आएगा कि जो आपके पास आ रहा हो, जो डेंटिस्ट अपने डेंटल फ्रेंड जो हमारे हैं डेंटिस्ट हैं उनके पास गए हुए हैं और उन्होंने 3-4 एक्सट्रैक्शन या 5 एक्सट्रैक्शन करवा चुके हैं वो पेशेंट्स की, और 5 एक्सट्रैक्शन के बाद भी पेन नहीं जा रही है, उसके बाद वो हमारे पास पेशेंट भेज देते हैं, तब तक नहीं भेजते हैं यूजुअली, उसके बाद वो भेज देते हैं पेशेंट के सर अब ये पेशेंट हमको लग रहा है कि ट्राइजेमिनल न्यूरैल्जिया है क्योंकि हमने 5 एक्सट्रैक्शंस करवा चुके हैं, नहीं उसका। सो क्लस्टर हेडेक हो सकती है, जैसे मैंने डेंटल पेन्स के बारे में आपको बोला था, या ऑर्बिटल पेन या साइनोसाइट्स में भी इस टाइप की माइल्ड टू मॉडरेट पेन्स हो सकती हैं। अगर मैनेजमेंट की बात करें, मैनेजमेंट और इन्वेस्टिगेशंस की बात करें, तो हम पहले सबसे बात करते हैं कि एमआरआई इन्वेस्टिगेशंस में। एमआरआई इन्वेस्टिगेशंस बहुत सारी लिमिटेड होती हैं। एमआरआई में एटिपिकल और जो ट्राइजेमिनल न्यूरैल्जिया बहुत कम आपको इन्वेस्टिगेशन में मिलेगा, मगर अगर कोई स्ट्रक्चरल चेंज हो या कोई ट्यूमर हो, वाइट मैटर में कोई लीजन हो, वेस्कुलर लूप्स हो, मल्टीपल स्क्लेरोसिस में आपको कुछ मिलेंगी इस टाइप की इवोक्ड पोटेंशियल्स, आप कर सकते हैं ट्राई, या गुड क्वालिटी। यूजुअली जब भी आप एडवाइस करें कभी भी, इफ यू आर आस्किंग फॉर एन एमआरआई, प्लीज आस्क देम वी नीड अ वेरी गुड क्वालिटी एमआरआई विद 1 millimeter thick sections, और that should be evaluated firmly। एंड अगर आप एमआरआई को देखेंगे तो एमआरआई में आपको यूजुअली क्या मिलेगा, 95% या सेंसिटिविटी मिलेगी और 100% स्पेसिफिसिटी मिलेगी, बट ओनली फॉर द वेस्कुलर कंप्रेशंस, नथिंग एल्स। सो I told you from the very beginning, when we talk about the trigeminal neuralgia, you always have to think that it is on base of the history only that you make an exact diagnosis. So we have one BNI score which tells us when and when not to treat the patient. So what is this BNI score? BNI score is number 1, no pain, no medication. So if there is no pain, no medication. Kabhi pain aa rahi hai, mild pain, we don't give any medication. Number 2, occasional pain, no medication. Number 3, some pain adequately controlled with the medication. Number 4, some pain non-adequately and controlled with the medication. And number 5 is severe pain where you don't get any relief. So when we are moving ahead with the management of the trigeminal neuralgia, so what is the management? It can be medical management, it can be surgical management, and it can be MIPSI. And if we talk about the medical management, you have a lot many drugs, right? I told you from the anticonvulsants, you can do your TCIs, then we have baclofen, so many drugs that can be used in treatment of trigeminal neuralgia. But kya ye sari dawaiyan, are they really working? Yes, initially they do. But eventually they stop working. Then what do you have in your hand at the moment when they don't work? Should we go for a surgical intervention? Or should we go for some minimum invasive procedure that can be much better, safer, and can give a longer duration of pain relief to the patient? So we have one, and that is called as RF, radio frequency ablation of the Gaussian ganglion. So we have a medical management, we have surgical management, and we have MIPSI. So one more important thing is when we are going for this radio frequency procedure, we need to have a very good selection of the case. We don't have to take any patient who is getting some relief with the medicine and you are taking him to RF. So what you have to do is, so medication have not been very effective in a patient is an ideal candidate. Individuals who are not good candidates for surgical procedures or microvascular decompressions, they can be taken for this, or who have typical trigeminal neuralgia. These are 3 important criteria who are to be taken for this procedure. Basic anatomy is again the same. You all have been through this basic anatomy. We will talk about the foramen ovale. So what is more important about the radiofrequency? What radiofrequency you really used to do in these cases? So is it a continuous radiofrequency or a pulse radiofrequency? What is going to give you the better results? I'm not going to the part of the procedure how you are going to do it. The procedures, we all know how we do it. Take the patient, lie down prone, make him a submento occipital wave, give an ipsilateral turn to the RF, then put a needle at the 45-degree. So these are some of the very important things. So needle selection is also very important. So 10 millimeter of needle with 5 mm of active tip is usually used in case of continuous RFO. And this needle is to be placed at the junction of the petrous and clavus. You can see that B and C I have mentioned here. At the junction of this, you have to put the needle. And once you have put the needle, you have to visualize this needle both on the lateral view as well as on the anterior posterior view. So lateral view will give you the depth of the needle, and anterior posterior submental projection will give you exactly the position in relation to the foramen ovale. So anatomical targets are very selected. So if we are doing the V1, the efficiently achieved by inserting the needle in the medial third of the foramen ovale. If we are targeting the V2, so we have to be in the middle of the foramen ovale. And if we are targeting at V3, so we have to be in the lateral third of the foramen ovale. So again, when you are putting the needle there, you have to do the sensory and then the motor stimulation. Once you are passed through the sensory stimulation, you have to do the motor stimulation. Motor stimulation and sensory stimulations, we do one sensory stimulation at 50 hertz for V1, V2, and V3 division, and 0.1 to 0.5 volts. And we are testing for the motor. We usually give 0.1 to 1.5 hertz at 2 hertz, 0.1 to 1.5 volts at 2 hertz. So this is how we do the motor. And once we are done with this, you can inject small amount of bupivacaine along with some amount of non-particulate steroids, and then wait for 20 or 30 seconds, and after that you can do the ablation procedure. So this is, we have done one latest case. I don't know, yes. You can see this. You can see the stimulation also. We have increased. We did the motor stimulation also. See, he's getting some pain, some sort of discomfort, so we have decreased the voltage. Now we come back to the complications. No procedure is without a complication. So there are some complications which are rare and some complications which are very known. So some of the complications are diminished corneal reflexes. They are 5.7% of the patients complain about it. Then we have masseter weakness. There's 4.1% patient complains about it. Then we have anesthesia dolorosa, 0.5%, keratitis, 0.6%, and transit paralysis of the cranial nerve 2, 3, and 6. This is around 0.8%. Rare complications can be permanent cranial nerve 6 paralysis, CSF leakage, carotid cavernous fistula, or aseptic meningitis. But they are very rare. Lot of studies have happened, lot of retrospective studies have happened, lot of meta-analyses have happened, and they have shown very positive results for continuous radiofrequency. They say around 89 to 90% of patients have the pain-free time, and they have been followed up to 36 months. You can go through these studies. They are very, very valid studies, and you can read them. I have put them here. And a lot of RCTs have also been done. You can go through them, RCTs also. You can find a very positive response. So evidence is again 2B plus for the conventional RF, and we can also do the pulse RF, which has 2B. So these are my references. Thank you.
Thank you, Dr. Rohit.
आप usually सुनते होंगे जब हम whenever we travel in a flight ना Indigo, we are very proud to give you an before time Indigo arrival. ठीक है? तो इसलिए मैंने भी आज आपको before time on time arrival दिया. Thank you.
I just have one question for you. There's a recent buzz of combining pulsed RF with low temperature continuous RFT. So does these hybrid techniques show reproducible outcomes in balancing safety and efficacy?
Yes, ma'am. There have been a lot of studies going on right now, and some of them have been published. In fact, one of the studies is by Wangs et al. There's one of the recent studies in 2022. They have done this study combined both on pulse RF as well as a conventional RF, and they have seen very positive response on pulse and conventional RF together also. But these studies need again to be evaluated in the further course of time, Because only if there are very limited studies who are showing these response, we need to do a lot of RCTs and meta-analysis of all these things. So once a lot of positive responses come out of it, then we can accept them.
Thank you.
Dr. Rohit, actually, if the testing is done properly, you can always spare the first division. Corneal anesthesia is very, very less if you take
Absolutely, ma'am. Absolutely, ma'am. The
patience of testing.
This is that. In the very beginning of my slide, I did said that this is one of the safest procedures ever that can be done on the trigeminal
Those
nerve.
testing can be repeated.
Absolutely, absolutely. But one has to be, like, you should be exactly knowing what you are dealing with.
And do you need any short-acting drug during the entry of the needle to the foramen oval?
Now, I'll tell you one thing. We had one complication. I personally met one complication. And that complication was, what we were doing is we had put our needle inside and we had just put, say, 0.2 cc of xylocaine. And abruptly what happened, the patient landed up in shock. And patient had the scissors on the table. And we had a very bad time because even if you have put your needle very appropriately and you see that CSF is not coming, but still then when you are pushing the drug inside, you never know. Your needle must have misplaced by few millimeters, so you never know. So one has to be very appropriate while doing this procedure, even though they are very safe. Any procedure, even though it is safe, you have to be a bit more cautious. No, ma'am. I just gave some local anesthesia before doing this procedure. Best local anesthesia.
So how frequently do you think it is acceptable to repeat procedures? Should our end target be single stage or repeat?
No, not at all. See, in my couple of patients, I have repeated 3 to 4 times also the procedure because you get a very pain-free big pain-free time for the patient. But eventually the pain comes because see, RF is not the treatment part of the disease. Radio frequency is not the treatment part of the disease. You are not going to treat the trigeminal neuralgia with RF. You are not going to treat the trigeminal neuralgia. So what you are going to give him a pain relief for the trigeminal neuralgia. So the disease process is there, so it has to eventually come.
When we started pain clinic and started the work, we started with glycerol. And that had a big safety margin. Never ever you affected the first nerve. But of course that did not stay, that was not there to stay. And RF took over.
Absolutely.
So we have to be a little careful.
So something new is going to come in the future also to take
Corneal
over.
opacity is very difficult to tackle. Very difficult.
Okay, we can take only one question from him.
क्वेश्चन नहीं है. आई अप्रिशिएट आपने जो हिंदी में दिया सबके दिल में पूरा उतर जाता है. यू नीड ए स्टैंडिंग ओवेशन एक्चुअली. प्लीज राउंड अप.
थैंक यू.
और जो कॉम्प्लिकेशन आपने बोला ना, हमारा कॉम्प्लिकेशन एक बार हुआ कि वी पुट ए लोकल इन द पेशेंट. वी वर डूइंग द सिटी कार्डियड एट द टाइम. तो पेशेंट गॉट फेंटेड. वी हैड टू इंट्यूबेट द पेशेंट्स. और वहाँ पे रिलेटिव खड़ा था, वो भी फेंट हो गया. वी हैव टू टेक केयर ऑफ द 2 पेशेंट्स.
एग्जैक्टली. तो आपने हिंदी में बोलने की बात की ना सर, क्योंकि जब भी हम कहीं बाहर जाते हैं, so like I have been to France and then Korea and Japan, तो जहाँ भी हम जाते हैं तो यूजुअली वहाँ के लोग वहाँ की भाषा में ही बात करना ज़्यादा पसंद करते हैं. तो मैं भी इवेंचुअली हमेशा यही कोशिश करता हूँ कि अगर हम यहाँ पे हिंदुस्तान में हैं तो हिंदी भाषा को कम से कम भाषा को प्रमोट करें.
Thank you, Dr. Rohit. And that's the important takeaway from your lecture, from me at least. Let's go to the next speaker.
Thank you, sir, for sharing your knowledge and personal experience. It was both engaging and enlightening. We now welcome Dr. To Chang Cheng, who will speak on microvascular decompression in trigeminal neuralgia. Sir is a neurosurgeon from Malaysia with a fellowship in pain medicine, and his area of interest is interventional pain procedures, along with his passion for primary subject. Welcome, sir, on stage.
Thank you, the organizing committee, for giving this great opportunity. Thank you, Dr. Gautam Das. Today, my topic is a bit maybe not relevant, but I believe is very useful. It's a microvascular decompression of trigeminal neuralgia. Thank you to the previous speaker that enlightened my presentation a lot. Okay, the most important thing is the trigeminal neuralgia is clinical diagnosis. There's no way you can confirm with any investigation. Investigation is only support. So the proper and the detailed history from the patient is the most important and all already explained by the previous speaker. So it's not only pain, he actually disturbs somebody's lifestyle, enjoying how their life is. You cannot even eat properly, talk properly, and drink properly. I think this is the most important, enjoying life activity. So my way of the diagnostic of the trigeminal neuralgia is I always differentiate into whether their facial pain is trigeminal or non-trigeminal. Non-trigeminal can be due to facial tissue pathology, like surrounding sinus, other nervous tissue, and also atypical facial pain. Most important is to rule out red flag condition, that no other tumor that we miss because we treat pain, we always need to rule out red flag condition. And for trigeminal neuralgia, again, we differentiate into primary and secondary. The secondary is trigeminal injury, whether it's unintentional or intentional. Unintental, that your traumatic facial injury. And of course, some other cause like tumor, vascular lesion, symptomatic like multiple sclerosis, herpes zoster. And primary, we differentiate into spontaneous onset, either it's classical or idiopathic, without any conflicting blood vessel. Don't forget there's another condition we call trigeminal autonomic calphalgia. They're normally affecting V1 branch. Sorry. So for treatment of trigeminal neuralgia, of course, looking at the stage of the successful, anesthesia dolosa we consider as failure, painful dysesthesia also the same. Successful is hyperesthesia or there's some numbness over the face. I always tell the patient, numbness is the price to pay and it's not a complication. We never say that numbness is complication because the more numb you have, the less chance you have the recurrence. Of course, ideal is without numbness, but at the same time pain-free. So pathophysiology, more or less, I think the previous speaker already mentioned. So there is a significant number of trigeminal neuralgia patients without evidence of neurovascular compression. And neurovascular compression is commonly seen in asymptomatic individuals. So sometimes we become very doubtful, is the compression is the only reason or more than that? Somebody believes there's maybe some damage of the neuron at the root entry zone. So pathoanatomy is a Harvey cushion who identified there is a mechanical compression and popularized by Dandy. However, there are almost 1/3 or more than 1/4 of patients without any neurovascular compression. So what is the other reason for that? Somebody believes there's maybe some arachnoid tethering of the trigeminal nerve, and some of them believe there's actually some trigeminal nerve atrophy or neuropathy. So the treatment option, medical treatment is always very effective in the beginning, but ultimately they lost the efficacy. So the procedure, we have nerve destruction and nerve preservation. Nerve destruction, we have interventional procedure like a balloon compression, radiofrequency thermocoagulation as explained by the previous speaker, and stereotactic radiosurgery gamma knife. I personally don't do glycerol lysis because I can't find any extra advantage compared to balloon and also radiofrequency. Of course, nerve destruction, sometimes we do internal neurolysis. We actually inject the nerve when they open up and don't find any pathology. So nerve preservation at this point of time is microvascular decompression and neuromodulation. So the option of treating, we compare of the three methods. One is MVD, one is radiofrequency and SRS. The number of patients requiring additional procedure is radiofrequency. And the number of procedures achieve pain relief is significantly higher with the MVD, the RF compared to MVD and SRS. So the numbness also is actually very high in radiofrequency group of patients. And the cost of the treatment, obviously, is the macrovascular decompression is the most expensive because of the surgery, OT usage, and the surgery fee. So at this point of time, everybody is asking, is surgery safe or not? But knowing that with the global population rapidly aging, older adults are becoming the fastest growing patient group. Addressing their unique health needs isn't just a good medicine, it's a future of healthcare. So previously, people believe pain was part of aging, but now people want to live apart from it. So let's say this is the oldest man managed to climb Mount Everest without any medical morbidity. I believe it is safer for surgery compared to a young man can't even climb a flight of staircase. So this is actually a study showing that they compare above 65 and below 65, the complication rate and success rate is equal. Same to the recent study showing that compare 70 above and below is still not much of difference. So the microvascular decompression is a safe, effective procedure for elderly patients with idiopathic trigeminal neuralgia. It is recommended that any patient with idiopathic trigeminal neuralgia should have opportunity to choose microvascular decompression unless their condition cannot tolerate general anesthesia or is a personal preference. So same thing to this, the age is now not really the concern, it's more medical background morbidity. So now, what is the best treatment? Sometimes the more we know, the more difficult we choose. So minimal invasive is always very safe, very difficult to say because sometimes, just like the previous speaker said, sometimes you accidentally may inject the local anesthesia into the intrathecal and cause seizures, but of course the one is treatable. So what is the plan of management here? So of course, myofascial pain block, TMJ block, and also the C2, C3 block, and trigeminal autonomic aphasia is a sphenopalatine pulse radio frequency. I always tell my junior, don't punish a good kid. Ultimately, it will give you produce a bad kid. So unless you are very sure it's a trigeminal neuralgia, idiopathic type, otherwise don't inject the healthy nerve. Otherwise, it becomes naughty, very difficult to treat. Subsequently, tumor removal or balloon compression. Multiple sclerosis, balloon compression. The rest is just a mixture of all. So in the microvascular decompression position, you can actually put them into the supine, turn the head to the opposite side, or park bench position is what I frequently use because there's no neck vein compression, and then exposure is nice. So this is skin incision. Nowadays, we only need to open up about 4 centimeters. The opening of the skull is only need about 2 centimeters. The most important is the right place to put the burr hole, always at the astrium. Skin incision, depending on which part of the burr hole craniotomy you want to do. Normally, we choose the astrium. So after the craniotomy, deciding the craniotomy site, then we do a skin incision, open up the skull, open up the dura. The first thing we need to do is aronoid dissection. It's very important, aronoid dissection, because aronoid actually sometimes is stuck to the cranial nerve. Sometimes if you pull too hard on the cerebellum, can actually injure the 7 and 8 nerve and cause facial palsy and hearing loss. Come to this superior petrosal vein. Do we really need to sacrifice them? If possible, try to save it because there's less than 1% of cerebellar venous infarct. But if you think it's too difficult to preserve, it's better to sacrifice it earlier rather than torn it, because once you torn the vein, intracranially it's very difficult to handle. So after that, identify the compressing blood vessel, separate them from the cranial nerve, trigeminal nerve, and put a Teflon in between to separate them. Hopefully this video can work. Yeah. So they open up cerebellum. Normally we retract superior laterally rather than laterally because you don't want to injure the facial nerve. Dissection of the aronoid membrane. You can see the petrosal nerve is more superficial than the aronoid membrane, the trigeminal nerve. I try to preserve in this case, but ultimately I think I have to sacrifice it because it starts to bleed. I try to take one small branch, but ultimately it's still bleeding, so I try to sacrifice the whole branch of the superior petrosal nerve. Even though there's less than 1% of venous infarct, I haven't met one yet. Hopefully in my whole life I don't see one. So this is the one we try to separate, and then he start to bleed. When you start to bleed, you better sacrifice early. And don't get panic, otherwise you can burn all the other cranial nerve. After we sacrifice, we can see the trigeminal nerve just below that, the very white color nerve is just below that. Then we have to look for any compression blood vessel. Sometimes the blood vessel can be so tortuous and so long, and this is actually go in between the motor and the sensory nerve. That's why the patient have so much of pain. During this procedure, my registrar continued, stop me for further. He said that, are you sure you want to go further? Are you sure you want to go further? He worried about the injury. But the whole objective is to reduce the pain. If you're halfway done, that means the pain will not be resolved. You can see actually pushing the nerve to the opposite side, thin out the nerve of the opposite side. So remember that we are just a peacemaker. You cannot injure both of the party, both artery and the nerve. So we are just a peacemaker to make sure that we separate them without damaging them, and then the pain will resolve. Very rarely I need to continue the medication for carbamazepine or whatever after the surgery. Immediately I off. Somebody, they are worried, they continue for a few more days before we off it, but I off immediately. Normally the patient don't have any pain. You can see how tortuous is the blood vessel. When you lift up the whole thing, you can see the whole thing floated up. You can see how tortuous is the blood vessel. And of course, the previous speaker mentioned about the MRI. MRI can tell us a lot of information regarding whether it's actually worth open up the head or not. So we just put the Teflon. Nowadays, Teflon we try to push the artery away rather than rest the Teflon onto the nerve, because sometimes with the arachnoiditis or Teflon scarring, he can cause the pain again. I think that's all. We go to the. It's about 2 centimeter in the opening enough. So what we mean, sometimes we don't have any artery compression, so we have to look for venous compression. Of course, venous compression, sometimes the outcome is not as good as artery compression. So this show that 82% of the time with the venous compression, we manage to reduce the pain. So when there's no venous compression, no arterial compression, what next? So it's actually paper, some of the literature did mention, they believe it's an arachnoid nerve conflict. Means that the arachnoid membrane actually pulling at the nerve and cause the irritation. So we need to dissect the arachnoid nerve surrounding to make sure there's no arachnoid tethering at the nerve. This is all paper showing. So that is when there's no arachnoid membrane, there's no conflicting blood vessel. Sometimes we can do partial sensory rhizotomy. Sometimes we just use a bipolar forceps just to press the nerve. Exactly same as we actually cause some neuropraxia, can buy patient few years of pain-free. And then nerve combing, internal neurolysis. All this is actually causing some kind of numbness to the face because it's considered is an open destructive method. So this is to show that sensory rhizolysis actually patient is less satisfied because patient have a lot of dysesthesia pain. And internal neurolysis are effective when there's no blood vessel conflict can be seen. So sometimes it's not always surgery is the best thing. I always believe that there are some other better options. So this is a picture showing the balloon and also the radio frequency. So for this patient, the MRI showed there's no vascular conflict, so we choose to do radio frequency. So when this patient having a tumor, excise partially, but go for Kamanai, patient continue to have pain, and this type of patient, I normally choose to do balloon compression because they are not specifically at one branch. Sometimes they involve many branches. At the same time, this patient also complained of some congestion of the conjunctiva, which is actually like a sympathetic component. So I do both. I do the sphenopalatine ganglion radio frequency, and then I carry on with the balloon. Balloon is very important to know that is the pear shape. any shape is not according to this, the efficacy of balloon become very not effective at all. But to do balloon compression, sometimes nowadays I think China have a product with the balloon compression kit. But I believe we can always modify that. I use a Fogarty's catheter, I use a angio catheter. Actually, we can do a balloon compression as well. So in summary, when the trigeminal with clear vascular conflict, microvascular decompression remain the gold standard. The trigeminal neuralgia with vascular conflict by patient high risk or refuse open surgery, consider percutaneous options like radiofrequency and balloon, and also gamma knife radiosurgery. Intraoperatively, no vessel found, perform arachnoid release for the nerve preservation. If needed, then we have to do nerve destruction, like you compress the nerve, internal neurolysis, or partial rhizotomy. When the MRI shows no vascular compression in the very beginning, we can always choose percutaneous procedure or gamma knife rather than open up and realize that we can't do much. So single branch, we use RFA. Multiple branch, we use balloon compression. So knowing that the microvascular decompression is the gold standard, but interventional pain procedures still carry a lot of weight and did help a lot of patients. So this is my last two slides. There is no single best treatment option, but there is always the most suitable treatment option. Another one is nerve preservation is always better whenever possible. Thank you.
Thank you, Dr. To. Okay. So anybody has questions? Okay. So just one confirmation I wanted from you. Like choosing patients for surgical microvascular decompression, do you select patients on the basis of high resolution diffusion tensor MRI that is available now, or do you depend on your intraoperative surgical judgment?
Nowadays, I normally, unless patient is beyond 80 years old, I will actually not going for open surgery because the recurrence rate also take few years, so we no need to risk the patient's life. But 70 to 80, I still suggest for open surgery because they have a long-term pain-free. How to decide is a few ways. One, the MRI showed there's no vascular conflict. So my open surgery threshold become very high. But I have to warn the patient that the surgery may not be helpful. But we can reduce the pain for few years by do some injury to the nerve. If let's say the patient understood and then we all mutual agreed, then I go for percutaneous or gamma knife.
Thank you so much.
Yeah. Dr. Tu, I want to ask you, after Janetta introduced this microvascular decompression, the Japanese school took over and surgeons like Fukushima and all, they made a big hype about it. They thought that all trigeminal neuralgias would be cured by microvascular depression. So what is the percentage of cases, your cases, of TN, which are cured by MVD?
Yeah, that is a very good question. As what we have known already, that's almost more than 1/4 or reaching 1/3 of the patient don't have any vascular decompression. So when there's nothing compressing the nerve, then the surgery by the name of microvascular decompression doesn't make sense. Because there's no compression, how to decompress. And come with another group of people thinking there's an arachnoid membrane which actually tethering the nerve. Then we have to look carefully at the MRI. Is the nerve being bent or not? If the nerve follow the usual course without any pulling, bending, there's no reason there's an arachnoid membrane tethering. Another thing is, I see the paper, they do the surgery of detethering of arachnoid membrane. The picture they show me, I believe more or less they cause some kind of neuropraxia. That also give pain-free, you know. They have to tell us how much numbness the patient have. If the surgery goes very well with the really and the arachnoid membrane tethering, the patient shouldn't have any numbness. Yeah. Thank you, thank you.
Thank you, Dr. To.
Thank you.
Thank you, sir. We sincerely appreciate the high standard of knowledge you brought to our program, sir. Our next speaker is Dr. Rupesh Jain, sir, who will speak on genicular nerve radiofrequency ablation techniques. Sir is a consultant pain physician at Apollo Hospitals, Bhopal, and is a director at Medicare Hospital and Paneka Total Pain Relief Clinic, Bhopal. Welcome, sir.
Okay. Good evening, everyone, and I would like to thanks the organizers for inviting me for this opportunity. So my presentation is on genicular nerve radiofrequency techniques. There are different techniques for performing genicular nerve neurolysis. So as you all know, knee genicular RFA is one of the most promising modality for every pain physicians, and the results are as good as any other interventions, and it is one of the most rewarding procedures in the field of pain medicine. So this is the typical neural anatomy of the knee joint, which is given by the sciatic, obturator, and saphenous nerve. So these genicular nerves can be identified by the presence of the genicular arteries by ultrasound, and these are our targets for genicular nerve RFA. So indication is mild to moderate to severe knee osteoarthritis and patients with failed TKR, patients who are not good surgical candidate as presence of different comorbidities like uncontrolled diabetes, hypertension, failures, and patients who avoid surgery due to some or other reasons, and patients who have previously successful genicular nerve radiofrequency ablation. So knee osteoarthritis is one of the most important indication of performing genicular nerve RFA. There are few contraindications like other interventional pain procedures, but to be specific for knee joint, any acute knee injury, unstable knee joint, chronic pain syndrome due to other etiology which is not identified, the etiology of knee pain is due to osteoarthritis, bleeding disorders, presence of implantable defibrillator, presence of peripheral nerve stimulator, presence of a pacemaker, and any infection. So before performing genicular nerve RFA, we have to give diagnostic nerve block either through fluoroscopic guidance or USG guidance. For fluoroscopic guidance, we have to insert the needle in AP plane till they contact the bone, and needles are moved in lateral fluoroscopy beyond the midpoint of the diaphysis. And for USG guidance, we have to identify the genicular arteries. So these are the typical targets for diagnostic genicular nerve blocks. They are the common genicular nerve targets. And these all nerves, they derive from the sciatic, femoral, or obturator nerves. So these are the fluoroscopic targets for performing diagnostic genicular nerve blocks. Radiofrequency ablation can be performed after successful diagnostic block. So there is a difference between successful diagnostic block and the successful prognostic block. So whenever there is a diagnostic dilemma that the knee pain is caused by osteoarthritis, they like in facet joint, we have to give diagnostic facet block whenever we are in confusion that the etiology of back pain is due to facet or not. So likewise in genicular nerve also, if there is a diagnostic dilemma, then we have to perform the diagnostic block, otherwise we have to perform the prognostic block, especially in cases with thickened synovitis or post-arthroplasty patients. So for more accurate results, there are some few revised targets for both fluoroscopic and ultrasound guided techniques. They can give better results if we target these new revised targets. So for USG guidance, first we have to identify the knee joint in the coronal plane, and then we have to confirm the final needle position in axial plane. These are the different genicular nerves and the revised targets will give you more accurate results like in fluoroscopic guidance. So the purpose of my presentation today is to compare the different techniques, whether fluoroscopic guidance is better, whether USG guidance is better, or there are different conventional RFA, cooled RFA, or pulsed RFA. So we will discuss later on. So post-procedure care, like in other radiofrequency ablations, we have to give ice packs, analgesics for 3 to 5 days, rest for 2 days, followed by gentle movement, and we have to advise them to resume normal functions after 1 week of the procedures, and follow up in 2 weeks, 3 weeks, and 6 months. And we have to reassess the patient's pain after 6 months for repetition of the block if indicated. On follow-up, we have to ask for intensity of pain for NRS pain scales, and we have to ask for functional outcome. So now we will discuss the difference between conventional RFA or cooled RFA. So this is the two lesions produced by the conventional and the cooled RFA. This is the typical large lesion produced by the COOLIF. And when we are comparing cooled RFA with conventional one, the cooled RF prevent the rapid tissue desiccation, charring, and increased tissue impedance because there is channeling of the cold water. The 18-gauge cooled RF electrode will create a large spherical lesion in comparison to the small elliptical lesion produced by the conventional RF. And the actual tissue temperature is more or less similar in both the techniques. And cooled RF, the electrode can be positioned at any angle to make contact with the target neural structure, while in conventional we have to keep it in parallel to the target sensory afferents. So in majority of the studies, they are having positive outcomes with cooled RFA in comparison to the conventional one. Side effects are more or less similar in both these techniques, like misplacement of the needle, unexpected bleeding. There may be allergy, infection, numbness, or worsening of the pain. While I was searching the literature for comparison of these two techniques, I have encountered this article which states the controversies in different techniques. So I have discussed the difference between diagnostic and prognostic blocks. The other one is what are the comparative benefits of using ultrasound versus fluoroscopic guidance. So there were 4 comparative trials of varying quality have suggested that analgesic efficacy of USG guided RFA is either superior or equivalent to that achieved by the fluoroscopic one. And as we all know, that fluoroscopic guidance may be beneficial for patients with high body mass index, that are the morbidly obese patients, and patients with post-knee arthroplasty patients, where anatomical visualization may be more challenging due to the implant. And in these cases, fluoroscopic guidance provides a clear view rather than the USG guidance. And USG guided technique is more cost effective. It is widely accessible to the clinicians, and it is more important for patients with advanced osteoarthritis of knee, where neovascularization around the knee joint is there. So USG provides the real-time visualization of the blood vessels. The space of cannula placement when we are targeting superior-medial and superior-lateral, there is generally adequate space due to quadriceps muscle atrophy. But whenever the patient is a sports person and the muscle strength is, quadriceps muscle strength is more, then if we encounter the needle with the bone, there is a false sense that we touch the bone, but we are in the muscle plane. So there are the chances of injury to the muscles. And USG techniques have minimizing the procedure-related complications, like in other procedures as well. So there is a need for combined approach. So the use of combined technique using both US and fluoroscopic guided is now people are accepting, but still we are not having long RCTs in favor of this combined approach. And integrating both modalities by US and fluoroscopy, they could potentially enhance the accuracy, efficacy, and safety, and making it a promising approach. So there is a strong recommendation against use of pulse RFA for genicular nerve radiofrequency ablation, and there was one study recently published in Indian Journal of Pain by Dr. Gautam Das, the efficacy and safety of conventional and cooled RFA. This study is also in favor of use of cooled RFA for genicular nerve for the long-term prognosis and the quality of the pain relief, because cooled RF can have a larger lesion in comparison to the conventional one. And if there is any anatomical variation due to these large lesions, the genicular nerves cannot be escaped by neurolysis in cases of cooled RFA, but in conventional RFA, they can be spared, and the initial pain relief may be due to the spread of local anesthetic or steroid given in these neurolysis. So cooled RFA provides more significant pain relief and it improves functional outcome, and both modalities have comparable safety profiles. And superiority of cooled RFA over conventional RFA for genicular nerve radiofrequency ablation has been established by this study. That is all. So the use of cooled RFA radiofrequency ablation is still the promising modality for treatment of genicular nerve in cases of knee osteoarthritis. I would like to invite you all for our next conference, that is Delhi Pain Summit on 9th November at Delhi. So I wish you all should join this conference. Thank you.
Thank you, Dr. Rupesh. I just want to bring up the findings of a recent COCOGEN RCT 2025 published in PubMed. So according to that, it says that when it comes to knee osteoarthritis, both cooled and conventional showing equal efficacy at the end of 12 months. But when it comes to post-surgical, that is post-arthroplasty, definitely cooled is superior. So keeping in mind the cost effectiveness and availability, do you think we should reserve cooled mainly for these post-TKR knee pain cases?
So basically you have to give genicular nerve neurolysis for these patients, whatever modalities you are having. You should not wait till cooled RFA is there, because still conventional RFA is the modality of choice in many pain interventions like in genicular nerve RFA.
Yeah, tell me, this RF that you're doing for this, will it totally destroy the nerve? Because I personally have a replaced knee joint, 10 years old, and now I'm getting the pain again. So someone was suggesting, so will it destroy the nerve and produce partial anesthesia?
It is not totally destroyed. The nerve can be regenerated after some times. So in your case, it is yes, modality of choice now, because revision of TKR is a problematic thing in your case. So genicular nerve RFA will be the treatment of choice.
Will there be a flame-shaped anesthetic patch?
Flame shape, burning. There may be local site burning, but usually the occurrence of burning may be subsided within few days. And
So
you
there
can
won't
control
be
it
any
with medication.
anesthesia?
Pardon?
Local anesthesia nahi hoga.
No.
That patch?
No, ma'am, no.
No.
So which are your primary targets? Because now we know that there are at least 10 nerves.
I am giving only 3.
So you're still giving only 3?
Yeah.
Do you give the medial and lateral branches of the nerve to vastus intermedius?
Still only 3.
Apart from medial, lateral and superior, inferior genicle, that's all?
Yeah.
So
okay, because I give at least 5 nowadays.
So the studies you just quoted, Dr. Rupesh, I wanted to know that, like conventional versus cooled.
Yeah, Dr.
How many
Ashok.
nerves or like which all structures are addressed to compare? Cooled versus conventional.
I think 5
3, 5,
lesions,
7.
five
Okay, 5
lesions was there.
Okay.
I want to ask 2 questions actually. One, many of us who are doing conventional as well as the cooled RF, particularly in the knee, whatever data or theory says, we say results are almost equal. So what is the reason why most of us feel that cooled RF is not as good as it is publicized or convinced by the companies, number one. Number two, would you like to do RFA both the knee simultaneously or after some interval? Can you do RFA of both the knees together?
Sir, one at a time. And I think Dr. Gautam Das sir will give the answer why cooled RF is.
You have said cooled RF is better than the conventional RF, but maybe the bulk you have done and the cohort you have made, but most of us feel the results are almost same. It is the number of the nerves you ablate rather than the technique.
Actually, recently we had a study. So there
Sir, I have
we have
quoted
compared
your
the
study,
cooled RF
this.
versus that was the randomized control trials.
I have quoted this.
So results are equal.
Yes.
Only thing is the
quality of lesion is better.
The duration of the pain relief we followed up. So there after 6 months, the conventional efficacy group, their pain started coming back, whereas cooled RF group, they even after the 12 months, their pain relief was continued. So we have followed up till 12 months when we have published it. So it's not that the cooled RF, the conventional RF is not working, never. But you have to keep in mind that both have a very significant failure rate. Very significant failure rate. We can never promise to our patients that you are going to get the results. So at least, study says the failure rate is almost 40%. Means ranges from the 50% to 70% is the success rate. That means if we are making it average, out of 10 patients, 4 patients will land up with a complete failure. So we have to always keep that in mind that it is not a great procedure. If our fellows know that we never do this as a fast the procedure, we always try to regenerative medicine as the fast one, and then this is as a supplementary to give the pain relief to the patient.
Okay. Thank you, sir.
I'll be requesting that, okay, because we are already running so late. Just. Genicular nerve alcohol neurolysis, definitely if it is evidence is created, it can be good. The point against is that very down is all the tibial nerve and the other branches. So that can be a dangerous thing if the drug is tickling down, because we don't have any control once we are injecting. That is the most important concern. But again, those who are doing it, I personally talk some of them, they are telling we are giving very small amount and that is not actually going tickling down. So it can be a good result. But definitely, if the more publications are coming, maybe in the future, the advantage might be the drug is spreading, so it will be catching up and it will be having a larger size lesion like things. But again, disadvantage is it might be tickling down to the area which is not our control. So both the things we have to think, and then finally the study will be guiding us whether we should do it or not.
I have used alcohol at least 10-15 cases. Results is same 40 to 50% success. And the answer lies what we have just discussed, that 40 to 50%. So we have to look for the other causes or other nerve targets to get better relief.
Okay, so you are running late, so we can have the discussion during the lunch.
Yes. Thank you, sir. It was an insightful presentation. Our next speaker is Dr. Hitesh Patel, sir, presenting on splanchnic nerve radiofrequency ablation. Sir is a reputed interventional pain specialist in our field, and he is specialized in spine endoscopic procedures. I welcome Dr. Hitesh Patel, sir, on stage.
Thank you. Thanks to the organizing committee and our chairperson, and thanks to you for introducing me. My topic is the splanchnic nerve RFA. Okay. So what are the indications for the splanchnic nerve RFA? So the most common indication is the cancer pain, in which the pancreatic cancer, gastric cancer, and hepatobiliary cancers, like liver, gallbladder, bile duct, and the retroperitoneal tumors. Non-cancer pain, if we are doing the procedures for the pain management for the splanchnic plexus block, the chronic pancreatitis is the non-cancer pain indications. And the situation favoring the splanchnic plexus over the celiac plexus, so is the distorted anatomy at the celiac level, tumor mass, post-surgical fibrosis, stents placements are there. So the splanchnic is the more favorable than the celiac plexus block. The splanchnic nerves are compromised of the medial branches of the from the lower 7 sympathetic thoracic ganglion. The greater splanchnic nerve is derived from the 5th to 9th thoracic ganglia, with the potential for the contribution from the 10th thoracic ganglion is the higher. The greater splanchnic nerves descends from the paravertebral space, obliquely weaving of the branches to the descending aorta and perforating crus. So the innervates, its splanchnic plexus innervates the gastrointestinal tract from the distal esophagus to the mid-transverse colon, pancreas, stomach, liver, adrenals, ureters, and the abdominal vessels. So how to perform the splanchnic plexus block? So our target is the T11 level. The thoracic 11 is the most common target. In the lateral view, we should be at the junction of the posterior 2/3 and the anterior 2/3. So patient is in prone position, AP images should be there, identify the T11 level, square the inferior end plates, square the inferior end plates of the T11, moves the CM on the ipsilateral side on the oblique, and identify the target. Watch the movement of the diaphragm. Some people are doing it at the T10 level, some people are doing it at the T12 level. So, if the diaphragm movement is at the T12 level, we should go on the T11 level. So, this is the AP images where you can see the end plates, which is not the squared. So, we have to square the end plates, we have to move our C-arm on the caudal side. So, once we have moved the C-arm on the caudal side, we can see the square end plates. This is the spinous process, this is the transverse process, and this is the ribs. So, the transverse process. Now, we have to merge the transverse process with the body of the vertebra. So, we have to put the C-arm on the ipsilateral side. So, once we oblique the C-arm on the ipsilateral side, the transverse process merge with the body of the vertebra, and this is our target point. The target point is inferior or caudal to the rib and lateral to the vertebral body. So, this is our needle placement. This is the needle placement. This is, practically speaking, don't directly jump on the lateral margin of the vertebral body. What I do in my practice, I go little bit more laterally to the vertebral body. If we are jumping on the lateral margin of the vertebral body, the chances that we hit the vertebral body and the posterior part of the vertebral body. What our target should be? We should hit the vertebral body at the junction of the posterior 1/2 and anterior 1/2. So we can avoid the pleura. If we are hitting vertebral body in the lateral view and the posterior part of the vertebral body, the chances that our needle will deviate toward the lateral side after hitting the vertebral body. So try to have some lateral view, try to be enter little bit laterally and goes towards the vertebral body. So the needle deviations on the pleura side of the lung side will be, chances are very less. Once you are here, you can take a lateral view if you want, but final our target is this posterior 2/3 and the anterior 1/3. This is our final target for the needle placement for the radiofrequency ablation, or if we are doing the neurologic procedures, this is our final target point. So if we are doing the RFA, you can put the contrast media. If you are doing the alcoholic or any chemical neurolysis, always put the dye. So the dye spread should be in the anterior 1/3 of the vertebral body like this, no vascular spread. Check in the anteroposterior view. Do the procedure bilaterally to get the good results. So alcohol injection can be done with the 50 to 80% of alcohol. Some people are doing the both level, T11, T12 level, both level they are doing. Some people are, like in my practical practice, I do RFA. Along with that, I usually put the alcohol, 1 ml of alcohol, if there is no vascular spread. Because many patients is terminally ill and there is no second chance of doing the procedure. If RFA work नहीं किया है, we'll do the chemical neurolysis later on. मैं नहीं करता, मैं दोनों एक ही साथ दे देता हूँ. So the radio frequency stimulation is 50 Hz sensory stimulation, conducted up to 1 watt. They should get the epigastric region stimulations. नहीं आते हैं, लेकिन अलग stimulations like the stimulation like girdle-like fashion in the intercostal space, the needle should be advanced. अगर वो नहीं है, epigastric stimulation भी नहीं है, if you are anatomically perfect, you can move ahead and do the radio frequency ablation. Give the motor stimulation also at 2 hertz of the stimulation, 2 hertz, and up to the 2 watt while checking the intercostal muscle contraction. If it is negative, give the 2 to 3 ml of the local anesthetics, perform the RF lesion up to 90 degrees Celsius, 80 degrees Celsius for 90 seconds, turn the radio frequency needle and 180 degree and perform the another lesion. This should be done bilaterally. Chances of the complication, thoracic nerve root injury, intercostal blood vessels injury, discitis. If you are not at the body level, you are at the disc level, chances of discitis is there. Pneumothorax is one of the most common complications we can face, or vascular spread is another complications. So it is always better to watch the patients for a few hours, or it is, if you have the hospital, allow the patient to stay for overnight so you can avoid any dreaded complication like the pneumothorax, aorta or inferior vena cava injury, infection, bleeding, vasovagal reaction. Always give 500 ml of the whatever the saline or whatever you want to prevent the hypotension in this splanchnic flexus RFA or celiac plexus RFA. So the complications for the splanchnic flexus is very rare. If you are doing it the right way, it is very rare. If you are doing it mild wrong way, it is also very rare. So don't be afraid of doing this procedure. This is one of the most common procedure we should learn, like the cervical epidural, lumbar transfemoral injection, splanchnic RFA. My dear friend explained the trigeminal RFA. This is the 4 to 5 procedure, in my opinion, or knee injection, shoulder injections, whatever the injections. These are the really good working and giving the good results. But due to the complications or the expected complications, some people are afraid of doing the splanchnic RFA or alcoholic neurolysis. There is no practical complication what I have seen. I have seen all kind of complications. It's not like that there is no complication in this splanchnic RFA. I have seen the intravascular spread, I have seen the hypotension, I have seen the cardiac arrest in my practice also with the RFA. But this is not a very common that you will face day by day. So it is a very simple, effective procedure. It gives the long-lasting relief. Long-lasting is 6 months, 4 months is a good long-lasting relief. Opioid requirement may drop significantly, or if it may not drop significantly, pain score will reduce. Chronic pancreatitis, yes, you can try. Patient satisfaction is high. And even there is no other alternative for giving any other blocks like the celiac or splanchnic. So in conclusion, again I said, it is the most reliable tool in the pain physician armamentarium, and I strongly recommend considering this in early intervention is always better. Like the patient having the abdominal pain or back pain with the pancreatic or any gastric malignancy, this is always better to go with the procedure. Thank you.
Thank you, Dr. Hitesh. Any questions? Yes, sir. Only one question we'll take.
Sir? Oh, 10 millimeter active tip. Yes, sir. Always you can try for the 15 millimeter also. But the chances of you are in the posterior part of the, so that there is a nerve root in the posteriorly. So the chances of you are near to the dorsal root ganglions for the 15 millimeter. Yeah. Thicker needle is always better, like you can cover the whole area.
Since you are doing the ablation and giving alcohol
Today we
also,
have a patient
it's a
suffering
total neurolysis. So if you really have a phrenic nerve involvement, will it recover?
If there is a phrenic nerve involvement or any dorsal root ganglion involvement with alcohol neurolysis, usually not recover, madam. But in practical aspect, the patients with the splanchnic flexus RFA or the celiac flexus RFA is totally terminal ill most of the time. And but the dye spread is good, so I'll do the alcohol neurolysis. And what I do, if I inject the dye 2 ml, then the spread is not vascular. I'll inject my alcohol only 1 ml. Otherwise, my dye and alcohol will dilute and this makes the volume bigger, and it can spread to the different areas. So practically, it is not giving any complication like the phrenic nerve or a dorsal root involvement. Yes.
So can we say that in malignancies, when the celiac plexus is distorted, can we make this as our first step, the splanchnic RFA, because it's safer, there is no serious neurological, neurolytic complications, and more precise So do you think that this should be our first move?
Yes, ma'am.
Okay.
In my practice, I do it as a first move for any abdominal pain for the malignancy.
Thank you.
Thank you.
Thank you, sir. We appreciate your time and valuable insights you shared with us. Next, we have Dr. Khaja Javed Khan, sir, presenting on shoulder joint cooled RFA. Sir has many awards and publications to his name. He has a gold medal to his name for the FIPM exit exam held in the year 2020. Welcome, sir.
A very good afternoon to one and all present. It's a very wonderful feeling to be back to my alma mater. I did my fellowship over here, FIAPM in pain medicine 1 year, and that 1 year has been the most wonderful year of my life. I'd like to thank Dr. Gautam Das sir for the wonderful mentorship during this 1 year, and it is the love which attracts us back whenever we have to come to a wonderful international conference like this. So with that, I'd like to start my presentation. My topic for today is shoulder joint cooled RFA, and without further ado, I'll be moving ahead. These are the contents of my presentation. We shall start with a brief introduction, have a look at the shoulder RFA targets, a video demonstrating the procedure, a bit of literature evidence, and I shall conclude. Shoulder pain, a very common complaint in our OPD practice when we see. Of course, knee pain is one and shoulder pain is another one which follows along. So whenever we see patients suffering from shoulder pain, it's not just the pain. Most of them come with a restricted motion as well. There is a range of motion which is difficult to move, so they have a lot of difficulty in doing day-to-day activities. And whenever you see these patients, it's very important to find out the cause. So rule out trauma, rule out diabetes, rule out the other causes, rule out the secondaries and then various other differential diagnoses before you make a plan to move ahead with the treatment option in mind. So coming to the relevant anatomy, the shoulder as such consists of kind of a ball and socket joint formed by the union of the humerus, the scapula, and the surrounding structures. That is the ligaments, muscles, tendons, which support the bones and maintain the relationship of one to another. Nerve supply is by the axillary, suprascapular, and lateral pectoral nerves. Coming to the shoulder RFA directly. So what are our targets over here? Our targets over here are going to be the articular branches of axillary, suprascapular, and lateral pectoral nerves. So here we have a picture, right? So do you have a pointer here? Yeah. This one over here is going to be the target for the lateral pectoral nerves, right? Here we have the target for the suprascapular and the axillary articular branches. So here we have a schematic video of demonstration of the lesions where all it is happening, right? So we have the suprascapular nerve. We saw that a needle is coming in now. The rounded structure, what you're seeing is the circular lesion which is formed when you are using a cooled radio frequency needle or a probe. So you get a big round lesion, okay? And for musculoskeletal degenerative indications, having a large lesion is always better. Now we are seeing the axillary nerve, right? And 2 lesions over there. Needle is coming in and the targets. So here what you're seeing on the other side is kind of a C-arm image, a fluoroscopic image of where the needle has to be there for you to do the targets. Of course, we do a sensory stimulation. We stimulate the nerves, try to reproduce the area of the pain, right? And then we do the lesion. Now you just saw it turn. So what it actually means is the patient is first in a prone position and you have to turn the patient to a supine position in this procedure. One of the only procedures where you have to turn the patient in 2 different positions, right? Now, when you have turned the patient supine, you are targeting the articular branches of the lateral pectoral nerves and the lesion happening over there. So we saw, right, the various nerves and the various targets. You saw there was the articular branches of the suprascapular nerve being targeted, of the axillary nerve and the lateral pectoral nerves which are being targeted. Suprascapular nerve, well, here it is. This is how the X-ray image looks like, and this is where the needle has to be placed to do the lesion and the targets. Of course, first stimulation, and then we go on to the lesion. Three principal articular non-motor branches of the suprascapular nerve are the medial subacromial branch, the lateral subacromial branch, and the posterior glenohumeral branch, all which have been named as such. So here you can see those different branches, right? The lateral, the posterior, and then the medial, where all they are going and supplying. Anterior and posterior views. Distal articular branch targets are there, like for suprascapular nerve. Okay, these are the one, the lateral subacromial branch, the posterior glenohumeral branch. Suggested landmarks we have, that is zone A, zone B, zone C, and zone D. Zone A, we are targeting the suprascapular nerve, lateral subacromial, and the posterior glenohumeral branches. The zone A landmark is posterior glenoid neck, upward 2/3 to half, lateral to the spinoglenoid notch. So here I want to go back to this, and we are focusing over here for zone A, right? Coming to zone B, here we are targeting the axillary nerve, ascending humeral branches, posterior, lateral, inferior aspect of the greater tubercle. That is zone B, which is zone B, right? Then the lateral pectoral nerve, ventral or superficial midpoint of the coracoid process, that is zone C, over here. And then the zone D for the upper subscapular nerve articular branches, that is superior, anterior glenoid neck, just medial to the base of the coracoid process. Okay. Now, axillary nerve, these were the targets. This is the C-arm position. This is the position for the needles to be placed as well. This is for the lateral pectoral nerve when the patient is turned supine and you have to target the coracoid process. Coming to the video now, you can start. Today we have a patient suffering from severe shoulder osteoarthritis. You can see this X-ray of this patient, wherein you can see the shoulder joint is grossly deformed and deranged because of the evident shoulder osteoarthritis. For the shoulder joint, the radiofrequency ablation is a novel technique wherein the painful nerves around the shoulder joint are identified and ablated. This cool radiofrequency ablation helps in bringing about pain relief to such patients suffering from shoulder osteoarthritis. So here we start off first with sterile prep and drape. That's the cooled RF probe, right? So this technique is a fully ultrasound guided technique. Of course, made it a bit hybrid with a bit of CM shots in between, but we targeted most of our targets using the ultrasound machine. Close to the spinoglenoid notch there, we are targeting the articular branches of the suprascapular nerve. Here in between the C-arm for the hybrid approach, just taking shots. That's the cooled RFA machine and the probe there for the lesioning. Local before the lesion. Now going towards the axillary part, just forming a track. Bit of an effusion there, which we had aspirated as well. You can see the needle track there. That's the lesioning happening. Now we have turned the patient supine for the lateral pectoral articular branches. So you can see the needle there on the coracoid process. The lesion starting. Giving some local for lesioning.
Today we have a paper.
Coming to literature evidence now. So this was a study done by Orhurhu and Akinolo et al. For RF ablation for management of shoulder pain, wherein they kind of confirmed that all prospective and retrospective studies review suggested a potential benefit of RFA in treatment of patients with shoulder pain. There was a systematic review and meta-analysis as well of the RF procedures for denervation of the shoulder joint, wherein they confirmed that targeting the sensory innervation of shoulder joints affected by degenerative conditions had a potential to reduce pain. Complications during this procedure could be pain during needle insertion because the RFA, cooled RFA needle is a fat needle, right? So it can be a bit of pain, even if you give some local. Bleeding can occur, loss of sensation along the distribution of axillary lateral pectoral or suprascapular nerves, infection risk if strict asepsis is not followed, soft tissue injuries and neuritis. So to conclude, radiofrequency ablation is a novel treatment option for chronic painful conditions of the shoulder. Cooled RFA has a larger lesion size compared to conventional RFA, theoretically as well, and even systemically if you see. So it's definitely an effective tool in the arsenal of a pain physician. I'd like to conclude my presentation here. Thank you very much for your patient hearing.
Thank you, Dr. Khan. Do you think that we still are yet to have strong evidence of cooled RFA for shoulder, unlike knee and hip? If that is the case, is it because we are dealing with different phenotypes here, more varied, like arthropathy, cuff arthropathy, osteoarthritis, post-surgical arthroplasty? So you think it works equally in each and every phenotype, cooled?
So basically, the RFA as such, what I feel, for the shoulder pain, we have a plethora of options, of treatment options. And the different treatment conditions, we have regenerative options to go with, and we have the other surgical options also to go with. But I believe for shoulder joint especially, the RFA is relegated more towards a certain set of patients in whom none of these can be tried. So I would keep it as a last resort, and definitely the evidence still has to come because a lot of RF has been done for the other joints, be it hip, be it knee, or even for sympathetic plexuses. But for shoulder, it's not being done much.
Thank you so much.
Questions from the floor? I want to ask you one question.
Yeah.
With the relief of the pain, does the mobility of the joint increase?
So this is more of a palliative procedure,
It's a
ma'am.
tenosynovitis, basically. Basically, it's a tenosynovitis.
Yes.
Which restricts, which produces the frozen shoulder. So
Okay.
does the mobility increase?
So if you are planning for a frozen shoulder, then we have the other interventions like hydrodilatation to improve the mobility. This was the case of chronic osteoarthritis of the shoulder. So it's a palliative procedure to reduce the pain. Mobility part, yes, with physiotherapy and rehab, we can expect little bit, but not much of mobility increase.
No, when the pain reduces, naturally the patient can move the limb better.
Very true. If the mobility is being hampered, if because of the pain, then it will improve. If it is because of the mechanical issue itself of the joint, it will not improve much.
Javed, one question technically. You said for suprascapular and axillary,
Yeah.
patient was lateral position
Yeah.
with the joint upside, okay?
Yeah.
And the view is lateral C-arm view to confirm needle placement.
Yeah.
And the hand is flexed or straight?
See,
Because there will be a lot of clouding of the
Yes,
structures, not
yes.
like AP view. So.
Correct. Ideally, if you seen, ma'am, correct, you told that the patient was in lateral. Ideally, the patient should be in prone position. This patient could not lie down prone at all because of the severe amount of pain. That's why we had to go with a compromised view of the C-arm as well. Otherwise, prone and AP is the best.
Okay, thank you. Let us go to our next speaker.
Question.
Oh, one last question. You can speak a little louder, yeah.
So my question is, how do you specifically select the articular branches of axillary nerve? Because that one is really tough.
Yeah.
And
So.
mostly you are doing cool RF, so there is a high chance that you are going to involve the motor nerve.
Very true. Especially for the axillary nerve, I feel it's somewhat similar when you are doing the operator nerve for the hip. It's very close by, the motor branches. So you have to rely on motor stimulation, on the sensory and motor stimulation when you are doing. Try to see that you get almost nil motor stimulation when you're doing for the axillary nerve, and then only go ahead with the lesion. Especially if you're doing for cool, you have to be very careful. Sometimes if it becomes difficult to differentiate between the two, then better not to do a cool, you can do a pulsed.
There is one technique that if you are doing it in under ultrasound, that when you see the vessel, you try to move your probe little lateral so that the vessel actually goes up.
Yeah.
And then you do the stimulation there. That
True.
is one technique that you can follow, but most of the time the motor actually stimulation comes up.
Yeah.
That I personally faced.
That's a very nice addition to that. And very true. Other thing is confirmation should always be with stimulation. Be irrespective of the technique what it is. The stimulation is the only thing which can help us to avoid motor weakness.
Thank you. Thank you.
Thank you for your inputs.
Thank you, Dr. Javed. That was very fruitful, practical insight. Thank you.
Thank you very much for the opportunity. Thank you.
Thank you, sir, for a thought-provoking and well-delivered talk. To conclude this session, now I welcome Dr. Pratibha Mache ma'am, a pioneer in interventional pain medicine, who will present on pulsed radiofrequency in neuropathic pain. Ma'am is head of pain medicine unit at GSS Medical College, Mysore, and ma'am has several publications and book chapters to her credit. Welcome, ma'am.
So good afternoon, everybody. It's always a pleasure to come for ICRA. And I can see that all of you are waiting for the lunch, and this is a pre-lunch session, and you will have to bear with me for next 10 minutes. I'm also talking on a topic which, like if I have to take a quiz, I have to say that, who am I? I'm a new person in the market. You have been talking all these days, like the whole session was talking about the most advanced things, like the conventional radio frequency, the cooled radio frequency, and now I am, who has just entered. There is not much of evidence. I'm going to talk from my personal experience and a little bit of evidence that is there in the literature. So I bring greetings from JSS Medical College. That's my hospital where I work in Mysore. And I'm really thankful to the whole Daradia team, Gautam Das sir, and the whole team for giving me this opportunity. So we know that neuropathic pain disrupts the quality of life, and it's very difficult to treat. And we have a lot of neuropathic disorders we do deal with in our pain practice. Electrical stimulations have analgesic effect, and have several types of electrical stimulations have been used in pain management. And of these stimulations, radiofrequency is found to have an analgesic effect similar or better than the corticosteroid effects. Conventional radiofrequency and pulse radiofrequency are the two forms of RF technology. Goes without saying that cooled one is also there, but most commonly not everybody has an access for cooled. So these are the two technologies which are very commonly used in clinical practice. CRF creates a thermal lesion by heating the tissues to a neurodestructive temperatures of 60 to 80 degrees centigrade, whereas the PRF employs short bursts of current at lower temperatures of 42 degrees centigrade. Now, little bit science of pulse radiofrequency. We give the high frequency current here with the pulses or the short bursts of 20 milliseconds per second, followed by the resting period or the complete silence of 480 milliseconds. During this complete silence, there is no current applied, and this allows the time for the heat elimination and maintains the temperature of the target tissues below the 42 degrees centigrade, which rarely causes the nerve damage. That's the reason why adverse effects that can develop with the CRF are not seen with PRF. And that's how the PRF creates an intense electrical field around the target nerves, causing analgesia, while keeping the temperature lower than the neurolytic levels. And it is known to have a very good analgesic effect. And therefore, it is used in various neuropathic pain conditions. It can be widely used. Now, when I was actually preparing for the talk, I never knew what is the mechanism of PRF. I only knew that CFOS genes and a very vague idea I had. And when I had to prepare this talk, I really went into the details of mechanisms. I was very curious that how does this pulse radiofrequency work? And then I'm going to put that in front of you. Earlier, when it was introduced, it was supposed to reduce the pain by the long-term depression of the pain signaling, which is done by the C fiber mediated spinal sensitization, which prevents the signal going from peripheral to central nervous system. But subsequently, there were some animal studies that were conducted to determine the pain reducing mechanisms of PRF, which included the changes at the molecular level, which includes the decrease in the microglial activity, which decreases the inflammatory cytokines and chemokines, which acts at the both spinal cord and the supraspinal centers. There is also reduction of the pro-inflammatory cytokines, which they have studied, a lot of people have studied after PRF, what are the levels of interleukin 6 and the tumor necrosis factor alpha. There will be a reduction in this when PRF is used. Also, there is an increase in the level of endogenous opioid precursor mRNA and corresponding opioid peptides, which also exert an analgesic effect. There is also change in the neuronal activity by the active enhancement of the descending inhibitory pathways and inhibition of the excitatory nociceptive C fibers. There is some anatomical change that is happening, that is microscopic damage of the nociceptive nerves, which will cause the disruption and the closure of the ion channels and changes in the thresholds, and this blocking the conduction of pain signals and generating the analgesic effect. I know that you are too many activities. Now let us come to the practical part of it. So why pulsed RF? Pulsed RF is very safe in the locations where CRF may be potentially hazardous. Just now I heard Javed saying that in case you are in doubt, or in case you are targeting some motor nerve and you are not sure that you are in the correct place, there is a doubt about you, then you can always go for the pulsed RF because it is much, much safer, and I think it is sometimes become unforgiving when you are giving the conventional RF for the motor nerves. So it would be much more and safer option to use PRF. So that's how it is becoming popular. What are the advantages? Why it is becoming, though it's new, it is a lot of people have started using PRF. Why? Because it is virtually painless, because there is no heat generated. There is no destruction of the tissues, no nerve damage because the temperature used is 42 degrees centigrade below the neurolytic levels, and no inherent risk of the possible neuroma formation or no deafferentation pain. The absence of thermal damage, unlike in PRF may increase the safety of the procedure. There are no side effects of the medicines. So that's why it can be used as an alternative in patients where you can't use steroids. Like if there is a patient with uncontrolled diabetes and you have to do it. So you could definitely avoid the side effects of the steroids, and alternatively you could use PRF. And in long run, you may find this is a cost-effective option. So definitely, though we say it is safer, it is not without any limitations or disadvantages. So it will not work immediately. It has its own delayed effect, and major, I think, limitation would be the shorter duration of effect, which we compare with the conventional RF. And you can't, like when the patients ask us that how many days or how many months it is going to last. So you can't tell exactly that what will be the duration, but we can always safely say that it is a 6 months duration that it will last. And not uniformly, in all the conditions, you can't guarantee that it is going to work. So some of the condition it may work. So there is no uniformity, or there is no, like even for the conventional or cooled RF, just now we discussed that there is a 50% failure is there, 30 to 50% failure is there. So no doubt that even for pulse, we can't have that guarantee. And there are lack of large multi-center RCTs, and the mechanism is still not fully understood. So indications, it is used in many of the neuropathic pain syndromes, like trigeminal neuralgia. You can do a Gasserian ganglion PRF or peripheral branches, which I have done many, like peripheral branches where it is not possible, where there is a contraindication. I'll come to that. Then again, post-herpetic neuralgia is another condition which I do PRFs very, very regularly. Occipital neuralgia, cervical and lumbar radiculopathy, the DRG PRF, I have done a study on that, and peripheral nerve entrapment, or suprascapular, intercostal, and pudendal nerves. Diabetic neuropathy, it is coming, there are upcoming studies. It is still been studied, it is not, there is no established evidence for that, and in CRPS as an adjunct role. So as I said that I have done a study wherein it is yet to be published, but we compared the DRG PRF for the lumbosacral radiculopathy in the disc prolapse, wherein one group received the DRG PRF combined with TEFC, and another received only TEFC. So we did not find, there are a lot of mixed results in this, but we did not find any significant effect of adding DRG PRF to TEFC. But definitely, what we realized that the patients have the quality of analgesia was much better in patients who have received the DRG-PRF. This is another case. This is a child who had received an IM injection of diclofenac for fever, and he landed up into the post-traumatic, post-injection sciatic neuritis. Severe pain. The child was like completely, very resigned, had stopped. He came after 15 days of this injection, wherein he was shown to neurologist. Everybody had seen him. And then nobody could do anything. He was not able to go to the school, not able to sleep. The parents were really worried. And then here, after explaining all the risks, because already the parents were very, very angry with the doctors and the hospital that the IM injection has caused this problem. So when I was planning for a sciatic nerve PRF, then I did not want the medical legal, definitely things have to be kept in mind. I explained the parents that it may work or may not work. I'm not sure about that, but definitely we can try, because if it works, then the pain relief would be good for him. So with that explanation, I have done the sciatic PRF at the gluteal level, proximal to the lesion. He had already got an MRI done. So he had an excellent pain relief. I wouldn't say immediately there was a relief. Before that, I had already given the desensitization as well for him. And maybe 1 week to 10 days, the relief started. And I followed him up for 3 to 4 months, and he had completely recovered. So this is also, I have also done, this is way back when ultrasound was not there, and I used to do the stellate ganglion block with using the fluoroscopy. I also do lot of pulse radio frequency of the supraorbital nerve for herpes ophthalmicus. So we get lot of cases, and this is one condition I can vouch that it really works wonders. I have patients with 1 year follow-up and with wonderful results. Also, I have used the stellate ganglion RF for the Ramsay Hunt syndrome. which has worked very well, which is a variant of herpes. This is another patient with a brachial plexus injury where extraforaminal PRF or C6 nerve root was done, but I would say it was a short-lasting result, and the patient came after 1 and 1.5 months, the recurrence of pain was there for him. This is another condition which regularly I do suprascapular nerve PRF, which is done mainly for analgesia as well as an adjunct for rehabilitation. I do pass the suprascapular catheters, but also I do the suprascapular nerve PRF, which is done for the rehabilitation, to facilitate the rehabilitation. Then these are two interesting cases that I have. This is a lady who was pregnant and second trimester of pregnancy, and she had come with severe trigeminal neuralgia. There was no doubt that we couldn't do any, she was not willing, plus we couldn't do the RF ablation. So we gave the peripheral nerve mandibular PRF, and she had very good relief. And then later, another patient who had, this was a first trimester of pregnancy, she was literally not able to eat, very severe pain, and after the PRF of the mandibular nerve block, she had very good relief, and after the delivery, maybe 2 to 3 months after delivery, we did an RF ablation for her. This is again the herpes ophthalmicus, and this is an interesting patient who had the herpes pain, thoracic herpes pain for 8 years. He was admitted by the physician for vomiting and diarrhea. He was never wearing the shirt, so the physician asked him, and he saw the patch, and then they referred to me saying that if you can do something for the patient. So we did an intercostal PRF for him, and after 8 years, his son came and told me that the first time he allowed his grandchildren come near to him. Because he had such severe pain, he would never wear shirt. Even for the functions, he would, wrap around the cotton cloth, and that was like something very satisfying and gave a good relief. So these are another 2 patients whom it is an interstitial lung disease, where you can see that the patient is impossible for her to even lie down. She was on oxygen, home oxygen. This patient came with an trigeminal neuralgia, V1 division she had. We have done an PRF for this patient. This another right side patient, she was a long-standing case of trigeminal neuralgia on Tegretol. She developed bone marrow suppression with the Tegretol, and then we had to do, she was very keen on getting the procedure done. So for her to, till the counts came back to normal, I did not want an RF ablation to be done when the counts were so low. So I did an PRF, and then once the counts came back, we repeated an RF ablation. So I just wanted to give my opinion or the condition where I do PRF, because I do it extensively. This is another case of scar neuralgia, wherein ilioinguinal, iliohypogastric PRF was done. So now coming to the evidence. So in the literature, so there have been studies which are done. This is like one observational study which is done on 57 patients suffering from chronic headaches, all types of headaches, migraine cluster, tension, and occipital neuralgia. Both the PRF of both the occipital nerves was done after the positive diagnostic block, and they found that the number of headaches per month and NRS was significantly reduced at 6 months. So it can be used as a very good option. The occipital nerve PRF can be used or in the chronic pain headache disorders. This is another systematic review wherein they have found, but there they had doubts about other types. They found that only the occipital neuralgia and chronic migraines, it worked well. The other things, they had their own doubts. So this is in the cervical or in the disc prolapse DRG PRF, where it was beneficial. Then cervical medial branch for the cervical facet problems. Then this is, I'm just going to rush through the studies in where all it is being used. So here it has been used in cervical radiculopathy, where they have done for C5, 6, 7 level PRF. This is for the supraspinatus tears, where the PRF of the suprascapular nerve was done. And all of them, whatever I am showing the studies, they're all with the good results of 3 to 6 months follow-up. This is one very interesting. I was really looking. I have a lot of interest in diabetic neuropathy if something can be done. And there is no literature. This is just the literature which has come 15 days back. And they have found that there is if you do the posterior tibial nerve PRF in the management of diabetic neuropathy, though the evidence shows that it is not so much of improvement, but still there is a scope for studies. Then, as I said, for the trigeminal neuralgia, you can do the peripheral nerve blocks. It is also studied for the post-surgical arcalgia, intercostal neuralgia for the post-surgery, and also 2 case reports in tarsal tunnel syndrome, superior cluneal nerve entrapment, and sural neuralgia. I'm just putting the evidence in front of you. Now, just little 1 minute extra I'm going to take, that there is an emerging evidence that you can do on high voltage and extended duration PRF. So that is shown to have a good results in addition to comparing to what we are doing at 42 degrees centigrade and 120 seconds, that is a standard practice which most of the people follow. I do it regularly for 600 seconds, 300 cycles. Now, after studying and after having an evidence, I have shifted my practice to 600, that is 10 minutes minimum for all the PRFs. So here there is a study wherein you can do an extended duration PRF for 8 minutes. It was done, and it was done in patients with the refractory meralgia paresthetica. So they found that the results were very good. And another study, most of the studies for the high voltage and extended duration PRF are done in the herpes zoster or post-herpetic neuralgia, where they have found that the voltage, when it is increased from 45 volts to up to 90 voltage, the improvement or the duration of analgesia is improved, as well as the duration which is increased from 120 seconds. Some of the studies have up to 600 seconds. Some of them have studied up to 15 minutes, that is 900 seconds. So these are the studies which have been shown that extended duration and the high voltage PRF can increase the duration of analgesia for longer duration. So to summarize, PRF is an effective and safe method in, if you choose carefully in the neuropathic pain conditions. You have to really choose the patients carefully, and the diagnostic blockade would be better to go before you do it. And despite use in clinical practice for more than a decade, I would say that there is still no clarity. So whatever is your personal practice, whatever evidence is there, you will have to develop, when you are using a PRF in your clinical practice. And there is a lack of research evaluating the effectiveness and the safety of high voltage PRF. And there is still, I think there is a long way to go, and we have to find out maybe other parameters may come in future, like pulse frequency, pulse width, temperature, and treatment time, and which could attain more satisfactory effects. And this has to be studied further. Thank you so much.
Thank you, Pratibha ma'am. So as you rightly said, research till now says that we are preferring pulsed RF because of neuromodulation without neurodestruction. But I am also a big fan of pulsed RF, especially post-herpetic neuralgias, CRPS, I get good results. But evidence, as far as it goes for DRG, cervical evidence is there, but lumbar, which I also do regularly and get good results, though I haven't published yet. I have good number of cases. I'm looking forward to your case study, because till now there is mixed result for lumbar DRG.
Exactly.
Yeah, thank you, ma'am.
Thank you.
And it should be very helpful in diabetic neuropathy, because if it permits vasodilatation because of the neural block, it will produce vasodilatation. It should help immensely in diabetic neuropathy, shouldn't it? You mentioned diabetic neuropathy.
So diabetic neuropathy, we don't have much evidence, but maybe I think we should be getting few more studies wherein we can say that whether it is going to work or not, and how much duration it is going to work. Thank you.
Thank you, ma'am. It was a wonderful talk. We look forward to future opportunities to learn from you. Now I would request all the chairpersons and speakers to gather on stage for a group photograph. Thank you, speakers and chairpersons, for joining us and for being an integral part of this year's conference. Now I request all delegates and faculties to head for lunch and request you to be back by half an hour, as we'll be having exhibitors for demonstration by the company personalized of Stryker, Avanos and GE company. I request Dr. Gautam Das sir and Dr. Krishna Podar ma'am to come on the dais to unveiling the product.
continues to guide the future of pain management. Okay. To begin with, it is my proud privilege to invite Dr. Pankaj Surang sir, a stalwart in the field of pain medicine, whose groundbreaking contributions have shaped modern pain practice. Sir holds multiple distinguished qualifications and is a recipient of multiple prestigious awards worldwide. I welcome you, sir, on stage. Dr. Pankaj Surang, sir. Respected legends, I will not go into the details of your achievements because it will take the entire, the conference will end. So I will just welcome you all. Welcome, sir. Our next guest is a scholar and a healer, Dr. Karthik B. Natarajan, sir. He has a very impressive academic journey. Sir has contributed immensely as a teacher and a clinician in the field of pain management. It is my privilege to welcome you, sir, on stage. Some people collect degree, but few transform them into excellence. Dr. Gaurav Sharma, sir, stands as an inspiration in our field. May I request Dr. Gaurav Sharma, sir, to please join stage with us. Dr. Gaurav. I'll call him. Okay. It is my pleasure to invite Dr. Madan Pandyan, sir, a guiding light for young pain physicians. Please join us on the stage, sir. To invite on stage Dr. Krishna Podar ma'am, esteemed President of Indian Society for the Study of Pain. Ma'am has been a torchbearer in the field of pain medicine, contributing immensely through clinical excellence, academic leadership, and tireless effort to improve patient care across the country. Thank you, ma'am, for gracing the stage. May I now invite Dr. Sunita Lawange, ma'am, a renowned pain physician whose decades of clinical wisdom and teaching have guided countless physicians, to kindly join us on stage. Thank you, ma'am. Lastly, it is my proud privilege to invite on stage Dr. Gautam Das, sir, a true pioneer in the field of pain medicine in India. Through his visionary leadership, tireless dedication, and passion for teaching, he has not only advanced the science of pain management, but also has inspired and mentored countless physicians across the country and worldwide. So please grace the occasion. I invite sir to moderate this session. Thank you, sir.
Good afternoon. Post-lunch session. So we kept it intentionally in the post-lunch session so that there will be no boring academic session. So we'll be discussing something, whatever we are doing, or we'll be doing for these 2 days or 3 days. So here, most of them who are sitting here, everybody knows they're exclusive pain practitioners in India who are basically, what was announced, that they have inspired lots of pain physicians who are practicing pain. So I'll be just asking some of the questions, and let me start with Krishna, President of ISSP. Okay. So my question is that why you was inspired to be a pain physician rather than becoming well-known anesthesia practitioner?
So if I repeat my history, credit goes to you also, Gautam. If I really say, most of the people know it, but I was really very good and top anesthesia practice. He knows. So he came one day and I was doing some regional anesthesia conference, labor anesthesia. That was also not very common here in Calcutta. I was the first who was doing labor anesthesia and doing the workshop. He came, Krishna, I'm Dr. Das, there is some chronic pain. I saw him like, what? I don't know, I'm not interested actually, because I told, I think, same sentence, I'm not interested, Gautam, because I was not thinking for anything other than anesthesia. I was so busy. I was doing labor anesthesia, but I was so busy. Then he said, Dekho, it will is done by the others and all this thing, and it is the future of anesthesia. फिर बोला okay we'll do one conference. Okay, I say one conference. That I'm happily, because maybe it's my one of the hobby doing. Okay, I will do conference. That is okay to me. And he called. I heard the lecture by Dr. Daradia, and that day I was bit known about the pain. It is 2004. It is 2004. So I heard. Then I went to my hospital. I said, you know, we do the pain, chronic pain. If any patient you have, tell me. And I was so excited. So one of the urologists told me, okay, I have one very bad cancer patient, Krishna, if you can do anything. I just give an epidural, what I am used to do. I saw he's having pain. I called him, I done the epidural. And after giving epidural, I given the pump, elastometric pump with the local anesthetic and fentanyl. Next day, believe me, in hospital, 10 people came to me, party of that patient. And he was just, madam, yesterday my brother or my son, he slept without pain. For so many days, he couldn't sleep, so pain. I thought, I give cases in anesthesia where patient has 20% ejection fraction. It is not done by any anesthetist. He came long way, and next day surgeon came with the sweets. Krishna, for you, because you done the case. Otherwise, I cannot do the lap chole without you in the 20% of the ejection. But party didn't know me. They never came to me saying, thank you, doctor, you have done my anesthesia so that my surgeon operated. But here I have done same thing, epidural. Then I got interested. Then I said, Gautam, I am coming to you. We'll learn. Then we started here, our state branch, leaving Dr. Bibu Kalani Das is so great. She also helped us.
Thank you for sharing.
So it is my journey to be pain physician from the anesthesia, totally pure anesthesiologist to pure pain.
Okay, I'll be asking the same question to all the panelists. So get ready what you are going to answer.
So my journey is also like as Madam said. So I was also an anesthetist, and when I working as an anesthetist, so actually my interest before taking anesthesia was orthopedics. I always wanted to be an orthopedic surgeon, but I was in army and I couldn't make it in orthopedics. So I took this anesthesiology, and after doing some anesthesia work, then my interest started delving into the critical care. Then I shifted to the critical care. But in critical care, same thing happened as Madam said. There we are doing everything, right? In critical care, how do we manage patients, critical patients? But at the end of the day, a MD medicine who comes and he takes all the credit, everything, right? So I thought this is not a good thing to do. So I should have my own patients. This is where I started thinking 2005, 2006. So that time I decided I should go into the pain medicine, because that time it was very new and it was just coming up. We used to hear that yes, in USA it is doing wonderful, in UK they are doing wonderful job in pain medicine. So that was the time I decided I should have my own patient, and then I started shifting towards the pain medicine. So this is how I started pain medicine.
So but the question is basically still you started 20 years back, you, Krishna, most of you, but still the anesthesiologists have this question, shall I be able to sustain? If I am doing pain, shall I be able to sustain? So what is your suggestion or advice to the
definitely this was the question that time also, 20 years back also this was there, and I'm sure that most of us, we left our anesthesia practice, a roaring practice in a good setups, we were working in a very big setups, and we left that time, and I'm talking about 20 years back, when there was almost nothing. There's no backup to us also. But now we should not be worried, the youngsters, they should not be worried, because they have a lot of opportunities. They have a lot of opportunity to learn the techniques. And especially, you have backup also. You have a lot of senior pain physicians who are there to support you. So, financial wise, I don't think it is a big issue now, because most of the procedures are also covered under insurance. And if I tell you about Delhi, especially, tell you, in Delhi, we have all the corporate hospitals, we have a pain departments here. Now the corporates, they are calling people. They are looking for the people to start a pain department. Why they are doing this? Why corporates are going into this thing? Because they are seeing a huge revenues coming out of the pain medicine departments. So the revenue is not an issue now, and employment is not an issue.
So our struggle was much more than who are
Much
coming new.
Much more.
So Gaurav joined late. So Gaurav was discussing that why you people, you all are stalwarts. So why you have started or chosen pain as a leaving the easy, well-known anesthesia practice, or majority times you all people are giving in the pain. Why? Which actually attracted towards this specialty?
The main reason is that we are the master of ourselves, our work, and we want to put a place in clinical practice and the society so that we can help directly to the patient. In anesthesia, we don't have the control over the patient. Yes, or only clinical part. But in the society, you have to, actually you should be helpful to the society per se, that yes, directly you can give the benefits.
Means direct contact with the patients.
Direct contact with the patients.
And appreciation from the patient.
Yes, appreciation for the patient.
Okay. So now, Karthik, your view. How you started your journey and why?
4 points. 4 points. Recognition, no dependence, no night duties. Couldn't stand the obstetricians.
Okay, so short and crispy answer. Madan.
Probably I'll be having the longest journey and the answer, but thing is, I wondered why I was placed as an expert here. I don't belong to this league, probably. Like, anyway, means like it's a difficult story. It's always a difficult story to tell, like when 2018 Jammu ICRA, means like I still remember all the conferences in pain medicine used to be like this actually. 3:30 there used to be a panel discussion on day 3 when everybody used to go for the flights, and we will be discussing and Karthik will be roaring at me. What best you can do with ultrasound. So I think I had the answer today, 2025 we have the answer. The theme of the conference is MSK, right. So I started in 2012 when I came to Dr. Das. He was my guide, okay. And he was my college junior in MD. Means like much senior in pain though. So I called him up one day. I said like, see Karthik, I wanted to do something which is self-reliant, as he said rightly. So when I said this, like he said, Madan, I think it won't suit your things. You need to have your clinic, patients. He knows my temperament. Temperamentally not that. I say white is white and black is black. So that's the way I go it. So he said like, Madan, this may not be right actually. So I've done my fellowship. I have gone through a lot of things. So doing at this age may not be that easy. So I started probably like now I'm 49 plus. So you can imagine like 13 years back. So it's a bit late I started with. But definitely I took a tool called ultrasound. The moment I left Dr. Das after 15 days, I knew that I'm not going to take a fluoroscopy any further. So for fear of something, my father was a cancer patient, so I had some fear of malignancies and things. So I just started doing ultrasound. But those were days, 2012 days, ultrasound was nowhere in the picture. Nowhere in the picture, but when I started posting on my social media posts and things, people used to laugh. I kept on doing that, same mistakes. Wanted more critics to come in. A lot of people came in, a lot of people advised. I keep disclosing this anywhere in any conference. I have never gone in for any structured program in pain medicine, not even for ultrasound. But it's all about learning on myself, that which gave me the strength. Went about little slowly, steadily, but very clearly at 2018 I decided I should give it back to the society. It is not just about learning by yourself. You should spread the knowledge. Unless you spread, probably in 2025 I would not see this much big crowd for MSK. So that is what I did. And very clearly, after 2022, post-COVID, we had a group of like-minded people coming up. we wanted to start our own society. Starting a MUPS society was probably the greatest moment, I would say. Then after we slowly went into teaching more. And now, even though the radiology forum has actually said like no entry for us into the radiology conferences, they don't want to teach us as well. So still, I think like we are self-sufficient and self-reliant in teaching our own community. So that's probably the success which I wouldn't say own, I would share with other people.
Okay, so Anand, please.
So the necessity is the mother of invention, they say. Like the journey again started as an anesthesiologist only, but predominantly I was doing an orthopedic anesthesia work. We know like the role of regional anesthesia is more in orthopedic surgery for the post-op pain management. So when I was practicing orthopedic anesthesia at that time, like the post-operative analgesic regime is tramadol and tramadol infusion. And with the patient, one side pain, another side patient throwing up, and then it makes their life miserable with the opioid, and that too tramadol, we all know about it now. So then when I want to deep dive into it, like how to make the patient's post-operative situation better. So then, sort of started doing this psoas compartment block for hip replacement surgery and femoral blocks and saphenous nerve blocks. That made a lot of difference. Then I realized the key, the opioid sparing key. The opioid sparing key is the one that actually transformed me. So like for me, it's like a chain of event. Then, okay, I thought like, let me not just stop with only the acute regional pain services. We need to do something in chronic pain. Again, like we all discuss about the opioid sparing advantage of our interventional pain. So that actually led me to go into the chronic pain and learn. I first started my learning from Dr. Daradia in 2010. I still want to mention one point. After I come back, like I was given a responsibility by a national neuro trust. It's a national conference on neurology, happened in Chennai. So they asked me to conduct one chronic pain conference there. I was literally flabbergasted, like, I was so new in chronic pain, just 1 year over. So how am I going to do this chronic pain workshop? This I'm talking about 2009. Then I spoke to Dr. Das, and then, he was so busy that time with a lot of his commitments and everything. But even then, one phone call, he agreed to come. And then that's a very interesting situation that particular day, I think he skipped the flight, and then he came little late. Then there was no time because the audience were waiting. Then we took him in our metro train, the electric train. So, and then in last minute we went there, and then we conducted that National Neuro Conference, the pain workshop. So these are all cascading, like, you do something, like after that the visibility increases and the persistence, like you keep doing the same thing, not deviating from that. And then each time you do that, it cascades. Then somebody else will come to know, okay, he's doing so and so. So then with that visibility, you can expand your practice, or your expertise increases. And that is how it has taken me to US for my training in chronic pain. Then I went to Toronto Western Hospital for my ultrasound training there. So it just started from there. And the most important question what Dr. Das is asking, like about, can we sustain only in pain? Actually, yes. Because when we started, it was not like that, because people are telling me, what is there to learn in pain? It's all about epidural. You can make the patient sit and then give the epidural. That's what is all about pain. Then why you need a special training for that to go and then, excel in that field. But it has transformed so much now, it has become, it's evolved as a science now. And thanks to mentor like Dr. Das and Dr. Daradia and so many. And this has created a very big platform. And even now surgeons, they don't want to do any of the chronic pain, to be very honest, because I'm working in a corporate hospital where most of you feel there is no generosity from the surgeons to share their patients. No, it's not like that. They also feel so much threatened about the medical legality now, and with the evidence-based practice, they just want their patient to get better. And we are getting a lot of references from our fellow surgical colleagues. So there is a tremendous scope for the pain enthusiasts to take up this branch, even from day one, and they can still sustain well. That is my takes.
Thank you. Same question to Dr. Sunita.
Yeah, thank you. I was associate professor in medical college, and my professor asked me, ki there is one conference at Ahmedabad. Why don't you present one paper out there? As such, many orthopedicians, it was a government medical college, so they used to send patients. I was very much interested in giving epidurals. Only that was there, along with regional blocks. So I said, okay, I'll present this same thing. And I went, that was my first conference in 2006. And I really was so much interested that there is something else apart from anesthesia, where there is existence, and I will have my independence, because going into private practice was not my cup of tea. Being a female looking after house, we all know the problems. So then I really got interested, and then I left my job. I was about to become a professor, but then I said, no, nothing, this is nothing, something is lacking, something is there which I want. Then I thought, shall I go for critical care? What Pankaj said, same thing. Critical care or pain. And then I said nothing, I'll go for pain. And the journey started. It was really very difficult for us to survive because there were no classes and no workshops, only Dr. Das and Dr. Dureja. At Dureja doctor's place, there was 6 months waiting period. So, so we had to struggle a lot. For only one case, we had to go and see it, read. So this is how it started. And I will say I'm very happy today, fully contented, independent, and we have our own existence. So don't be scared. This is what I want to convey. Yes, it takes time, but then the journey definitely will take you to your wishes where you want to be. Thank you.
Okay, so thank you very much. I'm sure everybody enjoyed the journey, maybe inspired what they are thinking, and it's possible to sustain. They all people could sustain, so you people also can sustain in practice. Now, very interesting part, what I'll be asking to all of you. You have to share one of the very bad day, black day, or the day which the memory is not pleasant. Whenever you are thinking of that day, you are always feeling, awkward, bitter. But definitely, every bitter experience of us teaches us something, teaches to be a better person, maybe a better human being, maybe better service to the patient, whatever might be. So every bitterness in our life have some great teaching in our life. So your teaching, I always, this is my favorite dialogue I can say, that the mistake what I did, my fellows should not do that same mistake. They are also prone to, because we all are human beings. The mistake what I did, everyone else as a human being are supposed to do the similar kind of mistake. But if they are learning, they are starting from a point where we are actually transferring our knowledge that, okay, we did this mistake, you people should not do. So please, all of you, I'll be asking, there might be a lot of such mistake. At least if I am starting telling my mistake, it might be the whole day that, okay, I'm just going to tell my mistakes. So please, one very important mistake or black day or a day, bitter day you want to forget, and you learned an important lesson, please, all of you, just think and share one of such bitter experiences. Who will start? Others might be thinking. If somebody is ready, can start. And others might be thinking, which one is the most bitter experience?
The common thing which I normally do is a shoulder. So generally, when I do a shoulder, I always position the patient on the lateral side, try to convince myself for the ergonomics which I need. So literally leaving the patient, rather patient sometimes going from the, will be facing the wall, and lot of times I have seen patients landing up with vasovagal syncope, and the moment you turn the patient this side, almost unresponsive patients I have seen. So not just one, a lot of patients, around 20% of my patients were there like that. So what I decided to go for is, only patients will be facing only towards you, and lateral to medial needling, never go from medial to lateral, and ensure that you keep talking to the patient and give some time gap between the injection and the mobilization. So this is number one. Number two, with respect to carpal tunnels, there was a dentist who was actually showing her hand. Usually I started doing all my carpal tunnels with the patient in the sitting position. So I was just showing her, she being a doctor, actually the husband is also a dentist, she is also a dentist. So I was trying to show them, I have a slave monitor. So I enjoy scanning as usual. I was showing them the needle, all that, everything. The needle looked very big for her. The moment she saw the needle, she fainted. She didn't faint actually, she went into asystole. For a carpal tunnel, a seemingly simple intervention with local anesthetic with a 26 gauge needle. I normally choose only 26 gauge needle. She went into asystole. In my clinic, she at the intervention site, I resuscitated her. That's a different story altogether. A seemingly simple intervention without monitoring what can go wrong. This is what can go wrong. She vomited. She passed stools. She became apneic. So the kind of resuscitation equipments and facilities which you should have. See, luckily it was a good anesthetist clinic. Means I always had my laryngoscope, my tube, ambu bag, cylinders, everything were in place. But see how difficult it will be even for a simple procedure like a carpal tunnel injection, right? The third one, of course, I'll limit to another 30 seconds. I did a pyriformis injection. After the pyriformis injection, the patient, I started him to ask, means walk. He had a foot drop. He had a foot drop. So probably I had gone somewhere close to the sciatic nerve. I have given a sciatic nerve injection. Normally I choose injection volumes based on what is given in Samir Noros. Very standard volumes. 1 ml plus 1 ml, 1 ml plus 1 ml. That's all. I don't go beyond that actually. So I had given hardly 1 ml of 2% lignocaine. The only thing is I gave 2% lignocaine. So 20 milligrams of triamcinolone, that is hexacetonide. So 1 ml plus 1 ml. Given to it, the patient had a foot drop. So normally I do my procedures in the evening. So it was around say 8 o'clock and 9 o'clock he was not recovering. I was expecting the lignocaine to work only for 45 minutes. It didn't happen. So I got him to a nearby hospital. I admitted him. Basically see how it happens actually. Slowly things evolve. There is nothing, like no recovery. Patient starts getting more anxious. You get more anxious. No one to help you in the night. Whether to do any other investigation, any other, whatever be the amount of reassurance which you give, it's not working. Next day morning, 5 o'clock, I call up the neurologist, neurosurgeon, everybody, still the foot drop is there. So I didn't know what to do. So kept on calling people, gave a methylprednisolone, antibiotic, painkiller, everything. One thing which I understood that day was not to give too many things except for reassuring yourself. Not just the patient, by yourself. So by 2 o'clock, I took an appointment for an MRI just to see if there is anything which I did to the nerve or if there is any other pathology which I missed. But once he went to the MRI suit, after 45 minutes, he comes back walking. So there was no problem with that, but I still don't know the reason why it acted for so many, means nearly 48 hours, 16, 18 hours it worked. And for a 1 ml of volume, it is probably little too much actually. But I'm not sure why that actually acted for this many times. So these were my experiences, but luckily, like God's grace, nothing more than this has happened.
So thank you so much, Madan. I'm sure that the bitter days has a lot of things to learn. Thank you. Okay, Dr. Madan.
I want to share one interesting, I'm sure it will be very interesting for all of you also to hear. See, I'm working in a corporate hospital, so one of the patient is she's a cancer survivor. So I posted for a shoulder intervention, and of course I'll be having all the time 1 or 2 fellows, like I keep talking when I do the procedure. That patient was a little unaffordable. They had spent a lot of money in cancer treatment and chemos and everything. So, and she was in a severe agonal pain. I thought I should help her. So the procedure went on well, and I didn't charge the patient. I didn't charge the patient because I really wanted to help, because cancer survivor exhausted with funds. Next day I got a call from the medical superintendent of the hospital saying that you got the complaint from this patient. The complaint is so funny, like patient got the relief, but the patient said, I have been used as a clinical material. And then the doctor was explaining about my particular condition to their so many people there in the theater, and I can tell you, because he did not charge, he did not bill me, so it is apparently very clear that he has utilized me as a clinical material. So I realized one thing: never do anything free of cost.
Have he used the term guinea pig?
Yes, of course.
Sometimes
yes.
people use that term as well.
Yeah, but actually speaking, I always introduce the patient whenever they come to the theater that this is my team. But I realized that it's my biggest mistake. It's not about money, like at least some amount of fees, I think, or the paying charges you should make. That's my personal opinion, because I felt so bad that day. My gesture was taken in a different direction. I did it free for her, but it was misunderstood, saying he didn't charge for me because like he has utilized it as a material. So I realized that day, like, no more treating patients free. At least you have to charge in 100 rupees or 1000 rupees or 2000 rupees. So I really felt bad that day. That is one. And the second one I felt regret is, like, I started my clinical practice long back actually. 2009, I went to Dr. Daradia, and then I came back and I was so persistent in my practice. But I was never into the academic activity till 2018. So it was 10 years of my, in fact, Dr. Podar and everybody were asking, like, you are doing a good job, but you are not attending any conferences, you are not sharing. Actually, I felt, now I feel like it's a big mistake. So what you learn, you should teach others. So which I didn't do for 10 years, I started doing after 2018. That's another thing I felt very bad.
Thank you, thank you. Who next is going to share?
Me.
Okay, go now.
Just when you are starting that bitter incidents, so there are a series of events is coming to the mind. So we just in mind we are choosing which should be shared, which should not be shared. So they are just like Dr. Madan has shared that in his clinical setup he has gone patient into asysto. So 2 or 3 patients of ours also gone to such places. I have been attached to government as well as in private practice also. So in government setup, we don't, because anesthesia people usually they don't cooperate. You are being a junior or just to go to there and yeah. So how we started that, yes, एक कोने में जहाँ पर कोई PAC room है या उसमें घुस के आप कुछ procedure कर रहे हो तो simple trigger point injection and simple what you can do. At there are 2 or 3 incidents like him only. So that's how we learned the lesson. Don't do anything small intervention in that. You have to be in OT with proper setup and proper backup. So that's the one lesson which I shared with same with the Dr. Madan. Another is that money. There are 2 or 3 incidents in the initial practice when I started my practice. So we used to little bit of defensive because you are also not in very full command or full confident voice.
And
so
not sure what is going to happen.
What about the effect?
About the result.
So there was one NRI patient, NRI software engineer came from US and he came at Jaipur and he took one year back some intervention at Dr. Daradia place, Delhi. And after that, because he belongs to Rajasthan, so he inquired that who is doing practice. So some big neurologist, he suggested my name. Then I took that call and I asked him to come at my place at home, because at that time 2 or 3 there are centers, but he insisted, "Nahi, I want to come at your home." So I took the consultation at my home. And I explained the procedures and all these things and about the charges, because that's the most important thing, how you should be able to express about your charges. That the same thing, the charges ke baat hui, so I could not make me comfortable in asking. He said, "How much, doctor?" So I know that it should be around 20,000 or 15,000. And ultimately it was being bargained, and he bargain was happened at the last 750 rupees. Can you imagine? 750 rupees. I was so disappointed and depressed with myself that I could not ask proper money for them, and that to a very well educated, person who is known of the pain medicine. So because he took the treatment in US and in India also, but that was a very distressing moment. That was a very bitter memory. Another thing is,
so what is your advice?
You should charge good amount. You should charge your consultation, and if you are that was very depressing for 1 month. And then the lesson learned, जैसे तीसरी कसम में राज कपूर कसम खाता है कि घर पे मरीज नहीं देखूंगा कभी भी, है ना. It should be at proper setup एंड इट हैज़ टू बी विद सम, आपका वहाँ पे बाहर बैठा होना चाहिए आपका रिसेप्शनिस्ट, एंड अगर कोई फ्री भी करना है तो पहले फ्री 0 रुपीज़ की रसीद कटेगी, तो उसके बाद तक, सो दैट पेशेंट कैन अंडरस्टैंड दैट व्हाट दे आर गेटिंग इन फ्री. दिस इज़ द प्रैक्टिस विच आई फॉलोड. अनदर वन इज़, जैसे ही पैसे के लिए एक और मैं बात बताता हूँ, एक पीपल दे यूज टू, यार ये करता है, कुछ करता है, पता नहीं क्या करता है ना. तो साहब, देर इज़ वन पेशेंट इन आवर कॉर्पोरेट से वो डिस्चार्ज आई, द यंग फीमेल, इट्स अराउंड 2014-15. So young female patient, it was 20 years, so I was called upon that hospital. So he was owned by a doctor, physician and gynecology combo. So यार हमने तो सब कुछ करके देख लिया, अब इसको abdominal pain है, now what will suggest? So I put that सारा उसका रिकॉर्ड, तो उसका सारा पिछले 7 दिन में उसका 4.5 लाख रुपए का बिल बन चुका था. 4.5 lakhs already spent. 4.5 lakhs rupees already spent, and there is no diagnosis has been made. Abdominal pain, severe abdominal pain. She couldn't move. She's very, or she's weeping like that. So on examination, I found that anterior cutaneous entrapment acne. So clinical examination, I just put, मैंने कहा ठीक है ये low OT में मैं इसको कर देता हूँ. Again that मैंने procedure किया, patient got relieved, immediate relieved. So when I asked about the charges, तो उसने मेरे से पूछा भी नहीं डॉक्टर ने. He टेल मी, ओके 500 रुपीज़ दे देते हैं तेरे को यार. अरे मैंने कहा यार भैया, ये डायग्नोसिस भी तुम नहीं बना सकते ना, डायग्नोसिस तो मेरा, तो मैंने यहाँ पर आके, एक तो तुम्हारे यहाँ से मैं गाड़ी लेके तुम्हारे हॉस्पिटल में, सॉरी, सो आई वेंट टू योर हॉस्पिटल, आई एम ऑन योर कंसल्टेशन, एंड देन आई पुट, आई examined, I made a diagnosis which is not very common at that time. It is not had been discussed. मैंने कहा कि आप पूरे शहर में you will roam around in a whole city, and if anybody can make this diagnosis, then I will. So, but that physician and that couple are so adamant. So I have sorry. मैंने कहा I don't want to 500 rupees also. So that's the message is कि you should able to ask money. You should be very confident. These are the things which made us stronger. Now अब पैसे मांगने में मतलब आपको जोर नहीं आता. You should be very clear how much money you should ask. That is the important thing. Another.
So there are a lot of, I think how you inspire or how you start is the less inspiring, but we have lot of things to say, ki what mistake we have done, how we learned. Because I will do only 2 cases. One case, initially 2005-06, as everyone know, we don't have the YouTube, we didn't have the Google, and Dr. Daradia, when I did the training, he has given me, Xerox, Raj's practical book, Xerox only, not the original, which has the only black and white. So I used to, open, I was doing one celiac for the very big cancer and very big, and oncologist referred me. I was so happy, I am doing celiac and alcohol, and I used to open the book and step by step, and I used to say, technician को देखो ठीक है ना, ये ऐसा फोटो है ना, एक्सरे का फोटो is same as I am seeing in the book. हाँ मैडम ठीक है, next. So I was doing that way, and I was giving alcohol after putting the needle, and patient say, in Bengali, আমার তো পেচ্ছাপ হয়ে যাচ্ছে. I mean, I am not having control over the urine. I thought I have not done anything to urine. Why the urine why she is not having? And after that I saw she is the paralytic. Both. Of course we referred, but my oncologist was good, as she has a very big tumor, and even in fact she has the bust, after that bust tumor. So he explained, he said, Dr. Poddar, don't worry, and it was big corporate hospital, Ruby Hospital. He said, don't worry, I'll explain. So I said, but I thought my procedure done the paralysis. When I was in, I called him, my one only Gautam paralysis happened, so he also counseled me, and what happened, I didn't have, but that was very initial. One more very important, which I actually learned, that was my mistake. I think maybe how it happened, still I don't know explanation, because that was my initial days. I started doing vertebroplasty, kyphoplasty. So normally the spine, few orthopedic surgeon and neurosurgeon used to call me, okay, Dr. Poddar, you do my patient, I used to do their patients. It was not my patient, their patient. One surgeon asked me, Krishna, I have put, Dr. Padar, I have put one vertebroblasty, you come. So I saw only in the table. I did. And one side I was putting, one side he was putting cement. Both side I put the needle, but he was. And patient got leak, the cement leak. We called, of course, a spine surgeon. He opened and he was very elderly. So that day only, because after that I saw there was bust and maybe there was a retropulsion. And that day I learned the lesson. Now I will not do any procedure for anyone's patient. I first see the patient. I will assess the patient. And then afterwards, whenever that surgeon referred me, I said, no, doctor, you can admit under you, but you refer me, I will see MRI, I'll see, and then I'll put the patient. That was, I think, my mistake doing the procedure.
Thank you, Krishna. The most important things, your courage, because majority of, if you are asking the consultants, very few people will be telling what their complications about their practice. Very, very few. So you are so honest and so courageous that you could share publicly about your hot complication you will end up.
Yeah, because
so big cap for you. Really, really, very, very few people will be openly share that mistake or complication I did. Thank you. But all these are basically giving us the lesson.
Yes.
This all could happen to our life as well, even if apparently we are done everything very right. Thank you.
Yeah.
Okay, Pankaj.
But
Okay, so
never do, epidural for someone else patient. It should be your. That you should learn from the first day of the practice. Maybe you will lose 1 or 2 patients,
Or
but you
just
will get
examine
the
the
third
patient.
patient.
Just examine the patient beforehand. That is it. So, yeah. So I started my spine endoscopy in 2014, immediately after doing 3 days of workshop in Germany. I came back to India in 3 days for attending workshop. I started doing spine endoscopy. My second case, complication, discitis. Fourth case, failure. I couldn't enter. Sixth case, again, discitis. So this was my first initial 6 cases. That time, because I did not have my own instruments, so I used to call a guy from outside. He used to bring the instruments, everything with him, and then I used to perform this procedure. So 6 procedures, after doing 6 procedures, that was actually the black days, I can say black years also. For almost 2 years, I was cursing myself, why did I do this? Just after learning 3 days of, attending 3 days of workshop, I started doing, and I had 3 complications. 2 complications plus one, in one case I couldn't do anything. So almost for 2 years, I stopped actually practicing. I started thinking that why I should enter into this field. That was the time when I actually stopped doing endoscopy. But I thought it's not a good idea to stop doing anything which is we have already learned, and it is a requirement at this moment, because if we stop doing these things, our youngsters who are going to come, they will won't be able to even start, right? So we cannot stop at this moment. So again I went to Korea. I went to Korea for 3 weeks. After coming from there, I purchased my own equipments. The first thing what I did was, I purchased the entire set, entire equipment, the towers, instrument, everything I purchased myself. And then I started doing endoscopy regularly. And today, almost like, I can say almost, I'm the maximum number of endoscopies I'm doing in this northern India. Almost 15 to 20 I'm doing in a month. So basically what I want to say is that the mistake what I did was, I started practicing a more invasive procedure by just attending a workshop, which was wrong on my part. So without adequate learning, I started doing this thing. Second, I was dependent on the instrument from outside. Investment is important. So invest in your own equipments. That is very, very important in your practice. That's an investment. Whatever you are investing in this, you will recover within maybe 6 to 10 cases is what is required to recover those kind of investment. So never ever start anything with just 2-3 days of workshop and invest in your own equipments. So complications at times teaches you many things. And actually that basically gives you a break also. Ki yes, you should stop here. You should start learning more. This is not a good idea to start practicing like this. Maybe that's it.
Thank you, Pankaj, for your beautiful lesson. I'm sure that everybody will be encouraged. So now, Tom.
So probably most of us would have done our mistakes in the early part of our career. We've all learned from them and then become better. So this is more a technical thing from my practice, pretty early in my practice. So I was working in the Apollo Pain Clinic in those days. So this was a pretty routine case is what I would call. So I'm reasonably comfortable in doing transforaminals, caudals, facet joint injections. Probably 40 to 50-year-old lady coming in with a bit of back pain and a bit of radicular pain. Now this radicular pain, the usual segments that you're going to find is more L5-S1 nerve root involvement. This lady had a disc-related lesion slightly higher up. So she had a L2-3 and an L3-4 disc, which was pretty bad. So there was bilateral nerve root compression, 3 levels. And this was quite an old injury, so there was facet involvement as well. So she's having, in my opinion at that time, L2, 3, 3, 4, 4, 5, 3 level bilateral facet arthritis and nerve root impingement. Now, pretty routine case. So I thought if it was in the lower segment, I would have been inclined maybe to do a caudal epidural because both sides were involved. Along with it, a facet joint injection. I was planning probably an intra-articular cortisone shot for the facet. Now, because it was higher up, L2, 3, 3, 4, 4, 5, I thought, okay, we'll do a normal interlaminar epidural, which would go in the midline and I would cover 3 or 4 segments. Along with that, the facet joint injection. So that was my plan. So routine case, everything is fixed. May I say one patient. So a patient is prone. I have my pulse ox. I have my BP. I've checked the BP. BP is okay. One small, an IV line is running and 500 ml is going in. So I thought maybe I'm going to give contrast for the interlaminar and I'm not going to give contrast for the facet. So I thought, okay, we'll do the interlaminar first and then we'll come to the facet. So I thought it was a routine case. So L2, 3, 3, 4, 4, 5. So I went in, patient is prone, 3, 4 level interlaminar. And I thought I had a good give. The contrast looked satisfactory to me. I gave about 8 or 10 ml of local anesthetic with about 60 to 80 milligram of methylprednisolone. So the interlaminar was done. I thought I had good contrast for it. And then I was doing the facet joints. So facet joints I was doing intra-articular. So usually if I'm doing a 3 level, I'll put 1 needle, 1 level above, and then 3 levels, and then the other side. Now apparently, which I realized later, I had probably done an intrathecal and this lady had a hypotension, which because I was doing a facet joint injection and the patient was prone, I had actually missed. So probably because of the interlaminar or the supposed intrathecal local anesthetic, she had a hypotension and I didn't notice it. And I continued doing the facet joint, which probably took me about 10 minutes. And then by the time I had finished the procedure and turned it around, she was not responsive. She had a hypotension, of course. We did revive her. So some valuable lessons to learn there. So continuous monitoring is required. Talking to your patient throughout the procedure would be a good idea. And checking blood pressure almost like 3 minutes or 5 minutes after any epidural or interlaminar or caudal would be a good idea. So that's my lesson.
So thank you, Karthik. So I feel that, okay, this session could have been stretched for the long, you know. Yes, we are coming to you. I know you are left.
He says he thought that I am past president, but it's not like that. I am a president is always president. May I, sir?
Yes.
This incidents happened, though it's a very small incidents, not very serious type what all have said. But see, my negligence and it caused in medical college, the fellow is there with us always because they want to learn. And nowadays what happens is orthopedic people, they also want to learn. So what their PGs will do, their seniors tell them, you stand behind and see what she's teaching them. So we will see and we'll do it. It's like that nowadays what is happening is, it's because they want to learn. So that day what happened, I did a blog, patient was VVIP, some politicians relative. So the patient is VIP for every one of them. So everything was done, procedure done. After 4 hours, the fellow calls me. I went home. She tells me, ki, madam, patient is not moving the limb. I said, what? Ask, what, any motor thing is 0, motor power is 0. I said, how can this happen? It was L4-5 disc, and we gave our selective nerve root block, MIPSI, sorry, not block. And then after 4 hours also, when there was no movement, I thought, what must have happened? Then I asked her, what about the drugs? So then I said, what was, I usually give Sensacaine. So she said, madam, I said, what was the concentration? She said it was 0.5%. So usually we take 0.25 and we double dilute it. So this is something which made me, because I didn't see it there. I said, take 0.5 and double dilute it with steroid. But what happened was, it was 0.5 which was taken, not 0.25. And it was given at 2 level. So for that day, for around 6 to 8 hours, the patient was there. There was a lot of rush. I had to go see everything. And I told them, okay, next day he'll be okay. Sometimes it happens in 1% of patients. So because I knew what has happened. So this is a lesson which we should always see, even if fellows are there, that what concentration, even the drugs, which doesn't matter much, but then this can happen with anyone.
Thank you, Dr. Sunitha. Because of the time, otherwise, at least I am enjoying this session very much. And I'm sure that our audience is also enjoying. So I'll be asking one, not many, from audience, if they wish to share their mistake. Please stand and come, or we can give you the microphone and we'll be very happy to hear if anyone wishes to share. Yes, Kasinath, please come. You can come here. Today is not my turn. If any conference, any one of you asking me and sitting there and telling, okay, Dr. Das, please share your complication, that day I'll be telling. Or my bad day, that day I'll be telling. Okay.
First of all, thank you very much for inviting. The day or the patient or the complication, nobody wants. I had done that. And that is the death of the patient after meningitis, after a caudal epidural. So what happened is, patient of some malignancy, radiculopathy. Malignancy was not a reason for the pain, and I did a caudal epidural. 2 or 3 days after that, I received a call from the casualty that patient is having delirious, and he's come here for the admission. So I asked the casualty person, admit the patient and get the test done, neurologist opinion done. I rushed there, asked for the LP. Obviously, there was neck rigidity and all other factors. LP was done. It was a pus into the CSF. Worst thing, a lot of fight, medical fight. The patient died. Then we sit and we started retrospectively thinking, what could have been gone so wrong that the thing which nobody wants, and I have witnessed that. So ours is a urology hospital. The main work in the hospital is urology, right? I'll explain you what happens and how a lesson is learned. So there is a contrast, and it is a vial we use for the contrast. And when the person takes the contrast, there's a lot of habits. So you took 10 ml, you give the contrast, and you want to take another 10 ml. Now what the brother will do is, So you are giving it into the urological system, some RIRS, URS. And what happens is, the same syringe is taken, air is filled into that syringe, maybe some contamination is already there, then there must be pyelonephritis or whatever. You push the air inside, and then you put up the contrast, okay? This is the contrast. Next day, what happens? We go to the next case, and we use the same contrast. You understood? From that day onwards, none of me, none of my fellow, or none of any staff from the hospital where I work is allowed to reuse any of the drug for any of the case. And the consequence is he will get worstly fire of his life. And this has happened 2-3 times. No, now the people know me that, okay. So money doesn't matter for me. Or that for that matter, it doesn't matter for anybody. It doesn't cost everything you take a new, and it will not cost more than 1,000 to 1,500. And contrast vials are, ampules of the contrast are available, water-soluble contrast. So the biggest lesson learned is, for every patient, single-use drugs has to be used. Doesn't matter what happens. Thank you, sir.
Thank you, Kasinath. So we'll be ending the session, but before that, I want to, one funny incident. I remember we was one of the conference, and I heard this from Gaurav, and I'll be asking Gaurav to share that before we are ending this with a little bit of humor. And but again, I'll be asking that, okay, some part of it must be in Hindi, otherwise you'll not be able to get that, this. But still, try to be as much as possible in English.
So, actually, there are a lot of incidents, but sir has already, he remembered that incidents because we have learned that we should be in our hospital setup, our OPD should be, setup is like that. Nowadays, with our experience, I have the CCTV camera in my OPD consultation room with the whole microphone facilities also. So that is the one lesson which I have learned over the years, because it has saved me at least 6 or 7 times to get sued. Because I already said, there are fixed dialogues which I used to convince the patients and attendants. So there are multiple episodes. So one episode which I've sir mentioned, which I should share with you, that it's a very common practice. Patient comes to you, sir, I have pain this, and 6 months ho gaye, 6 months, 1 year, I'm so much worried. Please help me. Okay, so we used to counsel, yes, there is a myofascial is there, or something is like there. So you should have taken for pharmaceutical treatment, pharmacological treatment. Then if needed, then we can, oh no, sir, pharma, I don't like allopathy drugs, Allopathy is too much side effect. I don't, it's not my cup of tea, please. Okay, then we can help you by some exercise or lifestyle modification. I have already done. I'm going into the gym and I do the Zumbas and all these things. Okay, then another option, if you want to have, then we can go for intervention. These are some small intervention. If it is not working, then we can go some little bit more invasive intervention. Intervention? Sui? No, doctor. I don't want to go into any intervention. No. Okay, then please come near. I should ask something else. I have one more options for you. Yes, please come. Okay. तो हम हिंदी में बोलते हैं अपना कान लाओ पास में. Put I want your ear to be so. Yes sir. So I was just okay. I will whistle. मैंने कहा मैं फूंक मार देता हूँ कान में और तो क्या कर सकता हूँ. This is a so this is and उससे पहले क्या I was very depressed, मतलब embarrassed. मैंने कि क्या बोले, मतलब it's every third or fourth patient is like that. No, I don't needle is I don't want to do, and allopathy I don't. That day I got the answer. Nowadays any patient comes, come near me, I will give you the treatment. एंड आई हैव ब्रूम ऑल्सो, अगर झाड़ू से भी मैं हवा कर दूंगा उससे भी जाएगा. और दूसरा मैंने, सर आप मजाक कर रहे हैं, तो मैंने मजाक, तुम आए मेरे पास ट्रीटमेंट कराने हो, व्हेन यू आर कमिंग टू द डॉक्टर एंड आई एम एलोपैथी डॉक्टर, आई एम अ पेन फिजिशियन, आई विल गिव यू अदर पेन प्रेडिक्शन और पेन ट्रीटमेंट, व्हाई डिड यू कम? सो ओके, आई गॉट माई कंसल्टेशन, आई विल एडवाइज यू द ट्रीटमेंट, पास आओ, फूंक मारूंगा, थैंक यू वेरी मच.
गौरव धोनी वाले बाबा बन गए तुम.
So thank you very much. Thank you all the experts. And I am sure that all of you have enjoyed this session. And we'll be having the similar kind of session somewhere in some other conferences. Thank you very much. Thank you very much.
We now move into our next scientific block, advanced and emerging techniques. Pain medicine is rapidly evolving with the integration of innovative techniques that enhance precision and patient outcomes. Okay. Okay. So for the next session, I would like to call Dr. Bibhu Kalyani Das ma'am and Dr. Rajendra Sahu sir to chair the session. Dr. Rajendra Sahu sir.
এসছে আসেনি তো।
আসেনি সেটাই ওখানে দেখো না তোমাদের ডাইরেক্টলি কানেক্টরটা লাগাও অনেকবার এই কানেক্টরটা কাজ করে না
এইচডিএমআই নেই তো কি করে কানেক্ট
না 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 তোমাদের এটা নেই সিটা হ্যাঁ ওটা লাগবে
এটা
মিরর দা ইমেজ করতে হবে মিরর
কোথায় আছে
এই তো অ্যালাউ
তুই যাও
কিছু প্রেস করতে হয় এটা ছোট কেন হলো অ্যালাউ অ্যালাউ এটা সেটিং ওহো সেটিং তো এটা দাঁড়াও ওটা সরাতে হবে হ্যাঁ ইন জেনারেল হ্যাঁ এবার বলো বড় করলে
এটা কেটে দিন
দাঁড়াও এটা না
এই সার্চে যান
তো ছোট আমি তো দেখতেই পাচ্ছি না
এখানে ডিসপ্লে সেটিং DISP ডিসপ্লে ওই যে ডিসপ্লেটা খোল
Sorry for the interruption. We now move into our next scientific block, Advanced and Emerging Techniques. To chair this session, we have Dr. Rajendra Sahu sir and Harshita Surange ma'am on stage. To begin, we have Dr. Basavjeet Das, who will enlighten us on how artificial intelligence is shaping the future of pain medicine. Let's welcome him to take us through this fascinating topic. Welcome, sir, on stage.
আমারটা আসছে না নাকি I can put my own laptop. না না presentation তো আসছে না yeah it's fine yeah just let me scroll through yeah it's fine okay we're good to start yeah hello hi everyone just 1 second hi everyone I would like to thank Daradia Gautam Das sir and the whole organizing team to give me the opportunity to talk I'm going to talk on AI as such in healthcare and pain medicine so how many of you think that AI could be the future in pain medicine? Raise your hands up. Could be, all right. Okay, you just, like it's, more you know, more you think, yes, it could be. But from the first slide, I say AI is not a replacement. it's a tool. Whether it's radiology, whether it's pathology, and it's hardly going to replace pain medicine, but still it will be a tool all the time. I work in Dublin in a big private hospital, and we are 9 pain consultants. And just to tell about me, and yes, artificial intelligence, an important tool in pain medicine. From the first slide, I say it's a tool, it's not a replacement. So what happens in AI is basically we are putting human brain in a computer, but at the end of the day, like whatever information you put in the computer, it's all indirectly coming from us. And the computer will make a pattern where there is no involvement for interaction, the human involvement, but indirectly there is, all right? There is no direct. So just talking about the history of AI in healthcare. As such, AI, if you talk about AI only, it's not a new concept. It has been there since 1950s. And there was a Dortmund convention or research in 1956 where the first, the terminology of AI was mentioned there. And since then, there has been a big evolution of AI along with the evolution of computer science. And well, in the early 20s, we could see AI, it was more of supervised learning. So if we feed data in the computer, like put images, put some pictures with skin lesions, and then it will generate an information for you. You put the input and the output will be, and there was not much of extensive learning. And then there has been evolution after that. Now what we're using is ChatGPT, and then we are using MedPAM. So this is using more of advanced learning, and now we have combination of both supervised and self-supervised learning, and I'm sure we are heading in the right direction. And there are some challenges as well. There's something called the hallucination, where your AI could give you wrong information. There's a talk about ChatGPT, the older version, somebody asking ChatGPT with some criteria, can I commit suicide? And ChatGPT said, yes, you are. So that's wrong, right? But things have changed so much now in the last few years, and has been a big change. So basically, we are integrating the machine learning, and then we are integrating the deep learning. So in the machine, we put the data, we train the machine, all right? And then when you involve more and more, like, we validate the data, we justify what we are doing, and then what we do at the end is a combination of machine and deep learning, and then we get a proper AI. So what do you think about AI and pain medicine, especially in chronic pain? It is useful, starting from assessment to diagnosis to treatment, but at the end, I'm sure it's not going to replace us, it's going to help us. So if you look at advancements in medicine and healthcare, as I mentioned, self-supervised and combination of large language models. And one good thing is that, just to mention about AI, like what sort of information we get, like the biologics, we get information about proteins. And there was somebody I was talking to when I was doing my AI course, and she told me like it took her only 5 days to get all the protein sequence for the vaccine. And the COVID vaccine was made within 5 days because of AI, because they got the messenger RNAs, put them all together, and it was possible because of AI to get all the information and come up with a vaccine within 5 to 7 days. And imagine, like, if you're doing it by yourself, and it could have taken 10, 15 years. So there is a role for AI in the future, for sure. Sorry, I put my updated slides, all right? I put my updated slides, all right? This is not my presentation. Yeah, please, all right, if you don't mind. Thank you. Sorry about that, because these are not my updated slides. Can you check with Milton? Or I can use my own laptop. Sorry. Or I can plug in my laptop if you want, yeah? No worries. I have my laptop, yeah.
So till the time we are ready with this presentation, we are open for discussions. Any questions anyone want to shoot?
दोनों है मेरा दोनों कनेक्शन है इससे होगा Good, thank you. Sorry, because if I don't use my updated slides, I'll be very upset not to give you proper information, right? So, yes. No, fine, thank you. There we go. Thank you. So, so when you talk about AI and in the pain medicine, from assessment to diagnosis to treatment, is it useful? It is useful. So if you talk about AI, and we see that from the pre-clinical visit to to the clinical encounter, additional workup, diagnosis and treatment, AI could be so much useful. So if you see a patient beforehand, you can ask the patient to fill questionnaire about a procedure or why the patient is coming to the clinic, and then we can all put them in, electronic medical records, and this will help you to get more information about the patient's condition. It will help you to diagnose, make differential diagnosis, and of course, the patient could be given information about the procedure in the form of images, in the form of videos and anatomical structures, and at the end, it will be very useful. So what will happen when we do all this? It will optimize your outcome. This will help you to recognize the condition better, and it will improve your decision making. So again, AI is helping you, it's not replacing you. For example, like you are using a patient who's expressing pain in the form of facial expression, like it's so subjective, right? Okay. And if you have a system, if you have an app which recognizes the facial expression, will give you a better information about pain. So voice analysis is very important. It could vary from patient to patient, all right? When you have a voice which tells you exactly what sort of pain the patient has got. So there are some wearables as well, sensors, where you can, like when the patient could put the pain score, put the heart rate, blood pressure, and this will give you so much of information, and everything could be put into electronic health records. So there are some specific applications, all right, for risk prediction, like for example, a patient who is an opioid, and you want to predict the risk, you can follow up the patient, get some information, the patient will fit that, and you will know at the end of the day, like if the patient is has a risk for opioid addiction. So we can do opioid monitoring and risk reduction, absolutely yes. And physician drug monitoring portal, you could have your own portal where you can, along with the patient, you can use it. And of course, you can give a personalized treatment. And image optimization is very important in pain medicine as well. Like, you know, if you're having a scan, you're struggling to know exactly what's there, you can always use the help of AI to know more. And this is where I use more, I think this will be the future in neuromodulation, which is so much patient dependent, like the way the patient is using the spinal cord stimulator, the therapies, the programs, and if you have a proper AI, which could be app-based, and the patient can use it in such a nice way. For example, the closed loop concept, you all know that, like, you know, with changes of position, the neuromodulation or the stimulation could vary. In that case, AI will be so much useful. And if there is any device malfunction, right, in the form of the device is not working optimally or it has failed to work, and AI could warn the patient much earlier than the patient coming to your clinic and wasting time, and by the time you have lost here so much of important time. So, well, how you develop your own AI system. So the most important thing, the first and most important thing is that stage one, you have to train the model. You need to know your input, what you want. Then you have to train the model. Then stage two, you'll have to, this is the problem with, this has been the problem with the older models. Here what we do is that validate the model. You have to validate against all the evidences you have. And the stage three is you'll have to deploy. So overall, first of all, when you design an AI model, which could be a diagnostic model, which could be an educational model, first and most important thing you know is that what is your input? What do you want? What do you want to do with the AI? What the AI wants to do for you? So then you'll have to think about the overall structure of the AI. You can consult with your software colleague, and then you need data requirements. Data is very important. We need lots of data. Doesn't mean that you need millions of data. If you have quality data, that's what you need. And studies have shown that at some stage when you have more and more data, it really plateaus, all right? And then if you put more data, it's not going to give any more extra information. You're just wasting your time. And the implementation strategy, what software you're going to use, and the key stakeholders who you are going to sell your AI to, your patients, to your colleagues, to the other doctors, to the hospital, and beyond that. And potential regulatory implications. If you have an AI, you have regulatory implications. Like in our country, we have CE. In the States, they have FDA. In India, we have our own thing. Like even the hospital will have its own internal regulatory implications. So we need to know exactly. Otherwise, there's no point designing an AI when you know that, like, there could be a regulatory problem in the future. So better to know everything before you design your own AI. So the fundamentals, features means your input, right? What do you want? Okay. If you want to give an information, it's an information. If you want to give an education, it's your input. Second, you need levels or the data. So as I tell you, the data you need to get will be more of quality data, and you have to train the system. So overfitting, don't train the system too much that it gives you a simple answer. So this is called the overfitting. So to overfit your, to prevent the, what do you call it, your model to overfit, you need to tune the data, you'll have to compare the data to the evidence and validate the data, and then you're ready to go. So there are a few myths, all right, when you do, when you design your own AI. So more data is all you need for a better model, which is wrong, as I told you, because more data, you need more quality data. An accurate model is all you need for a useful product. It's not the thing. You need a model which is robust. It doesn't mean that accurate, like, it will give you whatever information you need. It has to study and give you a proper information. A good product is sufficient for clinical impact. It's not that. Again, you need to know exactly what sort of product you need. A good product doesn't sell well. You need to know exactly how the product is going to help you, your colleagues, and the patients. So these are some of the measures. We use all the sensitivity, specificity, positive predictive value, and negative predictive value. So I'm not going to go through much. So the most important thing is that we normally use this pipeline, all right? Okay, so here is the input, and here we have the output. So when you go from input to output, there are lots of places where the pipe could be leaking. And if you don't mend those leaks, you're going to get a bad output, all right? In that case, your model won't be a perfect model. So it starts from the problem selection, your input, the data collection, what sort of data you are putting, an outcome definition, what sort of, you'll have to define your outcome, exactly what you need. And you need to develop your algorithm, and then post-development consideration is very important. So the bias, of course, the human-generated bias and the machine learning models bias. So over a period of time, you'll have to assess your model's performance, highlighting the model's practical utility, how the model is performing all across, revealing the discrepancies and evidence during the initial training stage. And if you think your model is not performing well, you'll have to evaluate, re-evaluate, and then what you do is that you need to maybe redesign your model. So these are some of the regulatory bodies, like in EU we have CE, GDPR, then in Japan there's so many regulatory bodies you need to know. So most important thing is that when you develop your AI, it has to be very transparent. It has to give a very clear information. Yeah, and it has to be very much generalized so that it gives good information all across. It can be reproduced when it has to do the job. I'll skip through. So the challenges are, the pain is difficult because it is very subjective, and objectifying pain is really difficult. So data collection and privacy, there are lots of bias across. So there are some of the references you can read, you can go through. So to tell you, AI is not going to replace, but if you don't learn AI as a doctor, as a pain physician, we all need to learn a bit of AI. Otherwise, there'll be somebody else who is going to replace you. So there are lots of courses you can do. One is, among all the courses, I love this AI in healthcare from the strategies to implementation by Harvard Medical School. I got it done a few days back. And this is my own model. I have just to share my own experience, all right? So I've designed a module learning module for pain procedures information. This is a language learning model, and the pipeline, the input is selected procedure. I'm using what you call retrieval augmented generation AI model, which will retrieve the structures, content, and generates AI. So the output will be text. When the patient will ask a question, like, the doctor, your colleague will ask a question, I need a rhizotomy. So the AI will give the answer in the form of text, in the form of visuals, in the form of optimal video, and there is always a follow-up to know how your AI is performing. So this is all about AI, and I think that's the future. Of course, I'm still designing an app-based module, and it will be ready in the next 2 months, and if you want, I can share it with you for sure. Thank you. Any questions?
Thank you, Dr. Das, for the wonderful presentation.
Thank you.
And looking forward for your model to come. Is it open for the market?
It will be. We are still. I spoke to my engineer this morning. Right, I woke him up at 6 o'clock in the morning. He told us, I'm trying to get it there, but the model is still not ready. Hopefully, it will be ready in the next couple of months, and I'll be happy to share with you for sure.
That's wonderful. Looking forward.
Thank you.
Thank you, Dr. Das, for that nice lecture on the AI. Next will be Dr. Madan Pandian speaking on the barbutase for the calcific tendinitis for the supraspinatus. So you have seen Dr. Pandian doing it in the morning on the shoulder lecture. So he's a sono artist and he has significant expertise in MSK ultrasound, specifically more on the shoulder one. So let's listen to his lecture on saline barbutase for the calcific tendinitis.
Good evening, everyone. I will start with a question. How many of you do barbutages? Calcific tendinitis, anybody treats with needle interventions? Yes, Milton, yeah. See, this is not a very commonly touched intervention by pain physicians for one reason, because we really are literally scared about the amount of failure rates for when it is not done in the right way it should be done. So basically, this is about how to handle a case of rotator cuff calcific tendinopathy by different needle interventions. This is my disclosure. This is based on my original work on shoulder, based on the current amount of scientific evidence present, and with proper patient consent, no financial disclosures on this presentation. After this lecture, we'll have these things we'll learn actually. Pathophysiology of calcific tendinosis and the stages of the disease, patient selection, the interventional methods, and how I do it based on the evidence. So let us understand what exactly is the pathophysiology of a calcific tendinitis. One thing is very important. This is not a degenerate tendon. A calcific tendon means that this is a normal tendon where 20% of the patients by X-ray, if they have a calcific tendon, likely to be asymptomatic. Only 50% of the patients become symptomatic at some stage or the other, presenting as acute or chronic pain. Only when there is a calcification, there will be this amount of pain, be it minimal or maximal. It could be in the formative stage, resting stage, or the resorptive stage. The resorptive stage is supposedly the maximum stage of pain. Where exactly your tendon becomes calcified? It becomes calcified at the watershed area, which is more hypovascular, which is around 1 centimeter proximal to the footprint of the tendon onto the greater tuberosity. Histologically, this zone represents the collagen fiber orientation and the mechanical fibers properties getting shifted, making it vulnerable, prone for injury, tears, and calcification. Calcium generally forms at that critical zone and gets migrated because of tension and compressive forces within the tendon either within the tendon, subbursal, intrabursal, intramuscular, intraosseous, and sometimes intra-articular migrations. So this is how the pathogenesis, the primum movens of the pathology is this. The nutrition to that particular critical zone arrives from the subacromial bursa. So that subacromial bursa does not provide that amount of oxygen to be present within the tendons, which causes a fibrocartilaginous metaplasia, which makes the tenocytes transform into chondrocytes and thereby chondrogenous matrix that progressively calcifies. If you really understand this pathology, this is not actually a degenerate tendon, this is a normal tendon where there is calcium. Let us understand the stages of a calcific tendinopathy. Uthoff lower cycle, there is a normal tendon which becomes pre-calcific, then calcific, then becomes post-calcific. And during the calcific stage, you can have the formative, resting, and resorptive stage. And this is where most of your tender interventions must be done because the calcium is likely to be more liquid and paste-like at this stage. In the resting stage, generally it is very hard, casting a posterior acoustic shadow. Why staging is important? Because the patient's symptoms do differ, imaging appearances do differ, and the physical consistency also differs. So you decide about the type of needle intervention required only based on the staging. Calcification stage, either it could be in the formative and the resting stage, where it can be mostly asymptomatic, unless if it is more than 1 centimeter in size causing a subacromial impingement. X-ray, it is generally well prescribed, that is circumscribed, and you can see there is a posterior acoustic shadowing on the ultrasound examination. This is likely to be hard and chalk-like material. In the resorptive stage, where there are most symptoms happening here, there is a liquefaction of the solid phase and it becomes more soft and gets migrated, causing acute severe pain and restriction because of the movements. And it lasts for around 2 weeks, where there is an ill-defined calcium. There is no circumscribed calcium, there is an ill-defined calcium, and there is no posterior acoustic shadowing. This is the most common timing for your intervention. As such, the clinical presentation here, pre-calcific, calcific, and the post-calcific stage, the pain maximum being at the resorptive stage of the calcific stage. Patient selection. Never select a patient who is asymptomatic. Leave them alone. Don't do anything. If there is dystrophic calcification, don't do a barbotage, because this is a degenerative tendon, not qualifying for a barbotage. Again, textbooks are only guidelines. These are not set of rules. I always bypass rules. Calcific tendinitis happens in a healthy tissue, so always try to do the needling. The needling should not be targeting all the calcium to be removed, because we are not going to be successful 100% of the times. Just try maximum to remove all this calcium if possible and leave the cell-mediated immunity to take care of the tendon. Why interventions? Because of these evidences which are there. This is a set of 179 patients, out of which nearly 47% of the patients who required a secondary intervention in the form of either a rebarbotage or maybe a subacromial bursa injection. But very clearly, this has got an immediate good pain relief. The VAS score has reduced from 8.5 to 2 on an average. So it is always a good pain relief method. Doing a barbotage or a perforation or at least a subacromial bursa injection with a steroid, it's a good pain relief method. Secondly, this is a meta-analysis, right? This is on a set of patients who are more than 900 patients they have done. Again, the success rate of immediate pain relief is good, even though these patients will require a secondary procedure. So what are the interventions? Depending on, this is a landmark study published by Kevin Chang et al. So depending on the different stages, actually, the clinical findings, sonographic findings, and the ultrasound procedures. This is the calcific, this is the post-calcific stage, where the migration would have happened into the joint space or the subacromial bursa, where you require, means the patient can develop a adhesive capsulitis, for which you require an intra-articular injection, whereas a barbotage will be required only if there is no posterior acoustic shadowing. It looks like a big chunk of calcium causing impingement, whereas a hard arc of calcium where there is a posterior acoustic shadowing, you require a needle perforation. Why scanning is important? Because I do receive phone calls from very senior people, which is the best position for probing as well as for needling for patients with calcific tendinopathy. Definitely, there is no standard way which is actually being followed. You should probably do a proper routine scan and try to find out where exactly you are. You could see where all the calcium could be there in a single patient actually. This is the supraspinatus. At that point of insertion, you can see there is a calcification. This is at the lesser tuberosity. This is the greater tuberosity. Lesser tuberosity, you can see another finding, that is the subluxated biceps. Infraspinatus, there is a calcification, which does not cause impingement, so I don't need to touch this. And there is another calcification in the same patient, a very peculiar place, that is on the teres minor. Very, very important to do the scanning. Try to find out what is causing the symptom rather than actually tracing out and tracking all the calcium and doing a needle intervention. Definitely not warranted. So what are the interventions? As discussed, it could be a simple subacromial bursa injection, a barbotage, a needle fenestration, or a needle perforation. A subacromial bursa injection, where all it is useful? When there is a small speck of calcium, striated calcium within the tendon substance. When you yourself are not very confident about doing a barbotage, in spite of having a big calcium chunk, definitely it is worthwhile doing. A calcific bursitis following a needle barbotage again warrants a subacromial bursa injection, and steroid is mandatorily to be given into the bursa. There is no way you can avoid steroid in this particular scenario. Fenestration, again, small chunks of calcium, small stripes of calcium within the tendon substance. You create a needle opening with a needle so that you leave the cell-mediated immunity to take care, and no need for complete removal, as I have already discussed, because complete removal is just not possible in any of the cases. So what exactly is called impingement? This impingement can be caused by even the smallest speck of calcium. Can you see this? This is a small speck of calcium. In the next slide, I will be showing the video as well. That small speck of calcium trying to get underneath the acromion, causing lot of pain. The patient actually is resisting for the abduction. This is a very, very painful arc because of this seemingly very, very small calcium does not qualify for any needling at all. But since it is causing an impingement syndrome, you need to actually do a small little needling there, trying to do a fenestration. This is what is called fenestration. I try to enter into that cavity, small little cavity to be negotiated with, trying to push in a little bit of saline into it, not possible. So what I try to do is try to do a fenestration. As I do the fenestration, you can see the shift of the calcium into the bursa. This is of utmost importance in addressing the pain. Without doing any subacromial bursa injection with a steroid post any of the needle interventions, it is criminal. Generally, when you inject into the subacromial bursa post intervention, it's a little sticky wicket. So very difficult to open up that space. You'll have to be very, very slow and steady, and then open up the bursa, give a local anesthetic and steroid shot. And perforation is something which I discussed earlier, a well circumscribed calcium on an X-ray, and there is a posterior acoustic shadowing like this, and do a needle perforation with an 18 or a 16 gauge needle. It will be very, very hard, and you have only one chance to get into that cavity. If you get to deviate from that particular calcium, it is very difficult to go beyond that. So always try to do this. That's a needle perforation. Then comes the barbotage. Barbotage, always try to see the long axis and try to see where exactly the cavity is. Plenty of scans, different types of probe position, patient position, all that is necessary, and try to do which is the least painful position for the patient, because the patient is going to have excruciating pain. Use an 18 or a 16 gauge needle, 1.5 inches needle. Do not use a spinal needle because you won't get the stability for the procedure. And you can use a single or a double needle technique. I prefer single. and only one possible attempt which will be your best attempt. So try to get the particular image which is necessary, and you can't choose your images or needle visualization. So barbotage, again, lignocaine dosage calculation is of utmost importance. Do not keep on using 2%, 2%, 2% lignocaine. Always choose your dosage. Use only 1% lignocaine so that you will have buffer of injecting lignocaine. Either use saline or lignocaine. Use 2 ml syringes with 1 ml aliquots devoid of air. Air, you inject a little bit of air inside, you have spoiled the procedure and there is no further barbotage for the day. Right? So this is an infraspinatus barbotage. The infraspinatus scanning, slightly bigger calcification, so I try to intervene almost the size of the tendon. Initially, I tried to do a fenestration because I couldn't see the entire tendon, means like it was all different small chunks of calcium. I couldn't get into the cavity. But after some time, just got into that cavity, small little aliquots, 0.1, 0.2, 0.1, 0.2, that's all you need to do, nothing more. You need to have a lot of patience actually. Even if you don't see the needle tip is very, very much within the cavity, calcific cavity, so that I can see that fish mouth opening, trying to get it open and close multiple times, you can actually retrieve some amount of calcium coming out through the syringe. This is a classic barbotage. We may not get this classic barbotage every time you see. You can see there are a couple of calcifications on both the insertion site and close to the acromion as well. This is an 18 gauge needle getting into the calcific cavity. Slowly inject. Do not ever rush too much. And as I always say, textbooks tell you to push in saline and then aspirate. Never do that. Take saline, get into that cavity. First you aspirate. The moment you aspirate, you leave it, it will automatically push in. Aspirate, leave it, it will automatically push in. That will be the way to actually proceed for a barbotage rather than pushing in more saline. The idea is, if you push a little bit extra saline into that calcific cavity, one, it may even spoil the procedure. You may not be able to visualize better. Second thing, the calcific cavity can actually give way so that it can spread anywhere and migrate everywhere. So the volume also is very, very crucial. Do not exceed that 0.5 ml. Subscapular is again calcification. Address by doing a good scan. See this? You don't see any posterior acoustic shadowing. Then do a proper intervention into that particular calcific cavity. Even if you are not able to do it, never lose heart. Try to do a normal fenestration and come out and then do a subacromial bursa injection. This is a calcific tendinitis, that is both calcific tendinopathy are dystrophic calcifications. Again, textbooks do say that, do recommend, don't do it for calcific tendinitis because of dystrophic tendon degeneration. I do it even in tendon degeneration because I choose to give PRP after 4 weeks. After 4 weeks, a degenerate tendon will warrant a PRP injection, whereas a normal tendon will not require any PRP injection. So it's all by repeated doing, you will get that needle steadiness, and the hands will initially will not come. There will be a lot of hesitancy, but once you keep on doing, it will come up. See, this is a dystrophic calcification. There is no calcification after 3 months. So you can get results even in dystrophic calcification, provided the pain also goes only with a good regenerative therapy. Sometimes you are very lucky if you have a patient like this, a proper bursitis will be there. Initially, there was so much of bursitis, I could aspirate that fluid with a normal 21 gauge needle. I used a slightly bigger needle because that fluid is likely to be viscous. Likely to be viscous. Trying to do the short axis and the long axis scan. Find out which will be my best position for the needling and trying to visualize the calcium as well. This is the calcium chunk. Right? Now the patient is ready for the procedure. First, do a subacromial bursa injection, aspirate it. Since this was a good buffer of fluid inside, aspirated, gave a steroid, and then did the barbotage. I'll finish off. The same patient actually, a single needle technique.
small aliquots, gentle movements, not much is required. You don't really need to push. You just have to pull, it will automatically push. Pull, push, pull, push. That's hardly a matter of 0.1, 0.2 ml getting inside. Trying to aspirate so much that it comes, and the end point for your aspiration will be that no negative aspiration of calcium. The end point should not be to get a radiological clearance, because very, very unlikely that all the patients will have a radiological clearance. This is one technique. Again, patients who actually have a migrated calcium, a little larger chunk getting into the bursa, you can do a saline lavage so that you will be able to clear off the entire set of calcium which is there. Such a big calcium chunk, you can clear it only after giving a good lavage actually. Unless you do a lavage, definitely you can't actually get a, aspirate out of it. Again, this is not something which is described in a textbook. But when you get a scenario like this, you can definitely use it. It is definitely worthwhile also. This is a seemingly a very, very small, thin chunk of calcium. If you could see that, it's a very small, thin chunk of calcium, but very, very, like, I was surprised to see the amount of calcium which actually came out. It came out very much paste-like. One thing which I understood after this particular patient is, it is only the stage of the intervention which matters rather than actually the size of the calcification. If you do it at the ripe stage, which I call it the ripe stage is the resorptive stage of the calcification, definitely you will have a good amount of calcium coming out. If you do it at very hard stages, probably the patient selection was wrong.
We are oversitting, yeah.
The patient selection was wrong. Probably you will not be able to get the right results. Again, the last one. If you don't get a good visualization because of a coracoacromial arch there, only with ultrasound, definitely it is worth going for an intervention with a hybrid technique. A hybrid technique, you can use either a single needle or a double needle. Here I have used a double needle for only one reason, because I was not sure whether I was within the calcium or not. So I had to use fluoroscopy. Then I realized it was not there into the calcification. I decided to go for a double needle technique, where the technique was to actually use fluoroscopy plus ultrasound and take out all the calcification. You can see the results there on the table, right? Last but not the least, there is an element called calcific arthritis, which actually happens after migration of your calcium into the glenohumeral joint, where you could see there is a calcium which is there into the joint space. Can you see that? Generally, when you have a calcific arthritis and an adhesive capsulitis post-barbotage, you always try to do this particular maneuver, injection, that is the rotator interval injection, a low or a high volume hydrodilatation, which will migrate your calcium into the subacromial bursa for sure. It is going to migrate to only one space, that is the subacromial bursa. If it gets into the subacromial bursa, it is very easy to treat. It's a simple subacromial bursa injection with a steroid. Nothing else is required. Yes, you could see there is the subacromial bursa filled with calcium. So it's very easy to treat. Need not actually take it out. You can actually give a subacromial bursa injection, and then why and why nots. This is the last slide which I will discuss. I think let us close this. So textbooks always prescribe 5 ml syringes. I always say use a 2 ml syringe, not a 1 ml syringe, a 2 ml syringe, because this is a formula which all of us are aware. Pressure equal to force divided by area. These two are inversely proportional. You will get a good pressure if you have a smaller area. So 2 ml syringe is always good. If it is local anesthetic or saline, see how much local anesthetic, what dosage you are going to use. Second thing is push or pull. I will say it is pull first. Why not dystrophic calcium? Yes, you can do it for dystrophic calcium. Why not PRP? Because the tendon is a normal tendon. Is radiological clearance mandatory? No. Because cell-mediated immunity is there to take care of the long-term results. Till which size? Till the size which causes an impingement. These are the take-home points which I am not going to repeat it. And for future, you will have devices for doing a barber touch. For future, you will have non-invasive methods. Definitely, it is there already. High-pressure devices for irrigation, ultrasound-guided nano-life, or even an arthroscopy-guided ultrasound needling, which is there already. Definitely, these are the things for the future. Thank you so much.
Yeah, thank you, Dr. Madan, for a wonderful lecture. Fantastic, well covered. All the aspects. Very well done. Thank you.
Thank you, Dr. Madan Pandyan, sir, for that clear and practical session. I would like to call upon stage Dr. Bibu Kalyanidas, ma'am. She's the Director Academics, HOD Anesthesiology, Critical Care and Pain Clinic. She's a Course Director of DNB, PDF Neuroanesthesia and Neurocritical Care at Institute of Neurosciences, Kolkata, to chair this session. Thank you, ma'am. Now we call upon Dr. Krishna Podar, ma'am, who will guide us through a biculoplasty, a minimally invasive option for discogenic pain management.
So good afternoon, everyone. Just want to know how many of you are doing the disc procedures? Endoscopic discectomy, I know how many people are doing. How many? No. Discography or ozone disc? Okay. So it's the same thing when we do the biculoplasty, the entrance to the disc, any disc procedure. You go to the same. Here basically we are doing the biculoplasty with the cooled radiofrequency. So we are just doing the radiofrequency of the annulus part where the pain generating nerves are there. So how it helps? So what is the intradiscal cooled radiofrequency? Biculoplasty is a minimum invasive procedure that uses the cooled radiofrequency energy to treat the low back pain because of the degenerative. It should be degenerative. There should be no disc prolapse which is causing the radicular pain. So here 2 RF cannula goes. So how we'll go in details. The main important is the patient selection. For any procedure, you need to have a patient selection. It should be axial low back pain without any radicular symptom. And they will be exacerbated with the prolonged sitting, or sometimes patient has a forward flexion. When patient has the forward flexion pain, it's a discogenic pain. If it has the extension pain, means it is a facetogenic pain. So no improvement from the comprehensive. That should be always there. Whenever you want to do any advanced procedure, there should be always try for the conservative program. Absence of any inflammatory, because sometimes this patient come with the overlapping and they come with the, so you should always ask the history of the morning stiffness or pain, or if needed, sometime ankylosing spondylitis you diagnose in a very later stage, 45, 50, sometimes we think this is the age, maybe that, but to the surprise, the back pain, they come with this, then when you do, and that maybe have the inflammatory. And they may have the disc prolapse. So, if you do the 100 MRI, you can see there are 90 MRI have the degenerative disc. That doesn't mean they need the treatment. So your patient selection should be very good, because this is a very advanced procedure. So absence of prior surgery, it is very, very important. No neurological finding, negative SLR. Disc height should be more than 50%, because here the cannulas are going to cannula. So it should be more than 50%. And positive spring test means you can reproduce the axial back pain with the direct pressure over the suspected spinous process. So what is the pathology, how it work, how the biculoplasty work for the disc degeneration? So there is a small post-traumatic peripheral tear, maybe annulus tear is there, so that after the tear there is a fibrosis. And there is a dehydration of the intervertebral disc. And this annular trauma, it has been seen in the sheep, if this annular trauma, it can be cause maybe anything. It may be the only degenerative. This can cause the, and this support the theory. So whenever there is a disc degeneration and injury, It is a centripetal growth of the nerve fibers whenever there is a neurovascularization occurs in the annulus, because pulposus has no nerve or no vascular supply. So more extensive disc innervation and the severely dehydration lumbar disc compared with the normal disc, it has been seen whenever there is any disc degenerative pain. So there is a small unmyelinated nerve component extensively innervation of the inner part of the annulus, which is the cause of the nociceptive pain. So there is a no neuropathic component, it is basically only nociceptive. If you see the MRI, you can see easily there is a black disc or disc degeneration. So you can see there is the black disc and disc degenerations, and it may be sometime high intensity zone. And MRIs should always correlate with the symptoms, and if there is the main important, the disc height should be more than 50%. It may be some loss of the height, because disc degeneration always causes the loss of the disc height, but it should be more than 50%. And there should be no neural compression. If there is any neural compression, first treat with that, because if you do, then there will be no results. So if maybe the loss of the nucleus hydrostatic pressure, it may cause the delamination or fissuring, delamination of the disc, or microfracture of the collisions and the sensitization of nociceptive, which is the cause of the, and then it causes the stimulation of DRG, which is the cause of the discogenic pain. So how it helps whenever you do the intradiscal biculoplasty? What is that? First of all, it is causes the very easy to use. It is as any disc procedure you do, it is the same thing, and it is a bipolar heating lesion which is causing, and there is a isotherm. So you can see the dumbbell shaped lesion is there, and these are so whenever dumbbell shaped lesion occur, there is an isothermal line which is the affecting the nociceptive, which are in the annulus. Before that, you must do the diagnostic discography, because, and you can do in the same setting also, but at that time it will be risky, because then you cannot see the actual where you are ending up with both the cannulas. So it's better always do in the different position to identify the symptomatic disc, but maybe you have 3-4 disc level which are the have the degeneration, and you don't know which is the more painful, and it is always better, and discography is done for the other things also. Main procedure, patient is in prone position, and you should treat like any disc surgery whenever they are done. You should be totally sterility you should keep in mind, and always doing the MAC and IV sedation. IV antibiotics is very must, and do not inject the contrast, because then it's very difficult to have this contrast or antibiotic or saline will react with the lesion, we don't know. There is no studies available, so you should not inject anything. So here the patient is in prone position. AP, first you do squaring of the end plates, as you know, whatever your target site. After doing the squaring off, you do the oblique to know the Scotty dog appearance, so that the facet should do the in the midline, it should bifurcate the disc, and it is in the AP oblique view. So I think most of the here pain physician know how to acquire this position. Then we should see locate the skin insertion site, to give the local anesthesia proper way, because the cannulas are very big. It's not a small 22 gauge needle. It is normally 17 gauge cannulas. So it is a big, so you should insert very good amount, because it's very painful. You advance, the most important thing whenever you give the cannulas, so it is very, very important. The introducer should be 1 centimeter into the disc, and it is a posterior 1/3. When you see the lateral position, and both the cannula should be apart from the 2.5 centimeter, because lesion is weak. Lesion is 2.5 centimeter, so both the cannulas have the apart from 2.5 centimeter, more than 2.5 centimeter, and it is a posterior 1/3 of the disc. It should be annula. So when you confirm the introducer position, you should see that it should be just last 1 centimeter deep, not more than that. So you give the bilateral cannula, you repeat the another side, and then insert the probe into the disc. So there is a probe bilaterally, you can see, and it is a medial pedicle line. It should be not more than that. So when the cannula is the introducer cannula is the medial of the pedicle line, then it is the best position, and you should not go beyond that. So check the probe placement bilaterally. It should be in a P because, and it should be the middle of the disc. You can see here the middle of the disc, not the superior end plate or inferior end plate, because your lesion is around the cannula. So it should be the middle of the disc. So here you can see. And you can connect both with the Y connection. There is a cooled radio frequency machine that we have the Y connection. You can do for the bilateral lesion. If you are doing biculoplasty, then you should connect both the together. And it is a 15 minutes lesion with the 50-degree temperature. So in the bipolar, you set the 50 degrees centigrade and for 15 minutes. If you want to do the monopolar lesion, then set temperature up to 60 degree in the cooled radio frequency, and time is again like any medial branch you do, 2.5 minutes. So here is the video small, how I did. So this is the L45 disc. It's a visible, but whenever you take video sometime, this fluoroscope guidelines, so it is like the procedure and it's like that. Post-procedure, after procedure completion, remove the probe, discard and avoid the torsion. Main important thing, it is a heat lesion, so it is always take the precaution to transfer the patient, because if patient has any torsion and all, this can again injure the disc, and patient can has the long time back pain after that. So you should be very careful about that, how you are shifting the patient, and ask patient to have a LS belt for using the LS belt for that after the biculoplasty. Any disc procedure, you should give the clear instruction, because otherwise sometimes patient come with the more pain. So you should always give, and if patient has any radicular symptom, ask patient to contact you immediately. It is very, very important to ask the patient, and always keep the patient, because you are doing here thermal lesion, not the injecting any drug. So you should always ask the patient, if patient anytime in the procedure, if patient is complaining of any radicular pain, stop the procedure. These are the very, very important precautionary you should take. Then post-procedure complication, normally whatever complication happen with any disc procedure like the discitis, which you can prevent, and always take a complete and very, very importantly sterility as you do any disc surgery, do that. And always use IV antibiotics and post-procedure also. And if sometime patient complain of, one of the patient, they complain the persisting back pain, it happens, but mostly you can ensure the patient give the analgesic, because it take 1 day to settle. But if patient is complaining persistent pain and very severe, then you should always suspect the discitis. Whenever you do any disc procedure, even after transforaminal, also you should always suspect. It is always better you diagnose first if a patient is producing discitis, do the blood test, and you do the MRI with the contrast. In thermal injury, normally we don't, there are not much literature about any thermal injury. It is happened if you place correctly. It is if your placement of the cannulas are good, then there is a not thermal injury. So other complication like it can happen again, so you should avoid, ask the patient to avoid lifting, bending, twisting, turning over the bed, and give the good PT program, not a very aggressive, and LS belt also. The other complication like soreness, swelling, bursitis, these are common. Any procedure which can cause this type of the complication, it can, but it is rare. Infection, bleeding, increased pain, nerve damage, allergies, failure of technique. Yeah, we are intervention pain physician, we know it can happen anytime, so you should explain. If the patient, most of the time, you know what happened, patient, not particularly this procedure, with any procedure, आपने तो बोला था पूरा ठीक हो जाएगा, पेन नहीं आएगा. So this type of the counseling is very, very important, because this type of the things you face many times. कि how much recovery, how much pain relief, for how much time pain relief, it is very, very important to say. So if you say any evidences, so randomized placebo control trial has been done with the transdiscal radio frequency with the lower back, and it has been seen no procedure related complication, and there is a significantly improvement in the pain for 6 months to 1 year. Again, if you see any pain procedure, you will see the most of the data are up to 1 year, not more than that. It is published in Pain Medicine, again the 22 patients with the long-term follow-up, and for long-term follow-up is again for 1 year, and it is a sustained improvement in the back pain and function. Again, 1 or 2 studies where we have compared with the intradiscal biculoplasty with the pain management program, which includes the physical therapy, pharmacological therapy, minimum invasive intervention like epidural, sacroiliac joint injection or facet joint injection, or the behavioral therapy with that. And it has been seen for the 6 months, if the patient has been a biculoplasty, it has the better pain relief than the conservative management. So up to the 50% reduction rate in the VAS score for the patient who underwent for the biculoplasty. PANGS study is again at 21 disc has been, they have published in the Journal of Bone and Joint in 2005, and here the 15 patient with the discogenic pain, and it is all aging, and it has been done histopathological features like fibroblast growth factor, they have done this, and the results they have seen it causes the reduction in the pain. One more publication in 2014 in the radiofrequency intradiscal, and the results are again intradiscal biculoplasty has the better result.
Dr. Poddar,
it is a randomized control study.
Your time is up.
My slides are up. Thank you so much. It's finished. Thank you.
Excellent presentation. And I request the organizers, they should have some time for the discussion. If there is no discussion, no point in such beautifully presented, and what are the questions from the audience?
I invite everyone to go forward with questions.
I should ask the,
Yes, sir.
Yeah, I would like to ask, do you always do discography before we proceed with the biculoplasty?
Yeah, it is always recommended to do the discography. I have done one or 2 times, but most of the time, my patient has the clear-cut back pain with the 1 disc involvement. Then that time I don't do if MRI is showing 1. But it is always recommendation to do the discography.
What I know the discography is we have to do 2 normal level plus 1 abnormal level to confirm.
So you have to do all 3 discography to see which one is causing back pain.
Yeah, I'm not too sure.
Not in the normal disc. If you have the 3 degenerative disc in the MRI and patient is saying back pain, that time you have to do which level is more affected for the pain. Not all 3.
Okay, thank you, because we don't have
also
any
an
time.
indicator for discogenic
Doctor, you can also discuss with her afterwards.
Okay.
We don't have time. Thank you, Krishna, for that excellent. But I have only one question.
Yes, madam.
You mentioned that these people, they don't have any neuropathic element,
Yes.
only nociceptive. But all the time we get the patients who have neuropathy also.
That is why, madam, this procedure is for back pain, discogenic back pain, where the disc degeneration is there. Otherwise, you can do one thing, you give the transforaminal for that patient.
So you proved that by NCV that they don't have any
No, madam,
neuropathy.
you don't require, patient doesn't have symptom of radicular pain, why you need a disc?
Any heaviness like that, anything they don't have. Okay, that's fine. Thank you. Let us move to the second speaker.
Thank you, Dr. Krishna Poddar, ma'am, for that excellent presentation. Now, everyone, please join me in welcoming Dr. Pratik Shah, sir, who will speak on transforaminal endoscopic dissectomy, an advanced approach in spinal interventions.
Thank you, Daradia Pain Foundation and Dr. Gautam Das sir for giving opportunity to deliver my talk on transforaminal endoscopic discectomy. So we have to do this through the foramen. It is a natural foramen. Okay. So you can see this why endoscopy is different than other procedures. So you can see this in endoscopy with small cannula we can visualize the more tissue, okay, in compared to microdiscectomy or open spine surgery. So it is always a beneficial. Okay. So the advantages are good visualization, it done under local or epidural anesthesia, preservation of facet joint and posterior ligamentous complex. So maintain the stability of the spine, infection rate is low, minimal invasive, only 1 centimeter incision. So post-operative pain is also less and no muscle cutting, only split with the dilator. Okay. So there are two different approach for endoscopy, interlaminar and transforaminal. In my talk, I am talking about only transforaminal. So today's topic will be covered is small anatomy, indications, contraindication, infrastructures, patient selection, how to do procedure, complications, post-operative protocols, and case discussions. So all we know the anatomy of the lumbar disc, and we have to do the transforaminal endoscopy in a posterior 1/3 part of the disc. Where the disc protrusion is there, it may impinge the nerve root. So we have to remove some part of the disc fragment from here. So just briefing the anatomy of Kembin's triangle. So this exiting nerve root is situated here on a lateral aspect. Inferior is vertebral body, and this is the superior articular process. Okay. So we have to introduce our cannula from this size. And the size of the foramen in normal adult with good 5.5 or 6 foot height is around 15 to 12 to 18 millimeter dimension. So easily we can insert the 7 to 8 millimeter cannula from this triangle. So indications are unilateral symptoms of the disc herniation is preferable. Extraforaminal, foraminal, subarticular or central disc herniation can be tackled out. Grade 1 and sometimes grade 2 herniation, and in some cases of infections which is limited to disc only, we can do the debridement of disc through the endoscopically. So the classification is there are two types according to grade. See, the grade 1 is protrusion up to here, grade 2 here, and grade 3 it is almost compressing the spinal cord. And according to the zone wise, it is a central zone, this is subarticular zone, foraminal zone is here, and extraforaminal zone which compressing the exiting nerve root. Okay. So these are the different examples of the pathology. So you can see here is a central disc herniation, and next slide is this is paracentral or subarticular herniation. This is subarticular and foraminal. So we cannot find exactly the same type of herniation, but it is somewhat like this. And this is the central herniation with grade 3. This is almost a cauda equina syndrome like symptoms. Okay. This is the foraminal herniation, and this is extraforaminal herniation. You can see it is outside the foramen and it compresses the exiting nerve root. So the herniation till this level is compressing the traversing nerve root, but extraforaminal herniation compressing the exiting nerve root. Contraindications are the lumbar canal stenosis. You can see this stenosis. So endoscopically it's very difficult to remove through transforaminal endoscopy. We can do interlaminar or open microdiscectomy. High iliac crest is another difficult case scenario in which this, if we have to do L5-S1 level, then the traversing of the endoscope and trajectory is difficult. There is too much slanting here, and there is a technical difficulty. So better to do an interlaminar. Spondylolisthesis case, in that case we need to go for a fixation. So mostly not possible to give benefit through transforaminal. Caudal or cranial migration. So it is difficult to remove this caudal migrated fragment through the transforaminal. So bilateral lower limb radiating pain. So obviously if we are doing from one side, so we can give a symptomatic relief on one side. So opposite side it is difficult to do this. Other contraindication is a trauma, tumor, bleeding coagulopathy, metastasis and infection involving the multiple disc herniation. So basic infrastructure required is a good size of OT is required. This is my endoscopy unit. So the camera, light source, this is a cautery which is a high frequency and screen. Okay. This is the endoscope. This is the 30 degree. There are variable endoscopies required, but 30 degree endoscope is enough. And the size is around 21 centimeter, 16 to 21 centimeter is available. German is also available. Chinese is also available, but prefer to start with the German. Basic endoscopic instruments are the endoscopic needle, guide wire, dilator and sleeve, mallet with Teflon head, grasper, forceps, annular cutter, and German instrument are preferable. Indian instrument is also available, so that are moderately good quality. This is endoscopic needle and guide wire. This is dilator and sleeve. This is camera, light source. These are some other instruments. Grasper, basically we need multiple different size grasper. So different diameter is this is 3 millimeter diameter, this is 2.5 millimeter diameter, and this is jaw is also different. This is 5 millimeter jaw, this is 8 millimeter jaw. So variable is required to grasp a different size of fragments. This is a palpation hook. So we have to basically in this you can see this this fragment is situated here. So if we have to down this fragment inside our tube, then we have to manipulate with this. So it will come here and we can remove through our cannula. This is a curette and this is a annular cutter. So many times after completion of surgery, if annulus is tight, we need to cut some part of the annulus to give a proper release of the nerve root. RF cautery. So patient selection, history and examinations are the short duration of history is preferable. To start practice, unilateral distribution of pain, young to middle age patients, old age patient, long duration, motor power weakness, cauda equina are the not used to prefer in initial type of practice. Obviously this is paracentral herniation. So to start with the practice, you select this type of patients. So preoperative requirement is a full explain patients to procedure, preoperative routine blood test, physical fitness, informed consent, antibiotic, type of anesthesia mostly local, and nowadays epidural anesthesia is commonly given. Position of patient is the prone position with good support below the abdomen. Skin markings are there, but mostly it is 10 to 12 centimeter on the side of the lesion. So these are, I am not going into detail, but this is the midline, and we have to do our procedure from almost at least 10 to 12 centimeter or 14 centimeter lateral to the midline. This is the position of the patient, painting and draping. So this is the 1 centimeter incision. We have to introduce our needle in AP and lateral view. No need to do any oblique or angulations. In AP, our needle position is in the mid pedicular line. This is the pedicle. So we have to keep our needle in AP as a mid pedicular, and in same view lateral position it is a posterior PLL line. Okay. So this is extradiscal position. Now introduce discal needle more inside, so it is in the center of the disc in AP view, and in lateral view it is a posterior 1/3 part of the disc. So this is the painting and draping and discography. So you can see this, there is a purely fully degenerative disc. My dye is spreading everywhere inside the disc. So after introducing needle, we have to introduce the guide wire, and over the guide wire we have to introduce the dilator. So this is the final position of dilator, posterior 1/3 part of the disc, and this is in AP, it is a center part of the disc. So dilator and sleeve. Okay. So this is the position of the sleeve. So introduce the grasper, and there is a small video which shows removal of the big fragment. So you have to catch this big type of big fragment from the grasper, and sometimes it is difficult to remove such a big fragment. Okay. So this type of the fragment is removed. Confirmation of decompression by free fluttering of the annular flaps, epidural oozings are there, visual confirmation of removal of the entire herniation, relief of pain given by, confirmed by the patients, visualization of the decompressed traversing nerve root, and this small video showing decompression of the nerve root. And in this video, this is the dorsal aspect, this is ventral aspect, one side of the end plate, and other side of this is cranial and caudal end plate. You can see this is the nerve root. Okay, so this nerve root is now freely moving with fluttering. Complication and management, inadequate decompression. So just one of my case presented with this type of herniation. I did, you can see dense plaque. I did a transforaminal endoscopy, and you can see there is a good amount of decompression here, but annulus is almost fibrocalcified. So patient didn't get any symptomatic vein relief, and ultimately I went to go for microdiscectomy by orthopedic surgeon's help. Incomplete pain relief. So after disc decompression, lots of patients have a facetal arthropathy pain. 30% of my patient, 30 to 40%, I need to do a RF treatment for facet. Some patients have SI joint pain, some patients have a muscular pain. So we have to think and check each and every patient to give a better pain relief. Another complications are bleeding, which is controlled by bipolar radiofrequency cautery, and sometimes just do compression with help of the dilator. Nerve root injury, if you are doing a good instruments and good visualization, then it is rare. But if it is there, then we have to check by motor power of the lower limb intraoperatively, and procedure should be done under local anesthesia. Another complication is infection, discitis. We have to do for antibiotic, go for 6 weeks, or endoscopic debridement, and if required, spine surgery with fixation. Dural tear, small tear, conservative approach. Major tear, surgical intervention may be required. Other complication is perforation of peritoneal sac or injury, though these are the rare complications. There are some missed fragments, instrumental breakage, hematoma, postoperative dysesthesia. So overall, I advise my patient to take bed rest for 3 to 4 weeks, lumbar strengthening exercise after 1 month to be start, and continue for at least 3 to 6 months. Avoid heavy workload for 6 months, and bending forward avoid for 6 months. This is just one case discussion. There is a 20-year-old female suffering from low back pain, lower limb radicular pain. So MRI shows L5S1, disc paracentral herniation, and just after 6 months I repeat the case, and you can see there is a nice decompression and totally free the traversing nerve root. Same patient, this is the protrusion, and here it is very good decompressions. Okay. One other example is a single disc infection, 38-year-old male patient with spontaneous onset of spondylodiscitis. I did a transforaminal debridement endoscopically. You can see before patient presented with L3-4 disc. These are the only single disc infections. These are different views, and this is after at least 1 year. Nicely, that disc is fused with good amount of the calcifications. Okay. So take home message is endoscopic discectomy can be learned by proper training under good and experienced teacher. First 10 to 20 case endoscopic should be done under guidance of senior. Quality instrument must require for safety and efficacy. Thank you.
Thank you, Dr. Shah, for that excellent. You have done so much, very good, excellent. So one thing that nowadays, after 1973, the triangle was described by Parvez, and now at this time we are more going for the endoscopy because of the development of technology.
Yes.
So that is the thing. Nowadays the surgeons are also doing unilateral biportal. So it is very easier and to go for unilateral and biportal discectomy. So that is very another
UB,
thing.
it's called UB.
We had that symposium few days back, so by the spinal surgeons. So we are also, we can do that. Our pain physicians, they can also do that.
Yes.
Thank you very much once again.
Thank you.
Any questions from the audience?
Sorry.
Thank you, Dr. Pratik Shah, sir, for sharing your expertise. Our next speaker, Dr. Madhujit Gupta, sir, will shed light on interlaminar endoscopic dissectomy and its role in modern spine care. Let's welcome him.
Good afternoon, everyone. After Dr. Pratik's explanatory, presentation on transforaminal discectomy, I will be talking about interlaminar endoscopic discectomy. So, whatever be the approach, either end-on or from the side, the target should be the same. You need to achieve the same final goal, that is to remove the herniated disc. I would like to tell you this thing very honestly, that all endoscopic method, different approaches, they have their own sets of advantages and disadvantages. And it's the expertise of the individual practicing it. I mean, he can deal with near almost conditions through the technique he has mastered. All the techniques have its own learning curve, and there are no shortcuts to it. You can bend the learning curve with the help of guidance and proper mentorship. And fair share of failures and complications are always there. Nobody talks about that mostly, but I think it should be done. So when do we do interlaminar? Where do we prefer? Especially in L5-S1, where the iliac crest is obstructing your approach through transforaminal route. Then in L1 through L4-5, L1 to L4-5, since the transverse foramina is wider and the interlaminar space is narrow, it's preferred to go for a transforaminal route in upper lumbar levels and interlaminar route in the lower lumbar levels, as in L5-S1. For central herniations, large disc, migrated disc, instability, or bilateral symptoms, it's always advisable to go for an interlaminar approach. The anatomy is, we all know, even during our anesthesia days, we were talked about the anatomy of interlaminar space, the boundaries of it, and the ligamentum flavum, which is a butterfly-like shaped curtain which connects the upper lamina to the lower lamina. The dural sac is very close to the ligamentum flavum, especially at the midline. So it's very important to judiciously handle that area while removing the flavum. And that's why advised to go to cut the flavum from the lateral aspect. So how important is the port placements? It's basically to reduce the reduce the damage to the spine, and proper targeting of the extruded disc helps in that. I must say that the interlaminar window and the discal window are two different things. They are at an angle. So if you consider the upper rack to be the discal window, so if we approach from the interlaminar window, we need to go at an angle. So if something is jutting out of this margin, it's easier to just get hold on through interlaminar route. But if I have to place a implant or something where I have to go inside the disc, I need to be in front of that particular level. So that requires bone resection. So considering the lumbar lordotic curvature, if I square the vertebral margins, this much of bone is required to be removed to get an access to the disc. This is again shown in the model. If you could see, I have placed this dilator at the spinal minor junction, and it will coincide with the discal window. So I need to remove this much of bone or bur it to get access to the disc. This is again the same thing which Dr. Pratik had said, the different zones where the herniations happen. And this particular region through interlaminar root where we generally dock. So if a downward migrated herniation is there, it's easier to grab, hold on. And this is the shoulder of the exiting root, which would exit from the foramen below. We work out around this area. And this is the axilla. So preoperatively, the consent counseling, antibiotics, investigation, I emphasize on counseling because I generally do it under sensory epidural and local anesthesia. So the patient need to understand that very clearly. So I would be discussing 2 or 3 cases here. So this is an L4 herniation here. You could see a downward migrated disc extruded fragment here. This is a second case where L3-4 herniation is there, almost obliterating at L3-4 level on the right side. Both the patients had right-sided symptoms. So the OT setup, Dr. Pratik had explained, it's all the same. The scopes and the bipolar and everything. Port insertion. So the level you need to mark first as per the surgical. It requires a lot of pre-planning. Before you enter the OT, you analyze the MRI film and you plan and chalk out the approach before going into the OT. So you mark the level, use a spinal needle to infiltrate local anesthesia with, mixed with adrenaline. This serves 2 purposes. One thing is to confirm the level which you are going to operate. And secondly, of course, it reduces the soft tissue oozing or bleeding while you put in the ports. Make a stab, introduce a dilator, and confirm in AP and lateral for precise docking. Introduce a working sleeve. The bevel is placed facing laterally, and then upon reaching on the bone, you just rotate it 180 degrees so that the bevel takes away the muscles, paraspinal muscles on the side behind it. So it won't obstruct your vision there. Then you introduce the scope. So local infiltration, this is the first case. Since it was downward migrated, I am more focused on the lower lamina. So you put in the dilator here. I have docked on the facetal pillar in the lateral view. Then I put the working sleeve. So this is how the sleeve is put, and then the scope is held. So you could say this is the discal fragment I have to remove. This is the superficial layer of the flavum. I have removed it here, so you could appreciate the 3 o'clock is the cranial end, 6 o'clock is the caudal, and midline is always at 12 o'clock, and 6 o'clock is always lateral in all endoscopy, interlaminar endoscopies. So I have removed the superficial layer here. This is a blunt probe to, clear the margins of it. Some of the superficial layer of flavum is still adherent to the facetal pillar. I'm using a burr to widen burring the upper part of the lower lamina here, so that I could get access to the migrated disc fragment. Now you could see the flavum is clear, the bony margins are clear. This is the facetal margin, and here is the flavum. It's always advised to do the bone work first before you just cut open the flavum and see the nerve root. So these are the facetal part of it, where I'm removing bit by bit through a kerosene punch.
and almost I have reached the lateral margin of the flavum here. So once you see the lateral margin of the flavum, you are pretty sure that you are not going to hit the traversing root there. Now, this is the root here. I am just using a nerve retractor and trying to medialize the nerve. It's just like this. I am putting a nerve retractor here. I am rotating it like this so that the traversing root is protected behind the root retractor and exposing the discal surface. So that is here is the fragment which is entrapped. So you tease out the fragment and then you grab it and remove it. It's badly stuck there, so you might have to use a blunt dissector or a hook. So I'm just forwarding it. So you just grab the fragment and you take it out. Before taking out the cannula, you need to confirm where, by image, where the fragment was. You just see that area, scan that area. So I have scanned it up to this margin, the lower vertebral body. It was clear of any discal material. This is the second case, that L34. Again, the same process. This is cranial, caudal, midline, and lateral. This is the flavum. I have exposed the soft tissue above. That's why, so that you could see, appreciate the view. I'm just forwarding it. I'm just cutting, because here I have to go inside the disc. That's why I am cutting the undersurface of the L3 lamina. As I had explained, to reach to the discal window. So I am aligning my bone work to achieve that. You free the margins of the flavum using a blunt forceps, blunt probe. You do a little more of bone work using Kerrison punch. It saves a lot of time. Then you kind of make a rent in the flavum so that the irrigation fluid, it gushes inside. It just pushes the dura away from the flavum. So when you cut open the flavum, you kind of exercise the safety. You use flavum cutter and Kerrison punch to remove this flavum. Now, after having removed, this is the dura here. The exiting root would be coming around this area, the traversing root, which would exit from the lower foramina. A little more clearing of the flavum. Now again, that maneuver to medialize the traversing root so that you get access to the disc. So here is the disc, and whenever you are removing an acute disc, it bleeds a lot after, it oozes a lot. It's better you use bipolar cautery, RF cautery to ablate, and then you maneuver with the help of a ball hook and tease out the fragment. And in the post-op, you check for motor power and other symptoms of the patient. This is the incision size you get and remove the fragments like this. It's again an interesting case where you could hardly appreciate this conflict area where is a kind of, it's disc, mixture of disc and the ligamentum flavum hypertrophy which is impinging on the root, L5 root, it's at L4-5. So the L5 root which would exit from the level below is getting impinged here. The patient had typical left-sided radicular pain, severe radicular pain, unable to walk. So this bulge was there. I'm not showing the video, it's just the image, just to give you a revision of the entire process. So once you enter, you get to see a picture like this. So you could hardly appreciate which side is what and where's the interlaminar space. Again, the cranial end is 3 o'clock, caudal is 9 o'clock, and the medial and the lateral. So once I clear off a little bit of superficial tissue, you could appreciate the margins of the interlaminar space. Sorry, this is cranial. This is on the right side I am standing. This is the caudal end. So you remove the flavum and you expose the dura. This is something here. Keep guessing what it could be. I would show you it in the last slide. So here is the exiting root. This is the exiting root, this is the dura, and this is the axilla of it. I mobilize the exiting root to get to the disc. This is the discal bulging part which was removed. And finally, this is the swollen root removed of all the flaval hypertrophy and all. It was freed, and this was the epidural catheter tip which I had introduced for the sensory epidural. So it's not a rocket science to do an interlaminar this thing. We do a lot of this thing blindly, putting a epidural needle inside around this area. So, but under vision, I think it's a pretty safe procedure. So just keep focused on the target, and I hope you would be able to achieve this. Thank you.
Very good. Thank you very much. How often you got a dural tear?
Ma'am, mostly dural tears are common when you are dealing with a canal stenosis, chronically spinal canal stenosis. I have 2-3 cases of
because
dural tear.
It makes your life horrible.
No, that's okay, ma'am. But most of the time, in my cases, most of the tears they happened afterwards in the post-op, not while doing it. Afterwards, like the patient strained a bit, like a patient who had who didn't disclose that she was constipated. That's why the patient many a times they get.
But I have seen patients after the surgery. I'm not saying that intervention. After surgery, patient has gone and then having a post-spinal headache type.
And nausea.
So low pressure headache, and there is a small bag in the back. So that is a very and the next complication is your infection. So both the things, and you very rightly described when to go for transforaminal and when to go for this approach. So thank you very much. Very well done.
Thank you.
Thank you.
Any questions from the audience? Thank you, Dr. Madhujit Gupta, sir, for that informative talk. Now we are pleased to invite Dr. Pankaj Surange, sir, who will present on targeted cementoplasty, a valuable technique in vertebral augmentation.
Madam, please come. Pankaj is going to speak then. It's a privilege to hear Pankaj.
Thank you, madam. Thank you so much, madam. Okay, so guys, I'm going to present targeted vertebroplasty mainly for the cleft fractures. I'm only covering the cleft fractures here, not the routine cases of the compression fractures, osteoporotic compression fractures. So these cleft fractures are mostly the chronic fractures some says that it's a sign of ischemic vertebral collapse. These are also common as refractures, especially after the compression fracture, osteoporotic fracture, it is healed, and a patient has a sudden jerk, and then they again come with the same problem, same pain. So that time we see these kind of clefts. Relaxed positions are also painful in this condition, unlike our osteoporotic compression fractures, where we have a absolutely pain-free when they are lying down or they are sitting idle. But in these patients, every movement is painful, even if they sit for some time with the relaxed position, that is also positive, painful. Bony edema is mostly absent in these cases of the cleft fracture. So this is how we can differentiate between the osteoporotic compression fractures and other fractures and between the cleft fractures. So what are these cleft fractures? These are the basically air-filled or the fluid-filled clefts. These are basically what happens is that over a period of time, these end plates just start necrosing, and then there's an accumulation of the gas inside the cleft. So it also depends on when the MRI is taken. So if the patient is lying supine, initially they are having air-filled. They are usually air-filled. But when they lie down for some time, the fluid starts getting accumulated over there. And when we take sections after 20 minutes or 30 minutes, you start seeing them as a fluid-filled clefts. So this is the difference between acute fractures and the chronic fractures. These are the various names which are given to the cleft fractures. You can call them anything, but these are mainly the vacuum phenomena. X-rays, you can find them on X-rays also. You can see the clear-cut cleft over here, and you can see there's a movement happening over here in the dynamic X-rays. So with the movement, with the breathing movement also, they moves at times. That we also see during the procedure also. When the patient is lying down, we take a fluoroscopic image, and when the patient is breathing, we can see that the fragments are moving with the breathing movements. So that is also called a dynamic X-ray. Avascular necrosis theory is the most commonly accepted theory for development of these cleft fracture, because of this area where these fractures are most commonly found. These are most commonly found in the anterior part of the vertebral body. So this is the area where we have these cleft fractures, and also towards the end plates. So these are the areas where we have these fractures which are commonly found. But in my clinical practice, I have seen cleft fractures everywhere, all over the vertebral bodies. Even in the posterior part also we have seen those. So this is a vicious cycle which happens over a period of time. What happens is the vascular insult is there, insufficient revascularization, leading to ischemia and leading to vertebral collapse. That will again lead to the vascular insult. So this becomes a vicious cycle, and that is why these patients, they do not heal on their own. There's a biomechanistic theory which clearly says that if it is BMD is less, then obviously the chances of cleft fractures are more. Other risk factors are degenerated disc. Whenever there's a degeneration of the disc, the end plates are sclerosed. So that basically also hampers the blood supply to the end plates, and that also leads to the avascular necrosis towards the end plates, and that leads to cleft fractures. Investigation, X-ray is definitely the first investigation which we order. We can see them, we can see the collapse of the vertebral body, but when we see these kind of gaps within the fractures, then we can consider as a cleft fractures. Dynamic X-ray, as I mentioned, if you take a dynamic flexion X-ray, you may see these kind of changes happening in the cleft fractures, which is not seen in the normal osteoporotic compression fractures, or even for that matter in orthopedic fractures. You may not be able to see these kind of dynamic movements happening, but this is commonly seen in the cleft fractures. So these are the two common patterns. One is a vertical pattern and one is a horizontal pattern. These are different patterns of cleft, but you may have combination of the vertical and the horizontal clefts. There is another name which is given called the vacuum phenomena. So vacuum phenomena is actually what happens. Initially, when we see the X-ray, we don't see the end plates, ends of these fractures. It looks like they are opposed to each other. But when we put our needle inside and when we remove the stellate, suddenly you will see that air sucks in and you can see the gap. So this is actually the air vacuum phenomena. Rest all are having either air filled or the fluid filled. But this is actually comes as a surprise, which is not evident during the X-ray or the MRI. But when you put our needle inside, when you remove the stellate, that time you start seeing these kind of clefts over there. CT scan, yes, definitely we can send the patient for the CT scan. Especially it is important when the patient is having a chronic fractures. In those cases, if the fracture ends are sclerosed, that we want to find out, because that basically leads to one of the reason of the failure of the cleft, filling cleft. This you can see here. This is a big cleft over here. These are big clefts over here on the CT scan, which you can see very clearly on the CT scan, which may not be able to see on the MRIs. MRIs is definitely an investigation of choice, where we can see on T1 and T2, we can see the hypointensity on the T1 and hyperintensity on the T2. That gives us an indication that it's an acute fracture or is it a chronic fracture. In chronic healed fractures with a cleft, you may have hypointensity in both T1 and T2. But the cleft will be having either dark, very dark, because of the air filled, or because of fluid. It is fluid, it will be very bright. So you may have both the patterns, either very bright like this because of fluid, or maybe it is totally dark because of the air. So you can see here, this is a dark over here, completely dark over here. On the CT scan, we can see this is an air filled sign. This is another you can see here. This is air filled, this is a fluid filled cleft. Now in this case, what is happening? There's a whiteness all over here. But this whiteness is in the T1 images, which is an indication of already healed fracture with the fatty infiltration. Whereas we have this cleft, which is complete cleft over there, which is either fluid filled or the air filled cleft. Coexisting air and fluid, that is possible because at times we have some compartments within the cleft. Some are filled with the gases, some are filled with the fluid. So that is also possible. So how do we manage these the clefts? For that we have this targeted cementoplasty. So that is very important to understand that here we don't want to fill the vertebral body. That is the most important thing we must understand. I'll show you why. So this is a usual technique what we use. Basically the conservative management definitely comes first. Even if you have a pressure with a chronic fracture or the refracture, patient comes with the acute onset of pain and we are suspecting a refracture, still we had to go for the conservative management first. Vertebroplasty versus kyphoplasty is still controversial, but let me tell you, whatever we have done so far, I had started doing vertebroplasties in 2008. It's been more than 15 years now. I've been only doing vertebroplasties. I've never done any kyphoplasty. And we have excellent results with the vertebroplasty with a uniparticular approach. So, especially for the cleft. Now, this is a warning sign for the cleft fracture. Because once there is a cleft, when you put a balloon inside, when you inflate a balloon inside, you are actually doing more harm than good. So better not to do for this cleft fractures and the comminuted fractures, where we have fragments of the bones. In those cases, it is better to avoid balloon kyphoplasty. The better is to go for the vertebroplasty. So this is, you can see here, what is the meaning of targeted cementoplasty? When we say targeted cementoplasty means we want to target only the cleft. Our target is not the vertebral body. Like in our compression fractures, osteoporotic fractures, we want to fill the entire vertebral body, that is our end point, right? But here we don't want to do that. We want to keep it only to the cleft. So you can see here, this is an MRI over here, and I can see the cleft is here. So what I'll do is I'll modify my technique. So you have to modify your technique as per the cleft. You cannot go by the traditional technique of supraappendicular line and outer quadrant. That we don't want to go for that. Here we have to go and target the cleft only. You can see here, this entire cleft here, and we have filled the cleft over here. See this. This is a coronal section. Coronal section is again very important. See this. This entire part is of cleft structure over here. And this is what we have filled. So this is what you want to fill. Right? Not the entire vertebral body. That is not our aim. If you try to fill the entire vertebral body, you are going to land up into complications, because when you start putting the cement, lot of cement, it may leak through this fragment, through the cleft. So that is why it is important to target a cleft and go with a very controlled fashion to fill the cleft. This is again very important. We try to maintain some lordosis over there. Normally in all the procedures we try to reduce the lordosis. Here we want to maintain the lordosis so that you have excessive pressure on the posterior cortex. So since you have excessive pressure, the cement will not leak posteriorly. It will tend to go more towards anteriorly. This is one important tool. We must use this. If you have not used this, start using this. This uses a very good controlled cement injection inside the cleft. So you can actually control it very well. You can see if you start seeing it flowing towards some other side, so you can stop it there also. Okay. So this is a very important tool. We must use this tool. This is called a gun system. See where is the fragment, where is the cleft, and accordingly we have to target our cementing. Frequent lateral and AP images, these are must for any cementoplasty, whether it is a balloon kyphoplasty or vertebroplasty. For that, AP and lateral images are must. Now you can see here, this is the anterior one, right? But when we see the the AP image, you may see an entire cleft over here. But this is not the entire cleft, not covering the entire body. It is only the anterior part of the vertebral body. So that is why it is important to so Dr. Shani is going to present that study. just 2-3 minutes, man. She'll cover the study, where we have followed up our patient for 6 months. We have collected data of 2 years, and we have followed up our patient only for the cleft fractures. So she is going to present that.
Hi, thank you so much, sir, for the wonderful presentation, and thank you for everyone to give me the opportunity to stand up in here and presenting my. Why you close it? That is duplication. So, thank you so much. Thank you, everyone. So, I'm here to present our paper. We already submitted this paper. It's a retrospective study of the consecutive patients who underwent bone cement implantation for cleft fracture of the thoracolumbar vertebrae at our IPSC hospital from January 2023 to December 2024. So our total number of patients are 35. Actually, we did 50 patients, but due to the lack of the follow-up for this rest of the patient, we are not including this in our data. So these are the some patient characteristics according to the age, gender, and the presenting complaint. The main presenting complaint is low back pain, and that is 73.3%, and the stiffness over back is just 8.5%. And the rest is the duration of the symptoms in the week. The average is 1.85 weeks. So preoperative pain scoring is NRPS and ODI, and let's go to this distribution. The age distribution in the bar distribution, that is a 88.69 were above 60 years of or older than this. That's why there's a right screwing on the distribution curve. And next, because the choice of like investigation of choice is MRI spine. So total 13 patients are presenting with the L1 fracture, and just D9 fracture is just we get in one patient, and we see the dual fracture, the two-level fracture observed in 7 patients out of 35 patients. So, and according to the for pain scoring, we coordinate, that is the ODI score dropped down significantly. At preoperative, it's 80, and on postoperative day 1, it's 20. So that's significant actually, and the P is less than 0.001 in ODI mainly. And that's a comparison between NRPS and ODI distribution between the lumbar and the dorsal vertebrae that shows the significant improvement in the NRPS score. And as a conclusion of our studies, the cleft vertebral fracture represent a distinct and challenging onset of OVCs. Chronic pain in these patients is often due to persistent vertebral instability caused by non-union or mobile cleft. MRI particularly contrast and hence sequences, and CT play a complementary role in diagnosing and planning. The complete and controlled filling of the cleft using cement delivery system under fluoroscopy is key to the successful outcome. So that's, I'm concluding my research in here. Thank you so much, everyone. Thank you, ma'am. Thank you in here.
I see saying that because Pankaj is the has a husband, so she won't say anything. So she's giving that privilege to me. So thank you, Pankaj, as usual, and this study is very good, very good. We should have these research things, because you people do so many things, but we don't have that research one will be projected by the pain physicians that they are doing this.
Well, that is true, madam. But now, since last 2-3 years, I am having my fellows, full-time fellows. She is one of the fellow. So these guys are doing a wonderful job now.
Very good.
Thank you. Thank you, sir.
Thank you.
Thank you, Dr. Pankaj Surange, sir, for that enlightening presentation. Now, let's welcome Dr. Rajkumar, sir, to discuss transcranial magnetic stimulation, a non-invasive and emerging modality in pain and neurorehabilitation. Welcome, sir.
Good evening, ladies and gentlemen. Congratulations, Dr. Sarange, for a wonderful work you're doing. So I'll be talking a little bit different topic. I'm not sure how many people are aware of it, this modality, how many of you are using it, because if we talk about the transcranial magnetic stimulation all along the pain pathway, this is the last part we are targeting. We start from the sensory, organs to spinal cord, because we know the sensitization can happen at all the steps. It can be peripheral, at the level of spinal cord, and even in the brain as well. So this transcranial magnetic stimulation is targeting, or we are using the targets in the brain, that to a motor cortex for the purpose of pain management. And it's basically a non-invasive neuromodulation technique in which a changing magnetic field is used to induce electric currents in the targeted brain neurons through a electromagnetic induction. And just to put the things in perspective, this is nothing new or a experimental thing. This has got a level 1 evidence for treatment of so many indications, but if I talk about the pain only, it is indicated for neuropathic pain as well as for widespread pain syndromes like fibromyalgia. And it is FDA approved for pain management since last 12 years in 2013. So this is not a experimental thing, it's well established role, and we should keep in mind. So it's there since 1985 and is being used for various neurological and psychiatric problems. So how it functions basically, we are passing a large amount of current to the tune of 500 to 4000 volt, but that for a fraction of a second, for around say 100 microseconds, through a wired coil which is placed over the region of the brain, or maybe a spinal cord, or wherever you want to use it. We are passing a large amount of current for a fraction of seconds, and this current will in turn produce the magnetic field, which is to the tune of 1.5 to 2 Tesla. It's quite a bit. And this current is passing almost perpendicular to the path of the current. If your current is passing horizontally, these magnetic waves will go at a perpendicular to the current. And this changing magnetic field passes unimpeded through your scalp, your skin, and it induces the electric current in the brain, and which flows opposite to the current which was flowing in the coil. So if the coil is going clockwise, it will go anti-clockwise, and the magnetic field will be perpendicular to it. And how effective this is going to be will depend how much magnetic intensity you are producing, what kind of coils you are using, and the orientation of the induced current. We have got circular coils, then we have figure of 8 coils. So most of for the purpose of pain management, we are using figure of 8 coil because it gives a more intense and focused current. If you use a circular one, the covered area is large, but it's not focused. For the purpose of pain management, we are using the figure of 8 coils. And TMS, it's classified high frequency or low frequency, depending if you are using more than 1 hertz or less than 1 hertz. Because both the frequency, they have got different indications. For the purpose of pain management, we are using the high frequency one. And how you are delivering this frequency, it can be a repetitive one. Repetitive means there is a fixed frequency at which is working. Then we have a deeper transcranial magnetic stimulation where we use a special H-shaped coil. It's not for the purpose of pain management, but it's used to target the deeper structures in the brain. Then we have a theta burst stimulation coils. So in the theta ones, we have a baseline current going on, and in between the baseline, there are high frequency currents going on at a fixed time. Say we are using a 10 hertz current. Then in the baseline of 10 hertz, it will deliver, say, current of at the frequency of 50 hertz. Like we have a burst stimulation in spinal cord stimulator. So there also we have a baseline of some hertz, and then it delivers in between the. So basically on the top of the baseline, it delivering the extra currents at a fixed intervals. So if you talk about the components are pretty simple. It's occupy half a room only. So we have a pulse generator over there. Then we have a coil, that's the figure of 8 coil you can see over there. And this coil is mounted on a stand. So once you have fixed the coil, you can just screw it and it will stay there. Then we have a special chair for the patients, so the patient can lie down relaxed. And then we have a navigation system. We do get TMS without the navigation system, but then you are struggling finding the hot spot every time, and it takes a lot of time. It's better to have the navigation system along with your TMS system, because that makes your life very comfortable, and finding the hot spot is very easy. So coming to the indications, its first indication, which was FDA approved in 2008, was for the treatment of major depressive disorders. And at the minute, most of the people, they know about the indication of TMS for the psychiatric problems. But for chronic pain, there are so many studies have been done, and it's approved by the FDA 2013. And it is said that we have to target the primary motor cortex. We call it M1. And that has to be the opposite to the site of the pain. So the M1 is the area of interest for us as a pain physicians for the purpose of pain management. The other indications are obsessive compulsive disorder, post-traumatic disorder, and the chronic pain syndrome, like patient with fibromyalgia, the bipolar. People are now using it for the quitting of the smoking, alcohol addictions, so many other indications. For the purpose of pain management, we have primarily 2 indications. And it has got a highest level of evidence, the level 1 for the neuropathic pain, where we are targeting the motor cortex. If we talk about the depression, they basically target the left-sided dorsolateral prefrontal cortex. So for whatever purpose you are using, you need to know your target area. So if you target the proper hot spot, only then you are going to get the results. If we talk about the other evidences, level 2 for the fibromyalgia, Parkinson, MS, post-traumatic stress disorder, stroke. And at our place, we are using very commonly for stroke patients. That too, say, once the patient is stabilized, whatever weakness the patient has, immediately post-stabilization, we start the stroke therapy. Every day we are giving. We have protocol, I'll discuss about that, for pain as well. So how do we prepare these patients? So we have 3 components: target determination, motor mapping of that target, and then they deliver the current. For the target determination, we do a registration. If any of you are doing neuroanesthesia, madam is doing, she knows how to do a navigation. Because nowadays, everything is targeted. If you have to remove a brain tumor, you do a navigation, you know how deep is the tumor, you have to remove whole of the tumor with the help of the navigation. Similarly, we do a navigation to find the hot spot, and after we know that probably this is the area, we correlate that hot spot doing the motor stimulation. We need to know a resting motor threshold, so that we know how much current we need to deliver for the pain management. And then we deliver the current. And on successive occasions, we have to do motor testing on every occasion. So because on successive sessions, the patient may have a different need for the current. So every time we have to do a motor stimulation. For the troubleshooting, we have to look after if the patient is feeling any discomfort. There can be a problem with heat coiling. So acquiring the MRI scan, although we straightway tell the MRI guys we need a MRI for purpose of navigation, they know how to do it. But the bottom line is, because we are doing the navigation, we need certain points in the MRI, the patient's ear, nasion, and tip of the nose. So everything should be clearly visible in the MRI so that we can do the navigation. So although we are given too much of information, we simply tell them that we need an MRI for this patient for the purpose of navigation. They know it. They already fed it into their computer, and they do it. Because for the purpose of navigation, you need to have a good quality MRI of the patient. And this is how we do a registration. We have markers. It can be a strip kind of thing. It can be a sticker. We stick it at one place. But what we have at my place is a kind of a band. We just paste it. There are 2 points where we register for the MRI. We feed the MRI in the navigation, and then we put that band where we have a marker. Those markers, they are attached to the camera, which is not too far. That camera has to be within 10 centimeters from your markers. I'm not sure you are getting me or not. And then the MRI of the patient is fed in the navigation system. You're putting the trackers on your head, and that trackers are read by the camera, and then we do a navigation. So this is how we do a navigation. We have a probe, we put it on the nose tip, then nasion, left and right ear. So whatever target you can choose the whatever target you want to use for the purpose of navigation, you can do that. So then you verify your targets, and then you get this kind of slice. So if we are talking about the only motor cortex, we get what we call a omega sign. You see that omega sign, the red line? The area just in front of the red line is the motor cortex, the posterior is the sensory. So wherever you get this omega line, we tell our MRI technician to just mark that area because we are not very familiar with the MRIs. So this omega area is the hand area. So you can get an idea about the other areas depending how the different organs are represented on the motor cortex. Hand area, because most common indications, whatever patient we are getting, mostly we get the upper limb pains. So this way, once you know this omega sign, you can go left and right, forward and backward, just to know your. But this is giving you a rough idea about your hotspot. For the holding the coils also, coil has to be always perpendicular to your. It has to be a tangential to the curve of the head, almost perpendicular to your target. And once you find your hotspot, you just clip it and you just fix it. You don't have to move. This is a small video you'll get. So we have found that the hotspot. Now you will see whenever you are bringing the coil near this that hotspot, you'll get that distance will keep on decreasing. And it will tell us how far we are from the hotspot. The coil is coming, this video is from the navigation system. It's telling you that distance is decreasing. Yes, at this distance, you just fix your coil. It means your coil is on the hotspot now. And you start your treatment. Other component, as I told you, is the motor doing the EMG. So EMG, we have 2 options. Either we take the coil on the motor cortex, on the hotspot, and we deliver the current and see for any kind of a muscle movement. Or if you want to do proper EMG, then we need to get a response of more than 50 microvolt. So doing EMG and knowing the number is quite difficult. So we go by the movement of your muscles. Treatment protocol wise, you have to choose the frequency, you have to choose the intensity, for how duration one session has to last, how many sessions you have to give. So everything you have to determine. But at our places, we do it on the motor cortex. We start with the 10 hertz, 2000 pulses in one session. But it's not a continuous pulse. You have to give 20 seconds, 10 seconds on, 20 seconds off. It takes a lot of time to complete your 2000 pulses. And on successive occasion, you might have to increase this frequency as well as the number of pulses you want to deliver. So for first 2 weeks, we give 5 sessions, and then on each occasion, you can increase the duration. Maybe you can do after 10 days, next after say 2 weeks, 3 weeks. It depends how much response your patient is getting. Because this effect of TMS works on the principle of plasticity. As we know that with each successive occasion, the duration of pain relief is increasing. So there's something is happening in the brain which is, is helping you to increase the duration of your sessions. So that's what we call a plasticity, because duration of pain relief is much more than your session, because every session is lasting for a more and more duration. So eventually you might need a session one in 2 months, 3 months. Side effects are very mild, short-lived, and they keep on decreasing on each occasion. Usually the patient says, I have some headache or some, some patients say, I'm feeling dizzy. Just make them comfortable for a while and they're fine. We do it on OPD basis. The last one, the seizure, as I told you, the resting motor potential, we don't have to cross 120% of the intensity of the motor evoked potential, resting motor potential. So at whatever intensity you are getting your muscle stimulation, just don't go beyond 120% of that. Thank you.
Thank you, Dr. Arora. We are now.
So Madam must be aware of this.
At TMS we are having. And now next week we are going to have neuromodulation.
I was also supposed to come, but I had some family problems.
They have a society, and they are coming to our institute.
I know.
Yeah. Are you coming?
I was supposed to come, but I had some family issues. So won't be
You can stay. It is only the 5th to 7th. So
I know Madam Preeti is calling me every other day.
But unfortunately, I will not be there because we are having this neurocritical care. So I will not be there. It is coinciding with that. So anyway, it's very good. We have this. We have this with us, and we just share the. It came to the psychiatry department for depression. Then we are also sharing that with neurologists.
But if you have a navigation one,
some
then
of the
it's very
patients.
easy. Anybody can do it.
Post-stroke patients and all, they are using it. Thank you very much. Thank you. Any more? One more.
Thank you, Dr. Rajkumar sir, for that excellent session. To conclude this session, we invite Dr. Sunita Lawange ma'am, who will speak on ultrasound-guided dry needling as an adjunct to solve muscle mysteries. Please welcome her.
Are you all awake? I think. So, I am going to speak about ultrasound guided dry needling. This is something which is not so difficult and easy. Each and everyone as a beginner can definitely practice it, especially in chronic pain patients in whom after doing the nerve interventions, your patient still comes and says, my pain has not gone, the stiffness is still out there. So what do I do? So if your patient keeps on coming repeatedly, you what are you going to do? You are going to advise medicines, all medications, and physiotherapy. But no, you have to treat that. Are you going to repeat the intervention again? No, because his SLR will be negative, everything is okay. That is not the neural component, it is the myopathic component. So basically, whenever there is chronic pain, it is not neuropathic, there is myoneuropathy. So take care of the muscles also, because they are the major brunt which are left behind, and we all are mainly focusing on the interventional, that is the neuropathic aspect. So we all know, I'll not go in detail about these trigger points, we all know what they are the nodules, each one of you must be aware of, and those who are practicing know what to do. So what we all do is, we'll advise physiotherapy or give trigger point injections, but how many times you are going to give? At how many spots you are going to give? So it is only the local, not steroid, and you should not give such injections again and again in the muscle, because it will cause fibrosis and dystrophy. So these trigger points, what do they do? They exhibit a local twitch reflex. Whenever a needle is inserted, there will be a twitch, which means that point is sensitive, hyper irritable. So because of that, what happens is, due to continuous firing at neuromuscular junctions, there is release of inflammatory mediators, neuropeptides, cytokines. So whenever you see these all, it means now the pain, chronic pain is going into a stage of peripheral and central sensitization, and then it becomes really difficult to reverse it. So always and always, muscles are basically the primary pain generators, which we often forget, and our focus is mainly on, as I said, the neuropathic element. Along with that, they are also expressors. So how they are going to express? Whenever there is any nerve lesion, what is going to happen? There will be increased firing at the neuromuscular junction. And because of this, the actin and myosin, what we have learned in physiology, they slide over each other. Out here, it's not going to be there. And because that's why the muscles get shortened, stiff, and hence there is a stage where what you call is stiff muscle with enthesiopathy. So along with that, there will be disability, because whenever there is stiffness, whenever there is spasm, the range of movement will be disturbed, and your muscle is not going to stay in a dormant phase. They are dynamic, they will keep on contracting and functioning again and again in spite of any injury or micro trauma. Hence, what will happen is the problem will increase. So these are all various causes due to muscle injury or any stress or overuse of muscles. There is ischemic hypoxia. Because of that, there is increased acetylcholine release along with the mediators, increase in intracellular calcium. More and more muscles will be contracting, which is not normal, and this will lead again to the ischemic hypoxia. So this cascade will go on. What are you going to do? As when a patient comes, it is the routine line of treatment with NSAIDs, analgesics, muscle relaxants, and other drugs, mainly tricyclic antidepressants play a very good role, and Botox injections, but not each and every patient can afford it. We all know it is very costly, and again after 3-4 months you have to repeat it. So then came this is not a new concept. It was practiced by Dr. Chan Gun, who was professor at University of Washington. I got a chance to meet him also. And then he introduced this as neuropathic pain in 1970. So what are we treating is the stiffness, the shortening, and also the disability, which is not taken care of. What we do is we tell them to go to physiotherapy, and they all keep on doing that without any good result many a times. So what are we using for dry needling is the solid acupuncture needles. So they are of 0.25 mm, and you can see the other thickness, which is much more. So these are 32 gauze monofilaments, solid one, they are not hollow, sterile, they come in a packet, and they range from 13 millimeter to 75 millimeter in length. What we used to practice before was dry needling, which was blind. So here it was only by feel we used to do, and hence it was very superficial. and that used to reduce only pain and stiffness. But now out here with ultrasound, what is happening is you can reach up to the depth because you can see where the muscle is ending. You can go up to the depth, and hence the disability also gets treated. So these myofascial trigger points, they are confirmed by a jump sign. Whenever you press them, patient is going to jump literally, saying that this is the point which is painful. But out here, it is the local twitch response. Whenever a needle goes inside, there is a twitch response, a reflex, and this is the pathogenicity of myofascial trigger points, and this can be seen with under ultrasound. There only 6 to 10 needles were used earlier because we were scared and we were very much superficial, and the sessions were also not more than 6 to 7. But now we are confident, so we can use more needles and also of more length because it is not done blindly. Up to 120 mm, depending upon the thickness of the muscle, one can use them. So in neuromyopathy, we have to take care of sensory as well as motor aspect. So ultrasound guided dry needling is a comprehensive and extensive version of dry needling. Here what you say is local twitch reflex, and what we feel that these are the 2 points, it's not like that. When you see a normal muscle and when you see the muscle which is not normal, there will be abundant myofascial trigger points in them, and this can be seen under ultrasound, and hence we can target those whole group of muscles. So ultrasound guided dry needling, it targets the structural impairment also along with taut bands which are there in the muscle. So this is your muscle, and out here you can see this is a normal muscle which you see, but out here when the muscle is short and stiff, what happens is there is hyper echogenic structure, mass of tissue, and then this makes us realize, so you should be able to see how a normal muscle looks, then only we can go for that. The techniques are direct and indirect, so it can be in plane, out of plane. Many a times we just see the depth and then remove the probe and then put the needles by our judgment because a group of muscles are to be targeted. Back muscles. Out here, we have to target quadratus lumboris, paraspinal muscles, and various group of muscles. So after doing the intervention, when a patient comes again for review and complaints, 3 to 4 sessions, weekly sessions, make a very good difference, and patients are really happy, and what they say is when you did this needle treatment, that is being more beneficial. So along with neuropathic, they are also worried and they are also not happy because the muscles are stiff and they are not allowing them to do their routine action. So this is the shortened muscle. You can see the normal muscle out here with the tendon, but when the muscle gets shortened, out here there are tender painful bands, trigger points, and here this is the tendon. So see the thickened tendon and how the muscle has become short. So definitely the range of motion will be disturbed in these patients. So this was, I'll show 2-3 cases. So this is a case of pediscapulitis having severe pain, 16-year-old boy, and out here we did his ultrasound guided dry needling. After 6 to 7 sessions, patient was very happy because he was studying, he was doing his some entrance exam, and it was not possible to give him much sedatives or painkillers. So these all sessions he attended and patient was really happy, he could do his normal activities. So you can see the needle, it's coming out here. And sudden there is a twitch response. This is a female who had, after giving her intercostal nerve blocks, patient still complained of pain. She was unable to do her, again same, she was restless, not sleeping properly. So after 48 hours of block, patient had the same complaints what were before. So in this patient, you can see the intercostal muscles out here, how they are. These are not normal ones, okay? So these are the tight bands with nodules which could be seen only under ultrasound. So you have to just reach till that end and do the desensitization of those areas. And after around 3 to 4 sessions, you can see how beautifully You can see all the tight bands have gone and the muscle is looking pretty normal. This is a patient of hemifacial spasm who was referred by a neurologist because he was giving him Botox and then he said, I cannot afford it again and again. So he had sent for some interventions, but I said, let me try first because the muscles are short, the spasm is there. After doing 3 sessions, the patient was smiling, there were no twitches, you can see, and talking properly without any twitches. Shoulder, routinely, one must go for that. This is a case of occipital neuralgia, where after giving occipital nerve block, dry needling was done. This is a case of post-total hip replacement, complaining of thigh pain. You can see the loss and the tight muscle bands out here. So he needed lot of sessions, and the one who came limping was able to come, climb stairs, and was very happy. Can you see the needle going inside and the dancing type of muscles? So this is the local twitch reflex. So what are the benefits of ultrasound guided dry needling? It improves range of motion. It is affordable basically. Patients can come weekly for sessions, and along with pain, the disability is also gone. It definitely has a greater benefit because take care of muscles also along with them. So to conclude, chronic pain, it is a critical health problem we all know, and 90 to 95% of patients with chronic pain have myofascial element also. So dry needling is a more effective intervention which can be used with other treatments as an adjuvant. They say that larger needles are more effective when compared to fine needles, but the acupuncture needles, which are of 32 gauge, they are sterile and they are of various lengths. So under ultrasound guidance, you can see the depth and definitely go till the end to give better results. Thank you so much.
Thank you, ma'am, for the wonderful presentation. And it is heartwarming to see the response of doing the dry needling. And I don't know how many people are doing. I've only heard you doing this.
I was doing this blindly also, and when I saw very good results, especially in neck pain and this, I continued. And it is really, I think so each and every pain physician should know, because when you feel ki now what is to be done, and if you know that this muscle is taut and this muscle is stiff, what is to be done? What are we going to do?
Yeah.
We'll give medications and send them to physiotherapists. But then, instead of that, why not, when we know this modality and we have ultrasound with us now? So this is really a boon, and your patients become very happy. I am practicing regularly in ONE also. So after giving regenerative, patient comes, she says the pain is not there, but stiffness is there. So that is going to be there always, because these are all chronic problems. So the muscles are going to trouble.
Every pain clinic should have this facility.
Yeah. I think so. This should be one modality which should be taught to beginners also, because when they come, instead of going for the advanced modalities, it is always better that these all basic things should be known, because each and every patient in India cannot afford Botox. So you go for PRF, you do everything, but then also your patient is coming and telling that I am having pain, then what are you going to do?
In our course also, we should have this.
Yes. Thank you.
Thank you.
TKR? Total? Knee, na? You go for your genicular nerve blocks if you feel that pain is there, and after that to treat, I'll not say that don't do interventions. Do the interventions. Okay? And then after that, when your patient is very happy coming, but again complaining of one thing only, that the stiffness is there, my ROM, range of motion, is not normal. So disability can be treated with this. So you are doing everything, just do this at least 2 or 3 sessions will suffice, weekly session. And it is not very costly.
Any more questions? Thank you, Dr. Sunita Lavange ma'am, for this insightful presentation. Now we are opening the floor for extended question answers. Okay. I invite all the speakers of this session to come on stage and the respected chairpersons for the group photograph.
All the speakers for their excellent talk and the interactions also we had. Pleasure to be here and you come. No speakers. No speaker is there.
Thank you. Thank you so much, ma'am, for chairing this session. Thank you so much, ma'am. I would like to announce that we are going to have a quiz and award ceremony. An exciting quiz is coming, so please stay for it. And I would like to call Dr. Mamta.
Good evening, everyone. Now we'll be having a quiz program, the Brain Pain Tournament. We'll be having a preliminary round and also a final round later. So now I call Dr. Gautam Das sir to give a small demo on how to join for the quiz.
I would also like to request Dr. Sunita Lavange ma'am to join us on stage for the moderation of the quiz.
The two events, two part in the ICRA pain are really very exciting, and every time we performed it, we did it, so people enjoyed it a lot. One of them is your quiz competition, and we have a special name for it, Pain Brain Tournament, and we also will be having today, and I'm sure all of you will be enjoying. And second part is the award ceremony, Pain Physician of the Year award ceremony. So we have different categories of the award there. Pain Ambassador Award, Best Researcher Award, Young Pain Physician of the Year Award by the name of the Susan Raj Pain Physician of the Year Award, and the most prestigious, the Prithviraj Pain Physician of the Year Award. So these awards and the quiz will be together. And with me, Dr. Sunita Lavange will be conducting the first part of the quiz today. So we'll be having the two part of the quiz. First part, anybody can join, and that part will be basically the elimination round. Preliminary elimination round where 15 questions will be there on Kahoot, and you will be participating. Out of them, anybody can participate. And top 10 will be taken here. And second part is very much fun-filled sessions. I'll be asking Dr. Labange to share a few of our, earlier memories. We started it from 2015, and she herself also conducted earlier. Several times she was the quiz master, and she will be sharing, how fun-filled was the pain brain tournament in the earlier ICA pain.
Sir is calling it pain brain, but I'll say Gautam Das sir's brain concept is there. So he used to think and so creative it was always, and with all pictorial things, various tests in pictorial form, and then we really had to scratch our head what is going to be there. And initially, slowly we evolved, and then when it was Kahoot, that time it was super fun, and we really enjoyed. So, sir.
But this time, it was not, first part I have prepared, but the second part, which is the fun-filled part, is not prepared by me. This time our fellows who will be sitting there, they themselves will be conducting the second part. I thought that, okay, because they have prepared it, we should be giving the credits to them and let them conduct the Kahoot. So the 3 persons who created it will be taking and conducting the final part of that. So me and Dr. Labange will be there in the preliminary part, and the final part will be there. We are waiting a little bit. I'll be telling you how to go ahead. I'll be playing. All of you can participate. This is, I should say, the test part. This is not the final elimination round. We'll be waiting for the other hall. Last meeting lecture is going on. By another 5 minutes, they'll be joining. But you, because you have entered earlier in the hall, you have the privilege to practice a little bit, because questions will be similar. So after they are joining, then we'll be starting the actual preliminary round.
So, questions?
So, many of you have earlier joined Kahoot, right? But still those who haven't, it's very simple. I'll be asking to give the connection to my laptop. Okay. So, let us, it's not the final round. So somebody who is scoring highest, don't claim that I am not there in the final round. So you have to again have the same test. So this was the quiz we performed in the WBSSP Con 2020, 24, 25. So the same Kahoot. So first part is there will be a game pin, but for that, you have to join by 3 different ways. One is, you open your mobile browser, that is the easiest one. You open the Google Chrome or any browser, and then type URL, the URL, no? The website's name, address, URL as www.kahoot.it. Second option is you can have the Kahoot app downloaded through the Google Play Store. And third option is again very simple, just scan the QR code and you will be getting it. So once you are getting, so you can put your nickname, but don't put your name like lion, tiger, not like that. Then we will not be able to understand who is lion, who is tiger. So, and if we are going to win the first prize, we will be going on, we may not believe whether who is the tiger, who is lion. So put your real name and then you join it. So this is again the test round before the other hall is joining.
It was really fun when the Kahoot app was there, and in hurry we know everything, and then you click a wrong button and then the mark is zero.
That is very important.
So take time.
Fastest finger fast.
Yeah,
means
fastest finger.
those who will be answering faster, they will be getting more marks. Means both have answered correct, but one will be getting more marks who have answered it faster.
Yeah.
So whenever you see the questions, immediately try to find the right answer. But if you make the mistake.
That time, I think so there were negative marks also.
No, this time there is no negative marking. No negative
so
marking.
that time, it was ekdam down. Some of us were minus also, and then it was very difficult for us to go and
yes, and
go to the
earlier
positive
the
side.
negative round sometimes
So that
final score was negative only.
Negative final score.
So be aware of that. But fortunately here there is no negative marking. Okay, so should we start the practice round? Should we?
Are you ready?
Okay. You read the question, huh? I will be putting it.
There is a bullet injury at abdomen. This is an example of A. Nociceptive pain, B. Neuropathic pain, C. Visceral pain, and D. Nocivisceral pain. Your time starts now.
No, the counter has already started. On the left hand side, the counter is there.
So this is how it will be. Wow.
7 people has answered nocivisceral pain.
7.
Can you explain what is nocivisceral pain? This actually created in my,
So out of 27, 7 nocivisceral. Mixed pain.
but there is no nomenclature as nocivisceral pain.
So this is to confuse you all. Huh? And 16 people, 16 amongst you have answered nociceptive pain.
And let us see the score.
Yes. Anjali, 937.
SL. I warned,
Who is SL?
in the final, don't make this kind of names.
Because
then we will not be giving you
I
awards.
write SL and I don't have mobile. So, SL is 932.
So you are sure that you are not playing?
Yeah, no, I'm not playing. My mobile is not with me. You can check. Amu 906, Charu 886, and K Priyanka is
You
877.
see, this difference in the score is because means Anjali has.
Matter of seconds.
Because all of you have given the right answers, but fraction of seconds
So Anjali
score has changed.
has scored and she is the winner of this round. First question 937. What is the below given picture? A. VAS, visual analog scale. B. NRS, numeric rating scale. C. VRS, verbal rating scale. And D. Likert scale. Time starts. Already started.
And answer is
also there. So 25 of you have answered right. That is NRS. And 4. Let us see. Yes, sir.
Let us see the result. Anjali is maintaining the top.
Anjali, who kaun hai Anjali? 1878. Second is Priyanka, and you can see. So like this, the scores will be there.
So score will be going on changing
every time.
with each question.
Yes. Pooh, who's Pooh? 1781.
Okay, next, third question. What is this dermatome?
Be ready.
There is an image.
L4, L5, S1, S2. Enough time is given, I think so.
Yes.
Yes.
So only 4 has given the right answer. So it was S2. You see, it was the back of the ankle, So S1, majority has given answer S1. S1 is the sole and the lateral aspect of the foot. This was the posterior aspect of the leg. So this was S2.
So in a hurry, we often do this. So that is why it takes some time.
And let us see the score.
Yes, sir. Is it
Oh,
Anjali again?
Anjali came down.
Oh, Anjali came down now. It is PRI. Pre. 2615. Wow. So, like this, your score will keep on changing.
And you are maintaining the skill.
SL, yeah, I am also maintaining whosoever is there. Thank you so much. 2574.
Playing on your behalf. Okay. Fourth question. Which is not a part of pain pathway?
Sir's favorite, pain pathway, so you all know, I think so. A, transduction, B, transmission, C, translation, and D, modulation. which is not a part of pain pathway? This everyone will answer.
Still there are 4 wrong answers.
So let us see the score.
Yes.
Where is Anjali now?
Anjali is catching up. Second.
Yeah.
Pri is maintaining the fast.
Pri is maintaining. Anjali has gone up. Yes.
Okay.
Hall B people have also come. She's supposed to be. This is the last trial now. Trial round. What is tactile hyperalgesia? Tactile hyperalgesia. Touch causes pain. Mild painful stimuli are causing severe pain. C. Touch reduces pain. D. Touch sensation is felt differently. Think and answer. You have time. Oh.
Okay.
13:30.
Okay, lot of wrong answers. This was tactile hyperalgesia. It's not the tactile allodynia. Okay, so tactile hyperalgesia, it means hyperalgesia, and allodynia is having the tactile allodynia, the pinprick allodynia. They are the different kinds of. So hyperalgesia means always the hyperalgesia, pinprick. Okay, so Hall B people has already joined.
Yes.
Okay.
All have come. Na? Yeah, how to join.
Okay, so I'll be just, so, okay, let me remove it. So those who have joined late from the Hall B, so it will be a Kahoot based quiz. So there are 2 rounds in the quiz competition. Everybody will be encouraging everybody to join. So first round is the elimination round. So it is based on the Kahoot, and then top 10 will be taken on the stage, who will be making 10 groups. Other rules they will be telling. So after the top 10s we are getting, so out of them 5 will be called, and they can choose their partner. Who will be his or her partner? So they two will be sitting together on a table, and that way there will be 5 groups. Each group has very peculiar name, not peculiar I should be say, funny name like amitriptyline, like baclofen, means drugs which are used in pain that will be used as a team name. So they can choose the team name as well because they have scored top. So, and then the 5 groups will be there. And this final round will be completely fun-filled round. But between the preliminary round and the final round, we are having the different awards. As I told you, that this is one of the very important signature event of ICRA, that is your Pain Physician of the Year award. So this year also we are having the different awards. So in between the preliminary award and the final round, where the scores will be calculated, by that time the awards will be given, and then finally the final round will be there. Okay, so yes.
We welcome you all for this most awaited event of ICRA Pain 2025, that
So
is
everybody
quiz.
can join except 3 of our fellows who prepared these questions, they cannot join. Apart from that, everybody can join. And not me and
Yeah,
Shrita.
I'm there, SL is there. We'll have to ask them to download.
Okay, everybody should be having the WhatsApp connection, means hotspots connection, is caps, Altair, ALTAIR. It's the username as well as the password of this. If you are having your mobile, the data, that's also fine, but you must be having an internet connection, otherwise you cannot play. Okay, again, I mentioned it earlier that everybody should be putting their real name. Otherwise, we don't know who is winner. So be attentive here, only 20 seconds for each question. So we told that there are 3 ways to join. Number 1 way is open your mobile browser and type this www.kahoot.it. Second option is download the Kahoot app from the Google Play Store. And third, the easiest option is just scan this QR code. And you will be into it. And put your real name.
What are putting?
GC.
GC.
US. So, we may deny your prizes if you are winner.
GC has to put his full name, please. US, who is United States? You also, sir said then you will be disqualified. So please put your real name. Zigu.
If you wish to
win,
yes, if you wish to just join as a fun, it's fine. But if you wish to ultimately come onto the stage for the final round, then we may not.
So it's like everybody can dance, so everybody can join. And it is real fun. So if you want to...
Somebody's put on high.
That is, they don't want. High, low, Ishwar, Nida, SS. If anyone is facing any problem, please tell us. And if
yes, when everybody will be telling that, okay, we are ready, we'll be starting. Otherwise, we are waiting.
Wow.
Ready? Should we start?
All ready?
If anybody is telling no, then we are waiting.
No? Raise your hands. How many? Are you ready?
No, I'm not ready.
Okay. So you must be SS or US.
Okay, organizers are also not going to get prizes.
Oh.
Because question might have leaked.
Yes, there are chances.
Should we start? Should we start?
Done?
Nobody is telling no. So let us start.
Yes, sir. So myself, Dr. Sunita Lawange and Dr. Gautam Das, we the quiz masters of first round, welcome you all for the first round. All the best.
Thank you, ma'am.
All the best. Let's start. Once I start, I cannot stop. But after each question, we will be updating the score. Okay? So top 10 will be called on the stage. Still people are joining with these names.
That is for fun, I think so, sir.
Okay.
They are not serious. We are starting. Please maintain silence.
Pain brain tournament. So first question. All are the red flags in back pain except
A. Unable to hold urine. B. Progressive sensory loss. C. Moderate motor loss. Severe pain not relieved by analgesia. Time is over. Let us see the score. No, not now. No?
okay, this was actually two answers was given, but actually the best answers will be getting the scores.
Second question. All are multidimensional pain scale except A. The McGill pain questionnaire. B. Brief pain inventory. C. PHQ-6 pain questionnaire. 3. West Haven Yale pain inventory.
So all are multimodal pain scale except which one? Let us see the score now. Pooja, Niveda, Say will be disqualified, isn't it? Oh, Sai.
Sai,
okay,
Sai,
then it's
no.
fine, then it's fine, then it's fine. Okay. Next question. McGill's pain questionnaire assesses all of the following aspects of the pain except sensory discriminative, neuropathic nociceptive, motivational, affective, cognitive, evaluative. Which is not assessed by the McGill's pain questionnaire? This is a little difficult question. So neuropathic part is not done by the McGill-Spain questionnaire, but all the other parts are taken care by the McGill-Spain questionnaire. Okay, let us see the score.
See how it
Bimles.
keeps on changing.
So it's changing.
Ah.
Priyanka is maintaining the second position.
Yes.
Next.
Yes, sir. All of the following tools help in diagnosing neuropathic pain except
Means neuropathic pain assessment tools.
Yes. Leads assessment of neuropathic symptom and signs LANS. Number 2, neuropathic pain questionnaire, NPQ. 3, pain detective tool.
And
3,
DN4.
DN4.
Majority answered right.
Yes.
But still few have how. Have you ever heard of pain detective tool? There is nothing called pain detective tool. Have you heard?
No, no, no.
Okay. Ravi. So it's a lot of changes. Next. What is the name of this clinical test? It's very easy.
Yes.
Everybody should answer fast.
Sacral thrust, distraction test, Patrick's test, McGallen's test. Here everyone is going to answer. I think so. It is over also. All are looking at the score.
Oh my God, Magellan's test.
9.
Again, this, no, 3 people have given the Magellan's.
Magellan. You
It
know.
was created in my brain only.
I know.
There is nothing called Magellan's test. I know. How many of you have heard?
वो ऐसा होता है ना तुक्का मार देते हो जाएगा सही Even I was thinking what is
I told her there will be lots of fun, you know. So Magellan's pain question was basically, name was invented by me.
Pooja, Niveda, come
Ravi,
on, buck up.
okay.
Ravi is on top. Chalo, do it.
Next.
We have 15 questions.
All of the followings are external rotators of the hip except
Piriformis, quadratus femoris, obturator internus, and pectineus. External rotator.
all are external rotator except one. Pectineus. Pectineus on the medial side, no? That is not an external rotator.
11. Chalo,
So
Niveda.
now Niveda is on the
Great,
top.
I am happy. No? You are supposed to participate?
No, they are not actually in the. So we intentionally kept them. Only 3 people who have prepared the question and myself. These 4 people know the questions. Okay, next.
Ravi, buck up.
Trendelenburg's test. Test the following muscle. Which muscle is tested?
Gluteus medius, adductor magnus, piriformis, and rectus femoris. This everyone will, it will be 100% right, I think so.
Let's see.
I feel, my gut feeling.
Majority answered right. Majority answered right. It's gluteus medius. Okay, let us see. So Niveda is maintaining the top position. And then Sai, Bimles, Samir, and Pooja. Let's go to the next question.
Yes.
The following are the causes of the lateral knee pain except
Iliotibial band syndrome, biceps femoris tendinosis, meniscal tear, pes enserine, bursitis.
So all can cause lateral
Except
knee pain
one.
except one. Still there are so many wrong answers. Pes enserine bursa is on the medial side. Okay, let's see the score now. But we understand sometimes in hurry,
Yeah.
you know, wrong answers are clipped. So Nivedha is still maintaining the top position, then Sai, then Bimles. Okay, next. Thassaly test is used to assess the injury of the following structure.
Number A, ACL injury, B, PCL injury, 3, meniscal injury, D, medial collateral ligament injury. It is used to assess the injury of following structure. Done?
Yes, majority answered right.
Yes.
So it's meniscal injury. That is one of the most, the specific test. Now Nivedha is in the second. Sai has gone up. Okay, 10th question.
Which dorsal compartment?
No, there are 6 dorsal compartments, no? So question mark is there. Which dorsal compartment is this? The question mark one.
First, second, third, fourth.
And you see how the whole probe is there. Okay, majority answered right.
Yes.
So it was the second compartment, just on the radial side of the listed tubercle.
People
Still,
could
yes. 8 plus 4,
8
12
plus 4,
people.
12 people could not. It was so easy.
Okay, let us see Nivedha again,
Yes.
gone top, Priyanka, Sai. Yes, you see, so much of changes with one question only. What is the mark structure?
A, deltoid, B, labrum, C, infraspinatus, D, shoulder joint capsule.
Look at the position of the probe
Question
also.
mark and probe. This is 100% right. Everyone will do it.
No, still wrong answers are there. So
Deltoid?
infraspinatus, it was very easy. It is on the posterior side. and-
Deltoid bola koi?
Okay. Nivedha is still maintaining the top.
Nivedha, Priyanka, Sai,
Bimles and Sunayana.
Sunayana.
Okay, next question. 12th question.
12th.
What is the mark structure?
Multifidus, longissimus, psoas, quadratus lumborum.
It's lower back.
This is very easy.
Okay,
Multifidus.
majority answered right. The probe was not exactly in the midline, little bit on the paramedian side. So, score is almost similar. Sunayana came on the top, third
Tough
position.
competition. Almost.
So,
So
13th question, 2 more
13th
questions are there after this. Name the procedure. What procedure is done? I am sure everybody will be answering
Lumbar
it right.
sympathetic block, interlaminar epidural, transforaminal epidural, erector spinae block. Hope so no one ticks
Answer the
on
right.
green
Yes.
one. Even if one is there, my God. Oh, really?
Okay.
This is purposefully done, I think so.
Let's see the score. Still Nivedha is maintained. Same
Same,
basically is maintained.
Shubhamay,
So
who
now
is
2
here
more.
side by side?
14th
Two
question.
questions. Come on. Sunayana?
Still you have the chance.
Yes.
What is this?
What is this?
I'm sure this also will be answered by
Yes,
all.
normal dye spread in caudal epidural, SI joint block, vascular spread of dye, selective S1 nerve root block. There are 2.
Still so many wrong answers? Okay, so this was the very typical dye spread in the caudal epidural.
8 people answered vascular spread of dye. Okay.
Okay, so last question.
Last question.
And before that, let us see the score. Nivedha is still maintaining top. Priyanka, Sunayana, same. Sai came up. And then Subhamaya. Subhamaya actually emerged suddenly from, on the 5th position. Okay, good.
Last question.
And last question. So, here is your last question. What is the procedure? Look at the image.
Piriformis injection, S1 root block, hip joint injection for femoral nerve block.
So what is this procedure? You can see the dye. So lots of wrong answers. I know nowadays piriformis is not done, so I will not blame, because nowadays piriformis is done on the ultrasound only. So many don't have the idea about how the piriformis dye spread looks. But this is the way how the piriformis dye spread look. So right answer is piriformis. And let us
see the,
the score.
Come on now. Let us see who are the top 10 winners.
So, third is Shubhamoy.
Shubhamoy.
Okay. Second is Sunaina. Okay.
Sunaina. And first, Priyanka.
Priyanka. Oh, where is Niveda? Niveda.
Last question made a difference. Wow.
Okay, fourth is Sai and fifth is... So these top 5 will be having the chance to select their partner next 5, and also they will be getting chance to choose the group name. Group name are like different drug name is the group name. So, but that will be the second part. But in between, we'll be having the award ceremony, and I'll be asking Susan and Niveda to start the award ceremony. List I'll be giving.
Okay, sir.
List I'm just looking at that because I have to go to the back end to see the list. Okay?
Thank
Shall I
you
show
so
the list
much.
right now?
Yes, yes.
Yes, sir. We can
Okay, they are asking that, okay, please display the...
Congratulations to the winners, and the next round will be there. So a big round of applause. So be prepared for the name as well as for your partner who will bring laurels to you also. Okay?
Just a minute, I'll be displaying the score. It's very transparent.
Yeah.
No manipulation
It's not
under the table. So I'll be showing you who is... Let me first open it.
I hope you all enjoyed. Huh? It was nice. See, everything was so simple, but then also in a hurry, usually this happens. We all know the answers, but the time period is less.
Okay, so Priyanka, second is Sunayana, then Shubhamoy, then Sai, Niveda, and then next 5 is Srilekha, Guru, Somir, Dipanka, and Susan. So they are the next. So first 5 will be choosing their partner from the next 5, and also will be having the opportunity to choose their team name. Yes, yes. So everything is basically because of the time. That was what is.
Seconds. In 1 second,
Right.
Yeah, one question.
Okay, so we hope you have enjoyed, but the final round is much more fun-filled round. We are sure that you'll be enjoying it more. And big claps for the winners. And now over to Susan and Niveda.
Thank you, sir, and Sunita, ma'am. Oh, that was an electrifying session. Our neurons are still buzzing. Now we arrive at the most awaited event of the evening, the Pain Awards. This honor is a tribute to excellence, innovation, and dedication in the field of pain medicine. For presenting these prestigious awards, I would like to call upon stage Dr. Lohit Rahori, sir. Sir, please join us on stage. Dr. Swati Bhatt, ma'am. Dr. Hashisa Surange, ma'am. Dr. Shushpa Das. Dr. Smruti Hota, ma'am. And Dr. Gautam Das, sir.
Please join us on stage. Award ceremony. Yes, ma'am.
Dr. Rohit Rahuri, sir, please join us on stage. Dr. Krishna Podar, ma'am, please join us stage to distribute the awards. Some awards celebrate achievement, but our first award of the evening celebrates inspiration. Here is an honor for those who don't just practice pain medicine, they represent it with pride.
We are honored to present 3 awards in this category. The first award goes to Dr. Basabjeet Das, sir. Sir, please come up on stage and receive your awards. Next we have in this category Dr. Gopinathan Raju, sir. Sir, please come on stage. Congratulations, sir. The third person getting the award in this category is Dr. CJ To, sir, for the Pain Ambassador of the Year. Please come up on stage, sir. Congratulations, sir.
So we have had the awards for the Pain Ambassadors of the Year. But what about the people who are excited with articles, PubMed and p-values?
Oh, you mean the Best Researcher of the Year award?
Absolutely. The award for the Best Researcher of the Year 2025 goes to Dr. Gaurav Sharma, sir.
We have a short video clip of Dr. Gaurav Sharma sir's journey of his pain medicine.
ये तपस है तपस दरादिया का पुराना ये देखो कार्तिक की फोटो है
Amazing, sir. Congratulations, sir. Now we move on to a special category of awards, the Pain Physician of the Year Awards. Our next recognition is dedicated to the future of pain medicine. It honors a young pain physician who has shown exceptional talent, dedication, and promise in advancing our society. With passion, hard work, and vision, this individual truly represents the bright future of our field. Ladies and gentlemen, we present the Susan Raj Young Pain Physician of the Year 2025, and the award goes to...
Any guesses? Great guess.
Dr. Ravi Shankar Sharma, sir. That was nostalgic. Many congratulations, sir.
Our next recognition is the most distinguished of all, an award that honors excellence, leadership, and impact. This is for a physician who has set the gold standard in our field, the Prithviraj Pain Physician of the Year Award. And this award goes to Dr. Gurumurthy, sir. I request Swati Bhatt ma'am, who was the pain physician of the year last year, to hand over this award. Yes. Congratulations, sir.
So before I start, I like to thank my family. Maybe I will be forgetting at the end. At least I will make keynote that I had informed that I talked about something about my family. It's not for joke, but see, I think I should thank my wife, Dr. N. Vanathi, who is a gynecologist, who had helped me while I am transiting from anesthesiology to pain medicine. Yes. So maybe Supra ma'am will be knowing. So we have been here for madam, maybe the another person to be an example for my wife. So it was not an easy job to become a pain physician. Yes, it took financial constraints, totally a new field. So we don't know anything more on MSK. Yes, I learned. That's because of one person, Dr. Gautam Das sir, right? Even I don't know that I am a good academician. He only told that you are a good teacher, you are a good teacher. Every time whenever he says, I will head your doubt, is it the way sir promotes us, or it is a way actually he is telling the right thing? Yes, he has given me the chances like anything, I think, right? So the first book, as I told that, how to start and run a pain clinic, I came as one of the pain fellow who was, for that month we had got 4 fellows. Usually sir don't take 3 months fellows, only 1 month, 1 candidate. That time we had 3 candidates. So I had completed in 2011. So then I came back to learn. 2013 I was there. Sir gave me a small chapter, especially on, I think it is radio frequency generator. So it is a 5th chapter. So sir called me inside and told, okay, why can't you write chapter number 1? I thought, okay, it's his introduction. He told, write about evolution of pain clinic. So it's very difficult to Google it also. Right? So if it is written evolution of pain management, yes, lot of textbooks will have the words, but I really struggled. So I got it. Then sir called me on one day that, okay, we will do one animation video for procedures. So that time sir was telling, okay, you just make 1 minute animation so that we will give it to the delegates, whoever wants to learn. Sir, I told, why can't we write a whole book? He told, how can you write it? It will take a lot of efforts. I told you, sir, I will come with a small single chapter. So when I was sitting in the Chennai airport, I was formatting that format and wrote it. That is the common pain management procedure, volume number 1 and 2. If sir remembers, so even I was leaving my few Diwalis. It was a Diwali day, I was sitting with the editor. So my family was there in Tamil Nadu, I was sitting here because that book has to come immediately. Because that we have a conference on the next month. So we did it, then he believed me, he has given almost 5 books, I was there with sir. So he was there with, everywhere he supported me. And I just want to add Supra ma'am. So I think she considered me as her son or brother. Because I will consider as son, because I can reduce my age. Okay, so whenever I come to Kolkata, she makes sure, so because I was coming every month. So for 5 days I used to come. Ma'am, make sure I have everything there. So I will have food, I will have everything in bed, everything ready. Thank you, ma'am. So it's a great privilege. So I was the first young pain physician on 2013 when Susan Raj and Prithvi Raj sir was there. So even one day I remembered I am doing FIPP, Susan ma'am told me that Susan Raj name is not there. So in between it was not there. So I am happy, sir. Now we had added the name back as Susan Raj Young Pain Physician Award. I thank you, all my seniors. Yes, we have quite good number of seniors and all my juniors who still teaching me the art of pain medicine. Thank you.
I want to call upon Dr. Ravi Shankar Sharma sir also to share a few words.
So I don't know what to say, but first of all, I would like to say that my journey started in almost 2016 in the month of September, and I think this ISSP decided to have this IAPM exam. You are well aware of it, ma'am. So I first visited Hyderabad, Rinchi Hospital, and at that moment I wasn't aware of any institution in India who is teaching pain medicine across. But Muralidhar Joshi sir was sitting and Vijayanand sir was sitting next to me. And they told me, I was the rank 2 over there, and they told me rank 1 got Vinci Hospital. And I asked them, which one is the best institute in India? So, you know the answer. Yeah. So, it was sad. I directly came from Hyderabad to Kolkata, and I was with my wife, and we had a meeting. And what sir told, ma'am, everything about you, you know? Every struggle which he faced, he told everything about you. कि initially days में कुछ भी 1-2 patient आते थे, कुछ भी monthly income was almost nil. Sir told me, and he was telling it to my wife, and I was shocked. कि यार उधर 50,000 मिलता था, इधर तो and prior to getting admitted to this Daradia, I was driving a car. And some of my colleagues in the morning, they were telling me, that in Kolkata you were driving a bike. Yeah, that's a demotion. No, it was a promotion for me. I learned quite a lot because of the sir and the Daradia institution. And every senior present in this hall. Someone was, every, I cannot name anyone. From everyone I have learned something, okay? And that's why I'm here. And presently, I'm trying to improve this branch of medicine because of the blessing of the sir. Thank you. Thank you, Daradia.
Now we request Dr. Gaurav Sharma sir to share a few words with us.
Thank you. बहुत बहुत धन्यवाद. मन की बात मन से, दिल वालों से. कलकत्ता मतलब मैं फर्स्ट 2008 में आया था, बिकॉज उससे पहले मैं डॉक्टर दुरेजा के पास गया था 2008 में. तब हमें 2008 में फर्स्ट टाइम मैं गया, तब 2 साल की वेटिंग थी. आज सुबह कोई बदला 6 महीने की वेटिंग बोले थे. आई वेटेड फॉर 2 years, 2006 to 2008. एंड जब वहाँ पे मैं गया तो वहाँ पर सुना कि यार एक गौतम दास नाम का आदमी है. आई वॉज विद दैट Tripathi neurologist. He has passed his DM neurology. So we were 3 people at that time. So Dr. Santosh Tripathi. So me and Santosh Tripathi was in the same batch. We were 3 people over there. तो उस टाइम जस्ट ओके यार देख, इंडिया में तो 2 ही जने काम कर रहे हैं, एक गौतम दास हैं और हाँ आईडेट उस टाइम आया था. आईडेट तो यार आईडेट तो यार एक दास सर है कोई कलकत्ता में, और उन्होंने किया है. और बाकी तो मैं वो बोला कि ही वॉज फ्रॉम एम्स दिल्ली एंड ही वॉज न्यूरोलॉजिस्ट. ही वॉज वेल कनेक्टेड ऑल ओवर. और मेरे लिए तो ये सारा ऊपर से ज़्यादा बाउंस कि यार हो क्या रहा है, ये चीज़ें कौन कौन सी ये ब्लॉग दिखा रहे हैं, क्या कर रहे हैं. आई वॉज जस्ट लाइक अ बिल्कुल अनपढ़ आदमी होता है ना, जैसे कि यार उसको एकदम से किताबें दिखा दो तो क्या होता. तो संतोष त्रिपाठी वॉज फर्स्ट पर्सन जिसने कि मेरे को नाम बताया कि यार एक डॉक्टर गौतम दास करके कोई कलकत्ता में है. इस वर्ष 2006 और 6 to 8. तो फिर संतोष त्रिपाठी वेंट टू आउट ऑफ इंडिया फॉर फर्दर ट्रेनिंग. तो फिर मैंने पता किया तब जाके एक हाँ डॉक्टर मुरलीधर जोशी एंड डॉक्टर दास. ये तो आई अप्लाइड एट दैट टाइम. डॉक्टर मुरलीधर जोशी का भी एक 1 year का कोर्स था, बट जैसे ही मैंने अप्लाइड किया वहाँ पर वो कोर्स बंद हो गया. कि वो बोले यार अब मैं पैसे नहीं दे सकता. उनका एक वो कार्ड करके हॉस्पिटल होता था, बोला हमारा हॉस्पिटल ही बिक गया है ना, दैट चेन हैज़ बीन क्लोज्ड. तो मैंने कहा चलो सर ठीक है. बोला बिना पैसे के तो तू भी क्या आएगा यहाँ पे. तो मैंने कहा ठीक है. तो फिर मैं डॉक्टर दुरेजा का कोर्स 15 days ऑस्कोलैप अकेडमी वाला जो कोर्स होता है, देन आई केम टू सर. तो फर्स्ट टाइम देखा कि यार नहीं यार चीज़ें इतनी दूर से नहीं, क्योंकि वहाँ पर मैं ज़्यादा उसमें डिटेल में नहीं जाऊँगा. तो एक्चुअल टीचिंग, व्हाट वाज द एक्चुअल टीचिंग एंड व्हाट वाज द एक्चुअल लर्निंग इज दैट, तो वो यहाँ पर आके पता चली. 5 days एक एडवांस कोर्स 5 days का होता था उस टाइम पे, और एक होता था बेसिक. जो एक मैंने 2009 की फ़ोटो डाली है. फिर उसके बाद मैं वापस गया. अपन ने ओपीडी तो 2008 से करना चालू कर दिया था, बट जैसे ही वहाँ पर गए थे यार सियाम घुमाते कैसे हैं. एट दैट टाइम इट वॉज वेरी डिफिकल्ट. यू नोबडी इज देयर टू whom you can talk, how to do it. There is very limited book. We don't know what are the books available. एक फोटोकॉपी, जैसे मैडम सुबह बोली थी कि एक फोटोकॉपी उसकी थी, हमने एक फोटोकॉपी एक एटलस, उसका एटलस आता था, उसकी फोटोकॉपी करके देखा. उसमें स्टेप 1 स्टेप 2 फिर वो आप लगा रहे हो. तो एक ट्रांसफोरामिनल सीखने में आई टुक 2 years. 2 years आई टुक 2 years टू लर्न ट्रांसफोरामिनल. और जब मैं यहाँ आया तो वो 15 मिनट में सारे जो मैं 2 साल से स्ट्रगल कर रहा था, और वो 15 मिनट में बाकी सब भी सीख रहे थे. एंड द बुक्स एंड ऑल द लर्निंग मटेरियल्स आर ओपन टू ऑल. ये चीज़ बाकी कहीं भी इंडिया में नहीं थी. जो भी उस टाइम पे हुज जो भी बड़े से बड़े नाम थे, नोबडी वाज वेरी फ्री टू टीच. तो ये एक सबसे बड़ा डिफरेंस था. तो एक कल्चरली एक बिल्कुल ही एक अलग एनवायरनमेंट आपको मिलता जहाँ पे यहाँ पे आए. तो उसके बाद तो फिर मैं 15 दिन के मैं वापस आया. फिर मैं 3 महीने के लिए वापस आया साल भर में, और फिर उसके अगले साल 3 महीने में आया. तो मैं जहाँ पर मेरे हॉस्पिटल में वहाँ पे बोले तो इसका कोई ना कोई चक्कर चल रहा है कलकत्ता में. मेरे सारे जितने भी फ्रेंड्स थे वो बोले नहीं ऐसा हो नहीं सकता, अपना चलता काम छोड़ के हर साल ये भाग जाता है. एक मैंने और मतलब मेरी वाइफ को मेरे 3-4 सर्जन फ्रेंड्स वो मिलना है, नहीं आप सोचो कुछ समझो कुछ देखो कुछ करो. उन्होंने इतना भड़काया. बट कुडोस टू माई वाइफ. उसने बोला यार इसमें दम नहीं है कुछ करने का. बोला कि वो एक शेर है कि ना तीर उठेगा ना तलवार इनसे, ये बाजू हमारे आजमाए हुए हैं. बोले कुछ नहीं कर सकता. बोला कि हमें पता है इसमें कितनी टाप है. तो इसलिए उनका छोड़ो, रहने दो, कुछ नहीं, बोले जाने दो, इसको जान जा रहा है। तो एंड आई वांट टू से थैंक्स टू माय वाइफ आल्सो, क्योंकि उस टाइम बच्चे भी छोटे होते हैं एट दैट टाइम, बड़ा डिफिकल्ट टाइम। और जब आप एक चलती प्रैक्टिस में, भाई एनेस्थीसिया तो सेटल होता ही है, एनेस्थीसिया में तो जितना जवान आदमी होता है उतना ज़्यादा दौड़ता है, ज़्यादा पैसे कमाता है। तो सब बोले यार इसका दिमाग खराब है, क्योंकि हमारे यहाँ पे राजस्थान में कोई भी प्रैक्टिस करने वाला नहीं था। आई वॉज द फर्स्ट पर्सन हु स्टार्टेड। तो इट वॉज द ब्लेसिंग्स कि हमारे को एक ऐसा ग्रुप मिला, ऐसा गुरु मिला, ऐसा एनवायरनमेंट मिला। तो इट्स अ फ्री टू लर्न एंड फ्री टू टीच ऑल्सो। भाई यहाँ पर क्या है, जब 3 महीने यहाँ पर रहते हैं तो आपको सिखाने का बहुत मौका मिलता है। देयर आर मल्टीपल ग्रुप्स दो आर कमिंग टू लर्न, शॉर्ट कोर्स, लॉन्ग कोर्स। उस टाइम लॉन्गेस्ट कोर्स वॉज 3 months एट दैट टाइम। तो उसमें इतने सारे लोगों से तो आपको इंटरेक्शन होता है, आपका कॉन्फिडेंस आता है कि कोई इंडिया के बाहर से आ रहा है, कोई इंडोनेशिया से आ रहा है, कोई इजिप्ट से आ रहा है, कोई इराक से आ रहा है। देयर आर मैनी फ्रेंड्स, मतलब इतने सारे लोगों से आपको इंटरेक्ट करने का मौका मिलता है, आपको अलग अलग कल्चरल देखने को मिलता है, चीज़ें सीखने को मिलती है। एज अ पर्सनल लेवल, एज अ पर्सन you grow, not only academically, as a person you also interact with the different kind of people and different kind of thought process कि how you are dealing with that। तो एक तरीके से आपको मैच्योर होने में, बड़ा सीखने में, it was a, that's why it's called a institute। Daradia is an institute not only for teaching academically but all the other things are also। इसीलिए हर साल हम यहाँ आते हैं कि एक भले कुछ बात नहीं हो तो भी देख के ही खुश हो जाते हैं। आज हमने देखा है वो स्ट्रगल, उस टाइम पे हम गाड़ी में बैठ के सर के साथ जाते थे चारनौक हॉस्पिटल। हाँ, चारनौक में ही वॉज डूइंग द प्रैक्टिस। ये जमीन लिया तब ही वॉज इन वेरी वेरी क्रंच ऑफ मनी। वी हैव सीन दोज फेजेस ऑल्सो एंड वी फील। तो आज जब ये चीज़ दिखती है कि यार एक ऐसी जगह पे जहाँ पर कि आप विश्व बंगला पास में, इतने बड़े बड़े 20-20 माले के बिल्डिंग यहाँ पर पास में ऐसा लगता है यार हमारी भी बिल्डिंग है। वी ऑल्सो थिंक यार इस बिल्डिंग में हमारा भी पार्ट है, भले ठीक है हम आए नहीं आए, लेकिन वी ओव दैट। So thank you, sir. Thanks a lot.
I want to add one thing because it was a very big contribution by him when he was at Daradia for 3 months. So you have seen the mannequins, no? So mannequins made up of original bone, and the first one was he was the instrumental. So that time when I started my practice, that time there was no mannequin. So what I used to do, I पूरा एक skeleton मैंने सीएम के नीचे बैठा के एक I was covering it with a bed sheet so that it is not seen, and I was practicing. That is how I learned myself. And he actually was sitting together with one of the carpenter was there. So most difficult part was without any wires or any radio opaque the things, we have to articulate the spine, the ribs, all the structures. And he was whole night the awake of articulating all the bones together, giving the perfect anatomical shape. The first one, many of you are practice on the violet colored mannequin recently, that was made by him. That was the oldest one. And then we had more mannequins, but that was really still there. We repaired it 2-3 times because the gums are, because of the repeated use, it was disarticulating. So again we made, but that was still there. So, but it's a big hand to him. He was the first,
So thanks to madam. And thanks to, I put a photo of Tapas also, and that Sharmila ji and all those staff are very kind. And that was a team actually. So I have the photographs. Aaj, Oshima ji. So it was a good. Thank you. Thank you very much.
Wonderfully said, sir.
We now move on to a very special moment of recognition. In the journey of pain medicine, there are milestones that represent not just personal achievement, but also international standards of excellence.
Clearing FIPP and CIPS is no easy task. It takes years of dedication, skill, and perseverance. We take pride in recognizing those who have successfully achieved this milestone this year.
Dr. Ashwini GS, sir, has cleared the CIPS this year. Ma'am, I'm really sorry. Ma'am is not there. Okay. We'll move on to the next award.
Dr. Akansha Bansal ma'am, who has cleared the prestigious FIPP. I think she's not joining us now.
Okay, sir.
Dr. Sirish and Dr. Anamul H. Milton, sir, who have both cleared both FIPP and CIPS. Please join me in giving them a round of applause.
Next, we move on to a very special award. This award is not just a token of recognition, but a heartfelt acknowledgement of the administrative work, creativity, and behind-the-scene efforts that make our program shine. I would like to call upon stage for receiving this award, Mr. Soham Datta.
Thank you, sir. Every successful journey has a guiding force behind. Someone who may not always be in the spotlight, but has been the backbone, guiding with her quiet strength, gracious smile, and unwavering support. I request Dr. Shubhra Das Mistry to please join us on stage.
Sir, please.
No, what Gaurav was telling, Robi was also telling that the earlier days when the struggle was there, I used to tell that as an incubation period of leaving the anesthesia practice and coming to the pain practice means where you can sustain. For me, the time was 5 years. Means when I was doing the anesthesia practice, I was amongst one of the topmost anesthesia practice in Kolkata. And I left it, and when I started pain practice, my practice was almost nil. And that was the time when everybody was laughing, that, okay, what are you doing? You are so much of successful pain anesthesia practice, and you are running behind something which is not established. You don't know what will happen. And why are you leaving this? You might be doing both the things. A lot of people are doing like that only. I told, okay, what I feel is that the pain is such a big topic. I cannot do the justice to this specialty if I am practicing both. I need to read more. I have to, means that time when there was no patient, I always thanked God that, okay, He is giving me the lot of time to read. And when some of the junior also tells me, sir, I am not getting any patients, so what to do? I tell exactly the same words, that, okay, just thank God that you are getting a lot of time to read. And definitely, that is, easy to say, but difficult to practice just because you also have to run the family. And that was the time when, she was always behind me. She believed in me. Many people didn't. My surgical colleagues didn't believe. They always, used to laugh behind in the other room also. I used to, listen that other people, oh, what is pain? Mein? Kya kar raha hai log? So this kind of, the comments also I heard from the other room on the OT. I was working in the one OT, and beside me, some other orthopedic surgeons, some other surgeons are talking like that. So those are the days when, many people didn't believe that the pain specialty will be coming at this level someday. But yes, this is the day we are very, proud to see that these days, particularly we always talk about the DM. That is one of the very important recognition. And, we always will be talking about the Ravi because he was the fast DM. So those days, she was the earning member. And I used to tell that many times what happened, that I am sitting in the home. That time our Suspa was very small that time. And I was reading at night, I was reading in the day, and Suspa was with me, and she is in her duties. People used to tell, okay, ये बेकार आदमी क्या कर रहा है घर में बैठ के बच्चा पाल रहा है. This was the kind of comment so they used to make. But I always thanked God that, okay, this is the time which I am getting to read a lot. In fact, I always tell these things. When I appeared for the FIPP exam, I read almost all the textbook. Means Bonika's book, Prithviraj's book, Waldman's book, even Meljak and Wall's, that is a big book. That is one of the book most of the clinicians hates a lot. So that's open up and, they go away from that book because lots of theory backgrounds was there. But I am fortunate if in these days, if somebody is asking to read those details, I really don't have much time to read those things. So less practice, don't get frustrated. Less practice means you are having the more time to read. So those days, those difficult days, unless he was there and supporting the families, earning the bread for us, these days was not possible. This is easy to say, but if ultimately you have to run the family, many bright, the fellows I have seen, they have returned back to the anesthesia practice because they had to run the family. So again, as fortunate, and I tell these words exactly to Ravi, because Ravi's wife was earning. I told, okay, you will be getting these hard days when your income will be nil, and if you are having a supportive wife, then you can sustain. Otherwise, sustaining, leaving the anesthesia practice is really difficult. So thank you very much, and thank you very much for believing in me.
Congratulations to all the achievers. I request all the award winners to join us on the stage for a quick photo session.
Give them a huge round of applause, everyone. Thank you all. It is now time for a special moment. Books are the silent mentors that guide us, shape us, and continue to inspire generations of pain physicians. And today we have the privilege of unveiling not one, but two landmark editions in the field of pain medicine.
The first is the fourth edition of Basics of Pain Management, a book that has become a trusted resource worldwide since its first publication in 2015. In just 10 years, it has reached its fourth edition, an achievement that reflects its global acceptance. It continues to guide pain physicians across continents. And now I call upon the editors of this book, Dr. Gautam Das sir, Dr. Shushpa Das ma'am, Dr. Samarjit De sir, to join us on stage. Along with them, I would like to invite our distinguished dignitaries to join us on stage, Dr. Pankaj Surange sir, Dr. Karthik Nadarajan sir, Dr. Bibu Kalyani Das ma'am. Please join us on stage, ma'am.
And Dr. Harshita Surange ma'am. Please do the unveiling, ma'am, sir. And the second book being unveiled is Multiple Choice Questions in Pain Management. The editors of the book are Dr. Gautam Das sir, Dr. Shirish P. Amitya sir, Dr. Smriti Rekha Hota ma'am, Dr. A.H. Milton sir, Dr. Shushpa Das ma'am. Please come on stage, ma'am. I would also like to call upon stage Dr. Priyanka D., Dr. Yashasa Podal, and Dr. Niveda P. Swami, who contributed for these books. Congratulations to the authors and editors for this remarkable contribution. Thank you, dignitaries. May I request you to take seats in the audience now.
Now let's get back to the final round of our brain tournament and test our knowledge. I would now request the quiz team to take over the stage for the final round.
दूर है आपका वायर. टेस्ट कैसे होगा?
कुछ सॉन्ग वगैरह
वो नहीं अभी बता सकते. वो नहीं बता सकते.
हाँ कुछ भी
नहीं है मेरे पास.
कुछ भी नहीं.
के लिए वही है.
अच्छा कुछ डिस्प्ले में नहीं चाहिए. इसको नेक्स्ट करने से आवाज़ आएगा.
नेक्स्ट करने से नहीं.
तो कहाँ पर आवाज़ होगा तो टेस्ट कैसे करें?
मैम ये आवाज़
बंद कर दे.
Evening, everyone. I would like to call upon stage all the participants, the top 10 participants on the stage, so that we can divide the groups. First name is Priyanka. Then second, Dr. Sunaina. Top 5, please stand here and rest on that side. Dr. Priyanka, Dr. Sunaina, Dr. Shubhmay, Dr. Say, and Dr. Niveda. Please come on this side. Dr. Niveda. Now the next group, Dr. Srilekha, Dr. Guru, Dr. Samir, Dr. Dipanka, and Dr. Suzanne on that side. If the participants are not able to answer, we'll pass the question directly to the audience. There is no pass among the participants.
Oh, okay. Yes, sir. Dr. Vimlesh, Dr. Bimlesh, please come on the stage. We need 5 mics also. 5 mics.
One mic. I will just will transfer one mic.
Hello. Hello.
Is Dr. Bimlesh? Okay, so we'll be dividing into 5 groups, and the group names are based on medicines. First, A group is amitriptyline. So I'll be, and second group is baclofen. Third is carbamazepine. Fourth group is duloxetine, and fifth group is etoricoxib. So top 5 person can come here one by one and tell whichever partner they want to take and which group they want to be in. So I'll call Dr. Priyanka.
I like to choose Dr. Niveda, and I want to choose carbamazepine.
No, you have to choose from the other team. From the opposite.
I got that right, so I can choose anything.
You have to choose from the 6 to 10.
Okay, I like to choose Dr. Srilekha, ma'am.
Okay.
And I
So-
like to choose the group carbamazepine.
Okay, sure. Give a big round of applause. Team carbamazepine, Dr. Priyanka, Dr. Srilekha. You can go to your seats. Now, Dr. Sunaina, it's a tough decision for you to make.
I could like to choose Samir sir for the
Okay.
team duloxetine.
Okay, sure, ma'am. Team duloxetine, Dr. Sunaina, Dr. Sameer. Dr. Shubhmay.
Dr. Bimlesh,
Okay. Team etoricoxib, Dr. Shubhmay, Dr. Bimlesh. Now I'll ask Dr. Sai.
Yeah, I'd like to choose baclofen and ma'am
Suzanne. Okay. Okay. Dr. Suzanne and Dr. Say in the group baclofen, and Dr. Niveda and Dr. Dipanka in group A, amitriptyline. कनेक्ट कर दीजिए, डिस्प्ले ऑन कर दीजिए. Good evening, everyone, and welcome to the most entertaining medical quiz of the year, ICRA Pain Brain Tournament with a twist. And the twist you'll be grooving now. Tonight, pain is not just a symptom, it's a sensation, a performance, and a party. So brace yourself for the 3 thrilling rounds that blend neurology with Bollywood, physiology with flair, and of course, pain with pleasure.
कर गई कैसी जादू गरी नींद
क्या आपके दिलों में भी बेचैनियां बढ़ी? Okay, so let's welcome today's host for the evening, Dr. Pushpak Regmi sir, Dr. Rupali Gorgile ma'am, and myself, Dr. Mamta June. I would like to welcome our judges for this event, Dr. Shiri Shamatya sir and Dr. Swati ma'am. You'll have to join on this table. And for scoring, I would like to invite Dr. Hari Podal sir and Dr. Pavan sir on the stage. Give a round of applause. Judges will be sitting on first table. Okay. So let's meet our brilliant team members who will be dancing on the nerve endings of knowledge today. And the name of our quiz is Daradia Disco Quiz. So team A, you can just introduce yourself and where you are practicing currently.
Hello, I'm Dr. Niveda. I'm currently a fellow in Daradia.
Okay. Please give a round of applause.
Hello everyone, I am Dr. Dipanko Debnath. I am currently practicing as an associate professor in Tripura Medical College.
Team Baclofen.
I'm Dr. Sai and I'm practicing in Fortis Escorts Hospital as consultant pain and palliative care.
Good evening, everyone. I'm Dr. Susan. I'm in-house fellow at Daradia. It's just been 3 months here. I'm a very new person into pain medicine.
Team Carbamazepine.
I'm Dr. Priyanka. I'm currently working as senior registrar in Gleneagles Health City, Chennai.
I'm Dr. Srilekha Rajendran. I'm attached to Mohan Kumar Mangalam Medical College, Salem, Tamil Nadu.
Team Duloxetine.
So, myself, Dr. Somir Boshak, from consultant pain physician and FNB pain medicine faculty, Central Hospital, Southeastern Railway, and practicing for last 10 years.
Myself, Dr. Surana, I'm practicing as a consultant in Plexus Pain and Spine Center, Bhubaneswar.
Team Etoricoxib.
Myself, Dr. Bimlesa, and I'm practicing pain in Bir Hospital, Nepal.
Myself, Dr. Shubhame. I am practicing as a consultant in Plexus Pain and Spine Center, Bhubaneswar.
So, all the participants have to submit their phones. You please make it on a silent or vibration mode and please submit. It will be collected on this table. So you have to give it, hand over to them. So do you have 10 phones here? Just check once.
Yeah,
mine is not there. It's already in the bag. Okay. So let's begin with round one. Please give a round of applause. We'll start with the round one. Let's begin with the first round, hangman. This round will test your knowledge and your ability to identify chronic pain conditions under pressure. Each team gets a word related to chronic pain and we play the hangman style. Guess one letter at a time. If you guess 7 wrong before the timer ends, then your group will be digitally hanged in front of this audience today. So be ready to be digitally hanged, but don't panic. We'll be providing you with some clues before your timer starts. Okay? So here are the rules for the round 1. The time limit is 1 minute. Correct answers will give you 20 points, and wrong answers or time limit crossed, there is no negative marking and you'll not be getting any score. Okay? First we'll give a demo for this. I would like to invite Dr. Pushpak for the demo session. So I'll be counting till 5 after showing few photos. 1, 2, 3, 4, 5. And now we begin with the timer. So your time starts now.
Okay. Do you have A in this group? A?
Yeah.
Okay. C?
No. So your head is made?
Do you have D? D?
No.
Do you have T?
Yes.
S? S?
Yes.
Do you have P?
No.
L?
No.
C?
No. Dr. Pushpak, you are about to be hanged.
Do you have?
Oh, sorry. C is there. My mistake.
Do you have K? K? No.
No. So one leg.
Do you have N?
Yes.
So is it F?
Yeah. So it's the word fantastic. Okay. One I was missing here. So you just got some time before being hanged digitally.
Yeah, thank you.
So the round will be played like this. You have to see the image. I'll be counting till 5 and we'll move on to the next slide. So you have to give random alphabets. If it is available in the slide, I'll be putting those. And your time limit will be 2 minutes for this. 1 minute, sorry. So let's begin with team amitriptyline. 1, 2, 3, 4, 5.
Is there an N?
Yeah, all are chronic pain conditions.
Is there an N? N?
Yeah.
Yes. Yes.
Is there an E?
Yes. Time is ticking.
34 seconds.
R?
Yes.
V? V?
No. No prompting from the audience.
U?
Yes.
O?
No.
Only 13 seconds.
I-T-I-S. I? Neuritis?
Yes. 20 points to team A. So you have saved yourself from being hanged here.
Just 5 seconds before.
So we'll shift to group B. Are you ready?
Yeah.
1, 2, 3, 4, 5. And your timer starts now.
Is there S?
No.
C?
Yes.
O?
Yes.
Y? Coccydynia.
Yes. Very good. Team Baclofen. 20 points to Team Baclofen. So we'll move on to group carbamazepine. 1, 2, 3, 4, 5. letters.
C. C.
No.
N.
No.
A.
Yes.
E.
No. One more handmade.
B.
No. 20 seconds left.
I.
Yes. So you are digitally hanged. But this question passes to audience. Can anyone guess in the audience? I'll show the picture again. 1, 2, 3, 4, 5. So the correct answer is polyarthritis. Carbamazepine, good try. But there is no negative marking, so you'll catch up in the next rounds. So we'll start with team D, duloxetine. So here is a clue. 1, 2, 3, 4, 5.
A is A.
Yes.
L. D. N.
What did you say?
A L D N.
A?
N D L.
N.
N is there. D. L. I. L. I am spelling so many things. I.
One letter at a time, sir, not many letters at a time. Yes.
L. A. D. Y.
D also done.
Y.
Y.
Allodynia. Okay.
No.
Okay.
You can say the word. Image. Focus on the image. So your time is up. Anyone from the audience, can you guess? I'll show the picture again. 1, 2, 3, 4, 5. Any guesses? So the correct answer is tendinopathy. 10 dinosaurs and a path.
Oh, tendinopathy.
It's tendinopathy.
Okay. We started there is the crocodiles, maybe some alligators.
Is the fear of being hanged. So let me show you the photo. 1, 2, 3, 4, 5.
Y.
Is not there.
No.
A.
Yes.
I.
Yes.
N.
No.
M.
O.
Oh, that all is mistake. So we are so confused. I think.
This game is so confusing, even we are confused.
P.
P. No.
T.
Yes.
So I'm confused. O, I.
Itis, itis, S. Synovitis.
No. Time is up.
We know the answer.
Okay. So team E, no marks. So the correct answer is sacroilitis. Sac, crow, and mirchi for ilitis, inflammation. Good try by all the teams. Give a big round of applause, and we'll move on to the scoring for this round. So who's leading? Any guesses? Okay, so the final scores for this round is amitriptyline with 20 points, baclofen, give a round of applause. Team B, baclofen 20 points, Team C 0, duloxetine 0, and etoricoxib 0. So we'll move on to the round 2, and I would like to welcome Dr. Rupali ma'am to take over this room. Yeah.
Hope you all have enjoyed the first round where you have used your visual perception skill. Second round is more interesting than this and enjoyable. Now I welcome you all in the second round where you have to sense the pain in a dramatic way, means medical dumb sheraj, or you can say medical action sheraj. Here the only thing more confusing than the chronic pain is your teammates acting. In routine Damsheraj, we enact to identify the movie name, like Hum Aapke Hai Kaun. So, but here is a little twist. You have to enact to identify the test performed or sign seen in the various pain conditions by your body languages, bizarre gestures, and staring looks. In this round, each team will send one member forward to act out, and there are some few rules. No words, no whispers, and no writing is allowed. No pointing to the body parts related to the test or sign is allowed till 1 minute. Keep it creative, not clinical. Otherwise, you will get disqualified. You have got 2 minutes, means almost 120 seconds, to act and to guess the word. If you give right answer, you will get 20 points, and don't worry. Here is also there is no negative marking. Wait, don't get stressed by these rules. Here are some legal hints that can help you to win. Hint number 1, you can show the thumbs up gesture if it is a test, and you can show thumbs down gesture if it is a sign. Hint number 2, if it is a 2-letter words, you can show with the fingers, 2 fingers. Sorry, 2 words, then 2 fingers. If 3 words, then 3 fingers. And even if you want to say how many letters in each word, you can point out like that. If it is a first word, say 5 like this. Okay?
Point like this. Point like this. Okay?
So here we are going to show you one demo with the help of Dr. Pushpak. So
take one chit. So we'll allow you 10 seconds for looking at the chit, and then we'll start the timer.
Once you take the chip, I will count the pain. 1,
Yes.
2, 3, 4, 5, 6, 7, 8, 9, 10.
Show everybody. You stand there, no? So that all of them can see it. Okay. So look
So
at the demo.
your timer is start.
Test. Okay. Test. 2 words. Okay. Upward is a test.
Upward test, downward sign.
Running R? No. First word. Okay. First word. 5 letters. Okay. First letter. Okay. Sky. Dhoop. Sun. Okay. S. Okay. First letter is S.
No guessing from the audience.
Oh, it's fitness. Okay. So like this.
No prompting from the audience, please. You'll get the chance after the team's time is over.
So please don't prompt. So we start. So let's have a fun. We start with the team amitriptyline. One of you, please come here to pick up the chip. One, two, three, 4, 5, 6, 7, 8, 9, 10. Your time starts now.
It's a sign. Okay. How many words? One word. Okay. How many letters in the word? Four. Okay. Only 4. Break. Broken. Smashed. Crack.
Yeah, you got the right answer.
उसको बोलना था ना लेकिन she has to come.
Crack sign.
Right answer.
Right answer. Plus 20 points. It's a crack sign.
Can you tell where it is used? Where we use this? Where we get this sign? Team amitriptyline. Where we get this sign? Crack sign. Yeah, it's seen in the Achilles tendinitis. Very good. Now I request one team member from the baclofen group. Please come forward. One, two, three, 4. You need time. No, na? Okay, then start. Susan, come on. It's a very simple. You
can't prompt the letters.
After 1 minute, you can show the body part, but till that, don't show anything. Some do acting. You are poor in acting, I think. She is not able to understand.
How many letters? 4 letters. First letter. This is disqualification. You have made the sign.
But no, it's okay. It's not difficult.
Second.
1 minute. 1 minute is over. You can show. Give some another hint also.
Mine. Second and third.
Hey, say ek later. Do some acting, Susan.
S. B. I. Fair.
It's a fair test. Where can we use this test? For what condition? Team baclofen, can you tell the significance of fair test? Use of the fair test? Yeah.
There are two significance. There are two significance. One is in piriformis syndrome, Feder is positive, and second is it's a part of ROM of the hip. So.
Okay, good. Now coming to the third group, carbamazepine. Please come, someone. Your time starts now.
Sign. 2 words. First word.
You can't point out that body parts till 1 minute. Okay? Otherwise you will get disqualified.
Twist. Twitch. Twitch.
Do some acting, ma'am.
Second. First word. 3 letter. Flow. F. Twitch.
Rupali. Come here.
Jump sign.
You are the quiz master.
Can you try other something? It starts with which letter?
1 minute is over.
Light.
You can use the body part.
Now you can use the body
Light.
part.
Probe. Superior celiac plexus.
What
Superior hypogastric.
Almost 20 seconds. 20 seconds left.
What's that?
Seagull sign.
Wow.
Yeah, it's a seagull sign. Very good. Now coming to the
Actually, team B used 2 alphabets by showing the gestures, so they'll not be getting any marks for this round. So she can't draw this, no? We have already told you can't draw.
almost F. Okay. Seagull sign is seen in ultrasound of during ultrasound of abdomen during celiac plexus block. So now coming to the 4th group, that is duloxetine. Your time starts now.
Symptom or sign?
Test or sign?
Test or sign? Test. 2 words. 3 words. Okay. First word?
Do some acting. Make it creative. Don't just start finding.
Easy test or difficult test to do? Are we doing every day? The second word? First word? Dance? First word.
Don't utter any word.
First word. Okay. Related to which body? Okay, first word, how many letters are there?
Iconic step.
First word, how many letters? 8 letters. First word, 8 letters. Okay. First word. Okay, go for the second word then. Go for the second word.
1 minute is over, so you can show
Your
body
body part.
also.
Which body part?
You
The
can
test
use
is for
your
which
legal
body
hint.
part? For the shoulder? For the back? Shoulder. Shoulder.
Yeah.
Rotator cuff.
You only point the body part.
Rotator cuff impingement. Supraspinatus. For supraspinatus?
Do some acting, sir. You show the body part. Now it's over.
For supraspinatus. Test for supraspinatus. Infraspinatus.
Yeah, it's infraspinatus.
For infraspinatus.
No, no.
Okay. Back. Back. Trapezius test.
10 seconds left.
11 seconds left.
9, 8, 7, 6, 5,
Shoulder.
4, 3, 2,
From
1,
it.
0.
Please, sir, say by yourself. What's that? What's the word, sir?
Winging of scapula.
Sir, you have to show the wings. You have to show the wings. You were just doing this. This is Bhangra. Good try, good try. Good try. Good try.
Wonderful.
Now please come one member from the etoricoxic group.
This was good. We tried.
Your time starts now.
Sign.
Don't. You are at. Don't open mouth. Please close your mouth.
Eyes. 3 word. Second. E.
Do some acting, sir. Then only he'll be able to recognize.
First,
You have
second
to
word, first
act.
letter is E. First, okay. First. Okay. F.
Sir, do some acting.
This is the
Format
easiest
sign.
one.
Don't utter any word.
Frog eyes. Frog eyes. Sign. Test.
Yeah.
You're correct.
It's frog eye sign.
That frog was really good. Very good.
Can you tell where we get this frog eye sign?
While scanning the sacrum for the caudal epidural.
Yeah.
And
So this wraps up our most theoretical round. Let's give a big round of applause to our drama kings and drama queens. So scores at the end of the second round are?
ऐसी ही घबराहट कुछ लोगों के चेहरे पर दिख रही है अभी. We'll give you the total score of both the rounds. First this round and then total score of both the rounds. So in this round, group amitriptyline got 20 points. Group baclofen got 0 points. Group carbamazepine got 20 points. Group duloxetine got 0 points. And group etoricoxib got 20 points. So we'll total the round 1 and round 2 scores. So what do you think? Who is in leading? Okay, so amitriptyline group has got 40 marks. Give a round of applause, guys. Group baclofen, 20 points. Please give. Group carbamazepine, 20 points. Group D, no score? 0. And group etoricoxib, 20 points.
But don't worry, in third round, you have so many questions you can score because it's a buzzer round. And negative marking is also there. So while
I'll be telling you.
Yeah.
Yes. अभी तक सब पॉजिटिव और जीरो ही था ना?
So it's a round where you can score more and go ahead.
Yes, sir. So let's begin with the third round. Pain is a multisensory experience, and so is this round. You'll watch an entertaining clip and answer the questions based on it. This is a flag lifting round. Lift your flag after the narration of the question ends, but with a caution, as there are 2 parts of each question. And if you lift the flag and you don't answer both the question, negative marking will be given, and there will be no pass among the groups. The question will go directly to the audience. So if you are confident to answer both the questions, limit is 30 seconds. Limit crossed, minus 10 marks. If you have raised the flag and you are not answering both the question. So lift your flag with confidence only. So let's start with round 3. Give a round of applause for the participants. Let's cheer them up, guys. Here's Grandpa, clearly not in the mood. He has got an advanced case of knee pain instead of surgery, which he was advised ages ago. He is now choosing to blame his grandchildren for everything, including his knee pain. So, guess the stage of the condition. Which variant of radiofrequency ablation may offer larger lesion size and less collateral damage in GNRFA?
Stage 4, osteoarthritis, and cooled RFA.
Yeah, correct answer. Team carbamazepine plus 20 points. Now we'll move on to question number 2.
A charming boyfriend arrived at the seashore early in the morning to meet his girlfriend, and beautiful girlfriend was waiting for him, started describing the tragic tale of her feet in a melodious voice. So, guess the condition. What post procedure? Okay, before reading the question, answer is ready.
So you have to answer this.
Yeah, duloxetine group. Yeah.
And your timer is starting now.
If you raise up the, you have to answer immediately. You
have to listen also to the options.
Okay, it's right.
Right answer. Team duloxetine plus 20.
Again plus 20, so team duloxetine is now coming with the amitriptyline group. Both teams having the same marks. Now coming to the next.
Move on to the third question. Check out this middle-aged gentleman. Still got the charm, still got the dance moves. Well, almost. He walks into the party all set to impress. But oh, his arms aren't going the way they used to be. The sweets may be sweet, but something not quite right. Guess the condition? Which phase of this condition is characterized by the greatest pain and least mobility?
Please, your timer is started. Timer is started, ma'am.
You have to answer within 30 seconds.
If you raise the
Frozen phase.
Wrong answer.
negative marking.
And question directly passes to the audience.
Guess the condition. First, give the answer of the guess.
You'll be getting a goodie bag, whoever answer in the audience. Yes.
Yeah, please.
Yes.
And answer?
Yeah, your answer is correct. Ritudeep, please hand over the goodie bag.
Your name, sir? Please come forward.
Give some sweet.
I would like to welcome Dr. Shri sir to hand over the goodie bag. Give a round of applause, guys. Here. Everyone is tensed after seeing the video.
In this video, a poor boy visits the doctor to report his buttock pain. But the pain is so severe that he can't utter a single word.
Without narration.
Guess the component, symptom of the neuropathic pain shown in this video. This component is used as a descriptor in the following pain assessment tool except DN4.
Who raised the flag first?
C.
Team
Timer.
C.
Timer start. Team.
No video. After the narration.
Team C. Timer started. Carbamazepine.
Pain detect tool.
First, guess the component of the neuropathic pain shown in this video. What is that answer?
Sciatic pain.
No, it's wrong. It's a component or symptom, na?
Okay.
It's wrong.
Question directly passes now to audience. Wrong answer.
Again,
Among the audience, can anyone guess the component or symptom of this neuropathic pain? Yes, yes, sir.
burning.
Yes, you are correct. And what's the right answer? Second?
No, it's wrong. Anyone else? Except, it's a except, sir. It's a B, brief pain inventory. Except.
Except word is there.
But answer is given by two different people, so no one is getting the.
Please listen to the question, the narration. Don't be in a hurry. This round is having negative marks also. Let us explain you and then you can raise the flag.
After question is, and when the question is displayed, then only you please raise the flag. Otherwise, you get negative marking.
Unnecessary, you are getting negative marks. Okay?
Video is stopped and the question is on the display, you can raise. You don't have to listen to the entire thing, but it has to be displayed. Okay?
At least question to be displayed.
Before the question, somebody has, if you raise the flag, then we'll count the one after this is shown. Okay, so that is.
The question's intensity will keep on increasing as the questions are going on. So stay calm, stay cautious, and then raise your flag. Okay, we'll move on to the next question. A celebrity doctor makes a dramatic entry to check the heroine's back pain after a trivial fall. But wait, he's not just any doctor. He pulls off a textbook special test with the flair. Can you name the test a star doctor just performed? And this test is useful for diagnosing which of the following condition?
Team A. Team A.
Yes, you are correct. Team A, plus 20 points. So we'll move to the next question.
A cute boyfriend was trying to impress his girlfriend with some wild stunts, but gravity had other plans and he ended up kissing the ground instead. Guess the condition and the name the intervention block used in the refractory pain of this condition. Precise location of the target site is explained by the following Except.
Team C.
Team D.
D. D,
Start.
you have to answer. We'll start the timer.
So the condition is the coccydynia,
Hmm.
and the location of the target is located retroperitoneally near to
Name the
the
intervention block also.
near the anacoccygeal ligament. That is a
No. First answer is name
okay, that is the ganglion impar.
Yeah.
Ganglion impar.
And
And the C is located retroperitoneally near the anacoccygeal ligament.
no, it's wrong.
Question passes to the audience.
It's a except. It's except again.
It is except.
Except it's not.
It is except.
Yes, sir.
D. Yeah, it's a D answer.
He's getting all the goodie bags today. Ritudi, please come.
No. If you don't answer, you
You have to answer both the questions. So that's why you have to think properly and then raise the flag. Otherwise, you go in the negative marking. So don't get hurry. Otherwise, you go in negative.
Please, Moinadi, hand over the
Baclofen group is
goodie
not
bag.
giving any answer. Please come up.
Sir. Give a round of applause to sir. He is answering all the audience questions. So let's move on to the next question. Meet our dazzling dancer, but tonight she is not just grooving, she is sometimes grimacing. Severe neck pain and some strange symptoms in her arm have brought her to the party, only to find the doctor in the crowd. What's going on here? Guess the condition? Before performing a cervical transfemoral epidural steroid injection, with serious complication must be considered. Phrenic nerve palsy, spinal cord infarction, Horner syndrome, and seizures. The time starts now. Now nobody is raising the flag. They're cautiously reading the options.
Timer is started. Yeah.
10 seconds left. 4, 3, 2, 1. Question passes to the answer. Audience, wrong answer. Wrong answer.
Okay.
Sir, negative 10 marks.
Yes, negative 10. Okay.
Question passes to the audience.
Backward, back. Please.
Yes, sir.
Yeah.
Yeah, it's correct. Please come forward, Charu ma'am.
Serious complication must be considered. This is the most serious complication.
Serious, sir?
Serious complication.
Maswati bhai ma'am का नाम लो वो भी है।
Read the question. Spinal cord infarction.
Now coming to the next question, please see the video.
You know the story, no?
A tall, handsome man had been searching for his missing girlfriend, since 2 days. Because of that, he had neither eaten nor slept, and he was wandering under the scorching sun. Eventually, he found himself in a noisy environment where he began to suffer from a severe headache. Guess the type of headache. What is the proposed mechanism of Botox in the prevention of this type of headache?
Team C raised the flag.
The flag was read by Team D.
D. Okay. Team D, your time starts now.
After this question is displayed,
Yeah.
usually we count.
Yeah, that's it.
If you're raising beforehand, we don't count.
No, it's all.
They have already raised.
They have already raised.
Guess the type of headache.
Yeah, please say.
Yeah.
Next answer.
10 seconds only.
Wrong answer.
Wrong answer. Please think. That ma'am.
Yeah, you are correct.
Botox basically acts by preventing Release of CGRP and substance P and glutamate.
I would like to welcome Dr. Swati Bhatt ma'am to hand over the goodie bag. Ma'am, please come forward. Give a round of applause, guys.
So please think twicely before raising the flag. After thorough narration and display of the question, then only you please raise the flag. Otherwise, you are going in negative.
So we'll start with the next question.
You are in positive, but you please answer something.
लेकिन अम्मा कुछ तो लग रहा होगा, पेट खराब लग रहा है, दर्द है, बुखार है, अंदर वाला बुखार है, हरारत है, बस वो नर्स मन अच्छा ऊपर देखिए। गैस हो सकता है, ठीक है।
Granny is having Granny is having a tough week. Body aches, vague tummy troubles, and now a house call from a very patient doctor. She's charming as always, but can you piece together what's really going on? What's the condition? And as per 2016 criteria of this condition include following except. Who raised the flag first?
A.
Okay, I'll start the timer.
Answer. Raise the chronic condition.
And you have to give both the correct answers to score.
11 seconds, 10 seconds, 9.
Wrong answer. Question passes to the audience. Sir, raise the hand first. Okay. I would like to invite Dr. Swati ma'am to hand over the goodie bag to Dr. Deepak sir. ये राउंड बहुत ही मजेदार था, सब टेंशन में आ गए. Enjoy the video और फिर उसके बाद टेंशन लो.
Now coming to the next question.
This is the last question जहाँ पे 20 plus points है, उसके बाद से 40 plus points and minus 10 start हो जाएगा. So raise your flag with caution again.
Despite visiting the dentist multiple times and losing several teeth from one side of the mouth, in that process, the middle-aged man's right cheek pain stubbornly refused to go away. Guess the condition. All of the following drugs are used in the treatment of above condition except C. Carbamazepine group.
The condition is trigeminal neuralgia.
Answer.
Except duloxetine.
Yeah, it's correct. Very good. You got 20 points. From hence, the round after for each question, you are going to score 40 points. But negative marking is same, 20.
Minus 10 negative.
Increasing is doubling.
Increasing double?
Yeah.
So what's your say? Double? So positive, there has been some change. Positive plus 40, negative minus 20. So raise your flag with question. This is my tagline for this round. This young anesthesiologist has hung up the OT blues and is dreaming of a new path, one with nerve blocks, back pain, and maybe fewer night shifts. This is his first day in the pain clinic and he is astonished, at the same time confused while looking at the symptoms of this patient. Guess the condition? Which electrophysiological finding is most specific for this condition? Reduced CMAP amplitude, absent H reflex in tibial nerve, fibrillation potentials in paraspinal muscles, slowed conduction velocity. And the timer starts now. Group C?
It's lumbar radiculopathy. Yeah. And slowed conduction velocity.
Wrong answer. Question passes to audience.
20 negative. Okay. Please say something. Huh?
Wrong answer. Anyone else? Yes, sir.
Give us.
Yes, C is the correct answer. So please come forward. Dr. Swati ma'am, please hand over goodie bag to sir. Moinadi, please.
One bag.
Minus 20.
Yeah, minus 20. No second. See, that's the point. Otherwise,
They're not listening to the questions.
Beglu fan stock has finished.
Now coming to the second question, 12th question. This video shows a typical Salzburg argument, but here it took an unexpected turn, ending in a serious accident. Guess the type of headache which can happen after this type of accident. After this incident, the heroine started having headaches for which she underwent diagnostic C2, C3 medial branch block. But you have to read the full question.
Your timer is started.
Yeah. Yeah, it's correct. Very good.
Plus 40 points to group duloxetine.
Duloxetine get the 40 points.
Now the last and final question for this round. And duloxetine has started acting, sir. Yes.
मैं तो एक्साइटमेंट में आकर अरे एक्साइटमेंट मतलब क्या कहाँ बैठा हूँ किससे बात कर रहा हूँ क्या बात कर रहा हूँ समझ में नहीं कंट्रोल कंट्रोल उदय ए वल्लू बता इसे बता मुझे गुस्सा आता है तो क्या हो जाएगा
मेरी एक टांग नकली है मैं हॉकी का बहुत बड़ा खिलाड़ी था एक दिन उदय भाई को मेरी किसी बात पर गुस्सा आ गया तो मेरी हॉकी स्टिक से मेरी टांग के 4 टुकड़े कर दिए लेकिन दिल के बहुत अच्छे हैं फौरन हॉस्पिटल लेके गए ऑपरेशन करवाया नई टांग लगवा दी ये स्टिक दी थोड़ा खर्चा दिया और बस
Although you can see Uday Bhai is so generous and helped Ballu Pratap in acquiring lower limb prosthesis, still Ballu Pratap feels pain in his missing limb. Uday Bhai decided to send him to a pain physician. Guess the type of pain? Mirror therapy was originally developed by which neuroscientists for treating this type of pain? C. Group C? Group C?
It's phantom limb pain. V.S. Ramchandran.
Yeah.
Yes, you are correct. Group carbamazepine plus 40 points. Now we will be calculating the total scores.
And just like that, we have reached the end of our pain brain tournament, that's the disco quiz, where pain is a party and knowledge is the DJ. What a journey it's been, from trigeminal tantrums to epidural scabbers, and of course, the whole lot of Dom Serras drama. But remember friends, the real winners here are the neurons firing in your brains and the knowledge you'll take home tonight to spread like the true pain physician you are. Thank you.
जेरी की तरह धुक धुक किस किस को हो रही है? Among the participants,
She wanted me to do like this. I can't. Okay.
Whoever is winning, you three are the winners.
Thank you, sir.
ये फाइन ऑयल ना just prepare for them.
Yeah, correct. And welcome.
yeah, now take your phone. Yeah, you can take your phones now. Sir, let's welcome Dr. Gautam Das sir, Dr. Sunita Lavangi ma'am, our judges for today's quiz, Dr. Shirish Amatya sir, Dr. Swati Bhatt ma'am, Dr. Hari Podal sir, for announcing the winners.
As I told you, that whatever is the score, the real winners are these three. They really made a fantastic, the quiz, and we can see. So this kind of banquet is also possible where there is no drinks, no dance, and still everybody is enjoying. Okay, so third prize. Third are not one, two. So any guess?
Any guess?
So third prize goes to Team Baclofen. Another winner is there. And Team E, Heterocoxib. B and E. Second prize,
You all have to come on the stage.
please come. So second again, two winner. One is Team Amitriptyline. But again, rest two teams come on the stage. So one of you are second, one of you are top. Any guess? Who is second and who is top?
Guess who is the second and who is the...
Any guess from the audience?
Yeah, they will get a woody bag again.
So first prize goes to Team Duloxetine.
One bonus question can make so much of change.
Okay, so all are winners. All are winners. Okay. And the prize and not only the prizes, certificates will be awarded to tomorrow's valedictory function.
So give a big round of applause to all participants. Everyone played very well.
Okay, but there is some announcement. So they have mentioned me, reminded me that they will not be getting any prizes, any certificates unless you dance.
And we'll play the song also for you.
We are getting 60 marks.
This dance is your credit card for the CME points. For audience also, if you want more credit points, you have to just stand and groove on the beats. I request all the audience also to stand. Please.
As soon as you start the song, they will dance automatically.
Loud sound, loud.